Merrill Aortic Valve Symposium by two stalwarts in the field. The first session by Dr. Bijilal, TAVI, how I do it. Second session will be TAVI in complex subsets. We would like to invite the chairpersons, Dr. Mahesh, Dr. Rajiv, and Dr. Shafiq to the stage. Please, sir.
Very good morning to everyone. So we are now moving to a very important session in structural interventions. So we have now two exciting topics by experts in the field. The first talk would be Basics How to Do a TAVI by Dr. Biju. Over to you, Dr. Biju.
Good morning, and thanks to the organizers for giving me this opportunity. My topic is about how to do TAVI. So coming to the current status of TAVI in Kerala, the first case was done in 2016, I believe. And right now, more than 30 centers are doing TAVI in Kerala. I think according to one data, it was 34. And greater than 120 cases happens each year. That's around 10 cases per month happens in Kerala. The technique has evolved over time with better valves, better hardware. And so it is high time for achieving optimal TAVI outcome. It's just like coronary. If you just put a stent and come out, the long-term results may not be good. However, if you do imaging and calcium cracking and all those things, the results will be better. So we must aim for. We have now around more than 8 years experience with TAVI in Kerala. So it's high time we aim for achieving optimal TAVI outcome. So what is optimal TAVI outcome? None of these complications, this VARC3 guidelines, three endpoints, none of these complications should be there. And the mean gradient by echo should be less than 10, and peak-to-peak gradient by CAT should be less than 10 with a trace or mild PVL. And we must aim for commissional alignment in all patients, and we must aim for high implant in all patients. So this is very important, setting up a hard team. It's a team game. And meticulous planning is the prerequisite for a successful outcome. We must plan everything from access to implantation, identification of all possible complications which can happen in each a particular case, and we must have measures to limit them or mitigate them and hardware to tackle them. And the procedure success with TAVI is very high, as you know. So the pre-TAVI planning is all about this most important investigation is CT. It gives you everything, all information required will be given by CT. And just for to summarize, for self-expanding valve, the perimeter, the oversize by 13 to 30%, whereas for a balloon expanded valve, the oversizing should be by 5 to 10%. So we can divide TAVI procedure into two halves. One is obtaining a vascular access, second is a procedure. So when you have multiple operators or two operators in a team, it is good practice so that one person takes the vascular access in one case and the second person does the procedure. And for the next case changes. So both will be well versed in both. So essentially we divide it into two halves. One is the vascular access, second is the procedure. So vascular access is also very, very important. You must assess everything by CT. The minimum diameter required is 5 millimeter for a balloon self-expanding valve, whereas it is slightly higher for a self-expanding valve. We need to assess the tortuosity, calcification, bifurcation, pre-existing dissection, everything. All these are available, it's possible with the CT. And coming to optimal vascular access, you must learn to do ultrasound-guided puncture. So in that case, if you are well-versed with ultrasound-guided puncture, you need just one radial access and one femoral access, that's enough. The left femoral need not be touched. So it's becoming minimalistic TAVI. And micropuncture set should be used when you use a vascular ultrasound-guided puncture. It improves the leverage. I will show you in show an angio. And all these vascular sheaths should be available. It is better if you use a long front sheath for the temporary, because you put the temporary from the left side, there will be some iliac tortuosity. You put a long sheath reaching up to the IVC, then that temporary will be more stable. This is more important for a balloon expanded valve. It's an optional. And of course, proglet sutures and stiff wire for placing the sheath should be available. When you do ultrasound-guided puncture, you do it in two axes. One is the short axis and long axis. Short axis for an anterior puncture and long axis for the site of puncture. And the inferior epigastric artery serves as the landmark. If you are not well versed with the ultrasound guided puncture, you can put the pigtail and aim for the center of the pigtail and take puncture. This is a ultrasound guided puncture and with a micropuncture sheath. It's just 4-front sheath. You can just make sure that where your entry point is. If your entry point you're not happy at this point, you can take another puncture and keep this sheath below. So that's importance of advantage of using a micropuncture sheath when you're using a ultrasound guided puncture. So points to remember are anterior puncture, very important. You must take anterior puncture only. There should not be a through and through puncture. If you have some doubt also, just take it out and do another puncture. And avoid area of anterior calcification. If the anterior calcification is too severe, you have two options. One is calling your surgeon. If you don't have any area to puncture, one is calling your surgeon and getting an access, or you must be prepared for a covered stent post procedure. And after puncture, it is very important to prepare the access site. Keep your 6-front sheath, keep the dilator of the 6-front sheath also there. It makes it stiff, make a good round, open all sides with this forceps. And before putting the ProGlide suture, remove the pigtail and apply the ProGlide sutures. If it is a small vessel, it may be better to put single ProGlide because when you put 2 ProGlides, there will be some stenosis, and if in a small vessel, it may not be acceptable. And while applying ProGlide, also 2 points should be remembered. One is that you must apply it at 45 degree. So then only at 45 degree only these foot plate aligns to the vessel wall. Suppose you apply the ProGlide at horizontal, maybe 30 degree, 25 degree, then this foot plate will not be aligned to the vessel wall, and your needle may not take the sutures. So that's one important reason for ProGlide failure. Must apply it at 45 degree or more. And the second thing is when you apply 2 ProGlides, the first ProGlide should not be loose like this. Sometimes you see that the knot is outside the skin. So you must pull on the blue and let the knot go inside the skin. Otherwise, if it is loose, when you put the second ProGlide, this system can catch on this loose knot, and when you pull it, the knot may get tightened. Then this ProGlide the first ProGlide may not work. You may not be able to push it inside. Then serially upsize and place a 14-front sheath for a self-expanding valve and the expandable sheath for the balloon expandable valve. Aortic angiography is not very important these days. We get all the idea from all the information required from the CT itself. And nowadays we do aortic angiography only to look for coronary occlusion. While doing balloon inflation, do an angio to look for coronary occlusion. Valve crossing is generally not very difficult. It is difficult in 2 situations. One is the bicuspid aortic valve with the right non-fusion and left non-fusion. These 2 situations, it may be difficult to cross the valve. Just have a look at, and prefer to use a Teflon wire rather than thermo wire, because thermo wire can sometimes go inside the coronaries. So Teflon wire is more under your control. And look at this valve crossing. You see that when the wire comes out, the catheter moves. So give an allowance for that. So in this patient, probably the orifice is here. When the wire comes, the catheter is directed there. Suppose the orifice is in the center, you must put the catheter somewhere there and give an allowance for that movement of the catheter produced by that wire. And placing the LV wire is the next step. And you just need to advance the AL catheter just inside the LV, put an exchange wire, put a pigtail. Sometimes the wire goes to a chode and the pigtail also goes to the chode. So what you do is you need to keep the pigtail inside pull the pigtail to the LVOT and pull the wire back so that the pigtail forms a loop at the LVOT. Then you can push with that loop and it goes to the apex without catching on the chode. And we have different stiff wires, Confida, Safari, Linderquist. Linderquist is the stiffest one and Safari is probably the softest one. And the pre-balloon dilatation, it is very important to have a low threshold for pre-balloon dilatation. Unless there is a significant AR, it is a non-calcified valve, always try to do a pre-dilatation. And it is a good practice to do twice rather than once. I'll show you one case. And if it is, this first dilatation cracks open the commissure. And the second dilatation, if you do with the same balloon, it will give little more of opening, and it may be better to better interacting the devices. In this patient, this is a bicuspid right non-fusion. It appeared reasonably open here with the first, this thing. And in this position also, it appeared open. But in another view, you see that it is actually not open. This could have been avoided if we did two balloon dilatations in two projections. So the first one in AP and second one in LAO. Then you can identify that this is not fully opened. If it was identified early, we could have done better pre-dilatation and implanted the valve. And this is also very important commercial element. Commercial element achieves a little better hemodynamics, long-term hemodynamics probably, lesser central air also, and it is very important in young patients for future coronary access. This is what the mirror recommendation. Check the angle between the horizontal and the center of the right sinus. And this is 3 o'clock position. If it is like this, it is 258 or something, and if it is like this. So based on this, they align the valve like that, load the valve like that. And what they claim is that it will align the commissures to the native commissures, new valve commissure to the native commissure. But they consider that this system takes a 180-degree turn at the arch level. Whether it is 180 degree or not is there may be slight variation. And this is what can be done for a self-expanding valve. This is known as the hat marker. It should be on the outer curvature. There is this commissure is this is a commissural tab which is actually 90-degree away from the hat marker. So if you put the hat marker against the coronary, then the commissure will be away from the coronary. This is very simple. You just need to keep the hat marker on the outer curvature while you're going up and also in the LAO view. So that is all we can do. This is very likely to save the LCA. But what happens to RCA is probably not very clear. Most likely to 80% success is what they claim. So advice the transcatheter HALC portal is the next thing is that it's through an expandable sheath. It is a little difficult to track. You need to considerably push. If you have a dry gauze with you and push little by little, whereas for a self-expanding it is easy to push. When it's difficulty in advancing, use a stiffer wire or additional pigtail catheter. This is a difficult to track case. You put a Lundquist wire inside the pigtail, then you could easily track it. And the valve positioning is keep it for the self-expanding valve. Keep it at this middle, this center of the second dark band is where you keep it. And the deployment is 2% job. You put the pigtail catheter at the NCC as the marker and avoid significant parallax, and it's a slow inflation. This video is 20 seconds, so that much time you can take, or 20 to 30 seconds you can take. It's a slow deployment. There is no need to do it in 5 seconds and all. You can take your time and push in the whole volume. Whereas for a self-expanding valve, it's a slow process. It is generally done these days in the RAO caudal view, where it's where we should give some allowance for this valve. It will dive in while deploying. So you start deploying at the mid pigtail level, and the valve slowly dives in during deployment. And once you are happy with the position, do a quick deployment to 120 beats per minute pacing. And you check with a very minimal contrast. This is just to check the NCC side depth. You just need 5 ml contrast. And to do it the other LAO view, give a little more of contrast, check the depth on the left side. And once you are happy, you can slowly deploy it after waiting for 5 minutes. That's because this is a self-expanding valve. It's at 37-degree body temperature, it expands fully. So give it some time to expand. It's loaded at 7 degrees. So at 37 degree, give it some time to expand. So wait for 5 minutes before deployment. Post-deployment, carefully remove the delivery system. There is nothing more to do with the delivery system of the self-expanding valve. Whereas for this balloon expanding valve, just pull it back and assess it, and you can use the same balloon for post-dilatation if AR or significant gradients AR is there. So, and then put the sheath back. And post-dilation is based on hemodynamics, echo, and AR. Have a low threshold in self-expanding valve because there is nothing we have done. It's just a self-expanding where there is no force exerted. So it's maybe a good idea to routinely post-dilate the self-expanding valve. There is some push on that. And vascular closure is done after exchanging a less stiff wire. Don't keep this safari wire there. Put a less stiff wire. Put the dilator back inside the sheath. The sheath tip may be flayed, especially this expandable sheath tip may be flayed. So when you just pull it back, it can tear the iliac vessel. So it's a good idea to put the dilator back and then only remove the sheath back. And check hemostasis by angio after applying the sutures. If acceptable, remove everything and further tighten the sutures. If it is not acceptable, we can put additional sutures or maybe put an angioseal or an obturar device. You must have all the hardware to tackle the complications: peripheral balloons, 8-inch Balkan sheath, covered stents, a lane balloon for possible aortic rupture tackling, snare, angioseal, embolic protection device, coronary stents, gate extension catheters. This is a coronary occlusion, this is a valve in valve, this is a snare assisted tracking. So all these things should be there. So managing complications is meticulous pre-procedure workup is the most important step. Anticipate complications, quick diagnosis. You do not get too much time. All hardware should be available in the lab, and it's a teamwork. So a few words about optimal TAVI. You must have an outer scar to reduce AR. Whenever possible, use a valve with outer scar to reduce AR. Cost is not an issue. Cerebral protection is better to use in all patients, provided cost is not an issue. And you must aim for high implant in all patients. Thank you very much.
Thank you, Bijlal, for that extensive coverage. As you said, most important thing is planning. Even minor steps are important. From the groin, maybe you can have a very successful case, but finally you might land the problem in the femoral artery. Or even after deploying the valve, while removing the valve, if you are not careful, there can be a major complications. So 90% of the success is in pre-planning and careful doing of things in the lab.
No, sir. It's costly.
Cell protection can be used in high-risk cases. In routine use is not recommended, but then if you use, you might get some particles. There are devices like Sentinel device where you can cover the right and both carotids. Or you can use separately spiders in both carotids in very high-risk cases. In one case where we had a LV clot, so we had put two spiders in both carotids. No, because we avoided going to the apex.
Another point is about optimizing TAVI result in long term is that we are moving towards younger patients now. We are doing more TAVI in between 65 and 70. So it's extremely important to address coronary. What happens to coronary if the patient requires a valve in future or a valve in valve in in 80s. So that is the point when we talk about higher implants. That's a point against the routine. Higher implant is the fashion now for the to reduce the pacer rates. But then we have to consider the choice of the valve, type of valve, as well as the height of implant, considering these access to coronaries when he requires second or third TAVI in future.
Good assessment of the perimembranous septum will give you a hint as to where you're going to land up with a pacemaker or not. That's also very important in planning. Thank you, Dr. Bijlal.
No, it depends upon the size of the valve being used. Now, in fact, the first case that we did in March 2016 was a valve in valve case. No gradient at all. The echo showed some gradient, but CAT gradient was 0. Post-dilated. No, post-dilatation. If there is residual AR more than mild, you have to dilate further.
No, he said
Sir, it
is against pre-dilatation.
Pre-dilatation now.
The next topic will be by Dr. Ashish Kumar, TAVI in complex subsets. He's the root cause of majority of all the TAVOs being done in Kerala. Any root cause, any center which starts a TAVI program, including mine, relied entirely on him. He was extremely helpful, always taught us more than guided us. So, guided and taught us to the extent that by the 5th or 6th case, all of us became independent. Now, we don't trouble him too much, but only for difficult cases. And all the difficult cases posted in CSI group, you will find in the photograph one corner, Dr. Ashish will be standing. Let's have all your complex cases, Ashish.
Thank you, Mahesh, for those wonderful words. So, good morning to all. By complex subsets, I presume it would be those with a difficult vascular access, a narrow left ventricular outflow tract, severe calcification, low coronary heights, those with renal insufficiency, and those deemed to be at high risk of stroke peri-procedure. Now, if you have a combination of extreme tortuosity, severe calcification, and small-sized access vessels, I think you should consider an alternate vascular access. If at least one of these three is missing, you could actually use the same vascular access. Several techniques: serial dilatation of the vessel with progressively larger dilators smeared with propofol because it dilates the vessel, and then you can take the sheath in. Now, the alternatives to this would be a simple balloon dilatation and supplemented by the deployment of a self-expanding bare metal stent, or E1. If there is a flow-limiting dissection or perforation, you could consider a self-expanding covered stent. And as Dr. Bijilal said, whenever you have a small-sized femoral, always use only one proglide, otherwise you end up with a stenosis. Now, this is one of those cases wherein, as you can see, there's calcification, not much tortuosity, small-sized vessels, especially the external iliacs. And you know that any vessel, of all the vessels in the body, external iliac is most prone to rupture. Now, this is the stretched out images. The iliac angiogram showing small sized on either side, about 4.3 on an average. So what you do, smear the dilator with propofol, adequate sedation, dilate with 14 and 18 French dilators, and then the sheath goes in. Now you close it with one proglide, and that is not bad in a small-sized access vessel. Now you could have an extremely hostile groin, as in this gentleman, in whom the abdomen is so large and pendulous that you need to actually pull it up, strap it to the table before you could even see the groin, let alone access the groin. In such situations, you need to be extra careful because the surgeon also could find it very difficult. So we use 3 proglides. And as Dr. Bijilal stressed, securing the vascular access is as important as deploying the valve. Now, occasionally you could have very bad access vessels, diffusely diseased iliacs. There is a critical stenosis, almost amount of occlusion of the infrarenal aorta, densely calcific arch and the arch vessels, which are all diffusely diseased, which precludes the use of any of these as an axis, wherein you could use the transapical approach. Under general anesthesia, the surgeon does it pretty easily, under TE guidance, and then it is a straightforward procedure. Narrow left ventricular outflow tract. I'll show you certain case examples. Herein, the LVOT is at least 1.5 millimeters smaller than the annulus. Severe calcification, and you could see a calcium nodule at about 4 o'clock and 11 o'clock positions. The LVOT is smaller. There is calcification involving the sinuses as well. Ascending aorta is gently free of calcium, a lot of calcification. And here, better not to significantly oversize the valve because you rely on the calcified leaflets to hold the valve in place. And a shallow implant, and this I was talking about an implant about 3 or 4 years ago when we were not routinely aiming at shallow implants. And for a 24.7 annulus, we are using a 24.5 balloon expandable valve, which is a slight undersizing, pre-dilatation because of calcification, aiming for a shallow implant, and a graded deployment. The first 30% is very slow. There is a tendency for some of these valves to dive in. You can pull it back a little, Check your position during deployment. And this is what you end up with, almost like a 90-10. Narrow LVOT, but still there is no gradient across. And I'm pretty obsessed with this view because it tells you the valve is adequately deployed. And the cylindrical shape is essential to get the best hemodynamics in any aortic valve. Again, narrow LVOT, but there was no conduction disturbance. Horizontal aorta. Severe calcification, bicuspid type 1A, again calcium nodules. Here, much more dense calcium nodule at 4 o'clock position. You could see how the aorta is. Dense calcification. Here again, a little flexion on the delivery system. So this allows you some leeway to actually make finer adjustments before you go for the final deployment. And this is how the valve looks like. It's very well positioned in a horizontal aorta. You might wonder whether there's some bit of an AR, and the echo shows you there is nothing. Low coronary height is a huge challenge. Younger patients, ideally, you should send them for surgery. Now, this was a very frail lady. Look at the coronary heights and look at the annulus. The surgeons had refused. This was done at another center. The LCA height is about 6.5 millimeters. Very little calcification. And small size femorals because it's a very small, frail lady. Here, because 6.5, you need to protect the coronaries. Now, we all talk about coronary protection, but if we end up deploying a stent, the long-term outcome of these stents, no one knows. So it is just a bailout. Here, protecting the left main with the stent and the guide extension catheter in situ. Again, deployment, you check an angiogram immediately from the guiding catheter and also an aortic angiogram just to be sure that we have not missed anything before you take out the system as a whole. This again, a low coronary height plus an anomalous circumflex which is taking off from the right coronary artery. The LCA height is still less than 10 millimeters. Bicuspid. Low coronary heights in a bicuspid anatomy, you should be extra careful. You should definitely push for a surgical valve replacement. Bicuspid calcified, type pseudobicuspid, and the left leaflet length was about 13, so that is why we decided to protect this as well. The RC had a critical stenosis, which was tackled, protecting the left coronary. A slow and controlled deployment, and here again, we need not use a stent. The coronaries are flowing well. And this is a proof that actually, the commissural alignment works. You can access the coronaries pretty easily. And now we do the CTs, at least some of these patients, to ensure that the valve is deployed exactly as we had intended to. Severe calcification. This was a case that Paul presented yesterday, and courtesy Paul and team from GH Kochi. Extreme calcification, large size annulus. No oversizing again. That is the key. It is actually 2% undersized as compared to what you would have done otherwise. I haven't done a valve which is more calcific than this. So again, the commissural alignment keeps it away from the coronaries. And it was so calcific that you had difficulty in actually even taking the pigtail catheter in. Balloon rupture, and which Paul highlighted yesterday. Retrieving the ruptured balloon. Now, taking the valve also was difficult In such situations, what you can do, this is despite stiff wire, you could use a buddy wire as used in the corners. Unfortunately, they did not have another Lundecker, so this is an Amplatz extra stiff. And then deployment. And I think what had happened was there was a small perf, and we attempted to plug this or coil this off, the wire being there, and reversal of heparin, almost near complete reversal of heparin resulted, and their prayers maybe, it closed off. Here again, and then here we had to deploy a stent because, we were, already the right was a little compressed, spasm as well as extrinsic compression. And there was no gradient, no AR as well. One of the other things that you could do when you have difficulty in getting the valve across is a balloon assisted. You could use a peripheral balloon for gliding the valve in, and that it works pretty well as well. Advanced renal failure, we know that AKI occurs in about 3 to up to 50% or more because these patients are elderly. And this is courtesy of Shiva Prasad sir and team from MCH Trivandrum, wherein we could do this with about less than 10 ml of contrast. We have catheters marking the left and the non-coronary sinus. Now, the other thing that you could do in these situations is a fusion imaging, wherein you have the CT superimposed on fluoroscopy. You have the live fluoroscopic images on the left and the fused image on the right. And this, the dots, the red dots mark the annular plane, the green and the blue mark the coronaries, and the red line marks the depth of implant. And the same thing you can see over here, you're getting the valve in, so you don't require contrast injection. You know the exact depth of implant based on the fusion imaging. So you don't, again, end up injecting contrast as well. And the last part of it is a high risk of stroke, wherein you end up using cerebral protection. Who all should require cerebral protection? Personally, I feel any person who has a history of stroke, even a minor stroke, including a TIA, requires cerebral protection. Otherwise, routinely, I don't use because the data also does not seem to favor routine cerebral protection. And this is what is we had to use, and this is just in one case. So I've used cerebral protection only in one. So in conclusion, I would say it is possible to offer TAVR to more complex subsets, provided you plan appropriately and modify your techniques based on the case. You have to be prepared to handle all the complications, and you should have all the necessary gadgets. And you should always keep your surgeon happy. He is a vital member of the team. He can be the only savior when you have a complication. Thank you.
Excellent collection of cases and well performed. Thank you, sir. And just one question about the fusion technology. How reliable is that in defining the lower sinus line, all 3 dots? Have you ever cross-checked with an angiogram?
Yes. But now, the only problem with the fusion is the patient, because these days we do it only under conscious sedation. The patient has to be deeply sedated or under anesthesia. Slight movement interferes with the accurate positioning. So now that we're doing more of conscious sedation or almost exclusively under conscious sedation, we are not using the fusion much. It's not that reliable.
There is some movement with the cardiac motion itself, no?
But that is still okay.
That's okay.
That is still okay.
Any role of peripheral IVL balloons?
Yes. Yes. Especially in tortuous calcific vessels, you could use an IVL instead of a straightforward balloon dilatation, provided you have a covered stent, a self-expanding covered stent in place as well.
I was referring to the valve itself.
For the valve, because to have that kind of, that big-sized IVL balloons, at least, that is a great thought. I was also wondering about it because one way you can actually make it more pliable, in which case you don't require a valve at all.
It may cause embolization. If it,
Calcium,
calcium
probably,
embolization.
yes.
In the case where you had a rupture of the balloon, did you dilate once again?
Yes, multiple times before you could, and then only we tried a buddy wire, and then a balloon assisted.
So what were the balloons that used later? Which
For the to get the
particular-
valve in.
yeah.
So because I think first time we used an 18 millimeter because it is we are taking 21.5 valve or something, and then we used a 20
different
more
com-
aggressive dilatation, not the balloon.
different company balloon or
No, the same
it's
company
the same?
balloon. The same company balloon.
Okay, thank you, Ashish, for
Thank
that
you.
excellent presentation. That's the end of this session. Thank you.
Thank you, speakers and chairpersons. That was very knowledge enriching session. Next, we have session on imaging. I call upon Dr. Jabir Abdul Kutti, Dr. Krishna Kumar VV, Dr. Mahesh and Dr. Raghuram Krishnan to please chair the session.
So we'll go on to the second session. We have 5 cases based on imaging. They will be scored and 2 prizes will be given, one by lucky draw and one by the chairpersons. The first will be by Dr. Binu A, the vanishing stent.
Good morning, everybody. Respected chairpersons, I am presenting a case of a 72-year-old male, non-case of coronary artery disease, where double vessel disease intervention was done in 2024 LMCA elsewhere. He presented with a chest pain and 2 episodes of syncope. On examination, his vitals were stable and cardiovascular system was apparently normal. ECG showed LBB in sinus rhythm. His enzymes were elevated. Echo was showing abnormal LV function, septal motion, concentric LVH, and LV function was normal. So here you have got a patient with a NSTEMI who had undergone previous intervention elsewhere. And we have gone through the previous records and they brought the angio CD. They showed intervention procedures in LMCA, probably LMCA shaft was disease, and they put a 4 into 8 millimeter stent. And this was the final angiogram showing stent there. So we planned for the intervention. Angiogram was done on the next day after stabilization. So this is the LA caudal view showing tight L6 osteal lesion. LAD and L6 are proximally calcified. And cranial view shows some disease at the ostium of the LMC also. Meanwhile, we wanted to take another shot in the RA cranial view. There was acute occlusion of the middle AD, probably because of a thrombus migration. So what did we just wired the vessel and did a POBA with a 2 into 10 millimeter SC balloon at 10 atmosphere, and his flow was re-established. So at that point of time, he was stable. So we expected some more complex things in the LMC or in the proximal LAD. So we just wanted to stabilize him first, and we shifted back and planned for a major intervention later. Probably we'll do under image guidance. And meanwhile, he had some in-hospital issues like respiratory infection and hemoptysis. Those were tackled with antibiotics and all. And after 1 week of stabilization, we took him further and planned for image-guided PCI. So our plan was to study the previous LM stent, and we first planned for L6 to LM pullback. So there was some difficulty in introducing the OCT catheter to circ. So we had to pre-dilate LM first. Then we took the LMC to L6 pullback. So this is the pullback image. You can see tight lesion at the L6 ostium. And when you are coming to, this is the L6 ostium, and when you are coming to LM, also there is disease. And our next attempt was to take a pullback from LAD to LM. So there also we had some problem with advance in the OCT catheter. So we just pre-dilated to L6 LAD ostium, and we did the pullback with the angiocorrelation. So now we are at the level of septal branch. You can see some calcium at the wall, and now we are approaching the diagonal. Yes, there are also disease, and we are at the level of proximal LAD. You can see the lumen is coming very narrow, and again we are entering into the LM. LM ostium is also narrowed, and now we are at the catheter. So we have got very tight lesions. To our surprise, LM shaft of the LM did not show any images of the struts. So that shows that there was no stent at all in the left main. So this patient was having all antiplatelets and statins for the past 3 years. Even though he had a left main intervention, the stent was missing somehow. Maybe because of the, immediately after the post intervention in the first place, he had a missed stent, but there was no symptoms and he was doing well till that period of second admission. So we measured the ostial LAD. MLA was 2.14 millimeter square, and LMCA ostium was at MLA was 2.18. So we planned for a reintervention with a decay crush with a favorable angle and size of the L6 and LAD. So L6 was pre-dilated and 2.75 into 12 millimeter stent was placed in L6 with the studs advancing into LM. And after placing the stent was crushed with a 3 into 10 millimeter NC balloon in the LAD. And L6 was recosed. Then first kissing balloon was done with a 2.75 and 8 millimeter NC in L6 and 3 into 10 in the LAD. Then we pre-dilated the LAD and the LAD to LM stent was placed 3 into 38 millimeter. Then first port was done with a 4 into 6 millimeter port balloon. Then circ was recrossed. And then final kissing balloon was done, 2.75 balloon in L6 and 3 balloon in LAD. And then final port was done. This is the final angiogram. LMCA is okay, and LAD, L6 are flowing with the TIMI3 flow. So this is a case of stent dislodgement, where the patient was not having much symptoms for 3 years, and later he presented with the ACS. So the stent dislodgement is an uncommon complication in PCI. The incidence has been reported as 0.32%. Stent dislodgement is associated with adverse cardiovascular events. Retrieval of fully deployed stent is generally prohibited as it increases the risk of severe complications. It should be done only if mandatory and in the presence of surgical standby. When ISR or stent thrombus are encountered, imaging should be strongly considered to optimize the subsequent approach. Here, actually, imaging saved us from the, imaging guided us for the second intervention, how we have to do it. Actually, we end up in decay crush. Otherwise, we have to overlap. The stent studs will be more in LCX. And the patient was not, he was a frail patient with multiple issues, and he was not a candidate for a CABG, even from the bystander side, they did not opt for CABG. So we had to go with the intervention only. So really imaging help us to do a better way of intervention here. Thank you.
Great case, Vinu, because
Thank you, sir.
I don't think any of us has seen a vanishing stent before. Beautifully done case. The initial stenting, which was done, I think, somewhere else.
Yeah.
It was a mid-shaft stenting.
Yes.
Not extending up to the bifurcation.
No. Actually, they have used a 4 into 8 millimeter stent.
And what was the reason for the initial, what do you think finally the reason for the initial problem in sending your OCT catheter across the LAD ostium as well as the circumflex ostium?
Probably ostial LM, there was a tight lesion. The MLA was very small actually, very narrow MLA. That might be the reason for advancing the catheter. And in LAD as well as in circ ostium, there is associated calcium also. So both might have contributed for the problem.
And your OCT also revealed calcium.
Yes.
May not be very it may not be the close to the intima.
Yes.
A little deeper calcium.
Yes.
But you didn't think of calcium modification, and we didn't see the final OCT,
Yeah,
post
exactly.
procedural
So
OCT.
the problem with the calcium, actually the calcium was a little bit deep, and it was not that thicker calcium, and there was no calcium nodules protruding into the lumen and also.
And your
that
balloon was expanding well.
Yeah, that yielded for the first pre-dilatation itself. Other thing for second OCT, actually because of the long procedure and all, almost because of this difficulty in passing the hardware and all, we took nearly 2-3 hours, and contrast volume was also a little bit high. So we did not go for, unfortunately, we could not take the repeat OCT.
And where is the stent now, the old stent? What is your guess?
Actually, that's the issue. Ideally, you have to do a whole body CT to find out whether it is.
If it
situated
disappears,
somewhere. Yeah.
if it migrates, and you scan the entire left-sided coronary system, you could not find it.
Yes.
Then the only place it can go is to the aorta,
Aorta.
and systemic.
Yes.
But when we look at the OCT, your first OCT, I think there are some signals
I
where
solemnly
the stent
pledge
is
that
deeply
I
buried
will do
inside
my
the
best to serve humanity.
it's
Every
new
doctor's
atherosclerosis,
journey
perhaps.
begins with a promise.
What do you, any,
And this,
can we have a
No. It was a. No, it was not biopsiable stent. It was DUS only. I have shown that it's a science expedition stent, 4 into 8 millimeter.
when you excellent imaging and planning of the case, but my observation is that you have not applied the OCT findings into your treatment at all. You have not measured the LM dimension. I still feel that
LM dimension and MLA, everything we have measured actually.
done.
Yeah, it is
Yes,
done.
yes,
It
he
is
showed.
displayed also.
And I also agree with him. Probably the stent is lying behind all that muck that was there in the LMC.
But usually in when you do OCT, what I have seen the images and all, you will be some strut shadows might be there just to.
Such a thick thing.
Sometimes it's so deeply buried, and there is a huge amount of neoatheroma with calcium, because one or two of these things, there was some signal, which some artifact which may be suggestive of a deeply buried stent. Any
And
other
you could have used
anything?
Okay.
could be
Because some stents, it's very difficult, as you rightly pointed out, very difficult to see. And when it is deeply buried in the neoatherosclerosis, I think it may not be a migration, but rather we are not able to visualize it.
or it could be use stent boost. Did you try a stent boost there? Yeah.
And what about the fluoro images? It won't show much.
Fluora and a stent boost you have
Stent
to do.
boost we-
If it is not there, then you'll have to look at the vascular tree. Maybe in the iliacs it might be.
Okay.
Or a CT angio maybe.
Whole body, they suggest a whole body CT scan will reveal that. That's before the intervention. We have already done the intervention, and after going for whole body CT may not be that much.
No, it's easier for you to scan during
Yeah,
that
where it
procedure
has
itself.
gone, probably. All body CT means mainly the aortoiliac vessels or in the.
Yeah, just a second. So it's not non-occlusive. It might be in an iliac or some.
Yeah, final result was okay. Their final result was okay actually, because the stent was very short stent that was in the mid shaft. Then result was okay.
I think we'll go on to the next case for want of time.
Thank you, sir.
Dr. Jimmy George with imaging in calcified complex PCI. Jimmy is missing.
Jimmy is missing, I think. Shall we move to the next?
You'll have to present.
Jimmy is there. We'll call the next, and if Jimmy comes, we'll give him the last chance. Dr. Rajalakshmi, please. Praveen is presenting. And if the present comes, the prize comes, it should go to Rajalakshmi, madam.
So good morning all. So this case was not done by me because Madam requested. I am presenting this case on her behalf. And Abhilash, please note the price. If it's there, it should be from me.
And the answer should be given by you, isn't it? You are going to
Whatever
answer.
possible, whatever I know, I'll give. So the patient was a 53-year-old male, who presented with NSTEMI. He had a history of PCI to RCA in 2004, and after that he had a inferior wall MI, which was lysed with urokinase in 2007. So the current angiogram showed a dominant RCA with a single vessel disease of a dominant RCA with the ISR 90% in the proximal RCA and 70% after the mid part of the lesion and 90% just before the PDA, and the left system was normal. So it was planned for a PCI to RCA. So this was the angiogram, diffusely diseased vessel. You can see a stent in the proximal RCA. And it was pre-dilated with a 2 into 12 balloon followed by a 2.5 into 12 balloon. So the distal RCA was stented from the PDA with a 2.75 into 48 stent. And this was the image after stenting. So the pot was done to the distal RCA with a 3 balloon. And there was some pinching of the PLB, which was rewired and struts were dilated. And they decided for a spot sending of the proximal RCA, even though there was some plaque in the mid RCA region, and they decided to go with a shorter stent. 2.75 to 28 signs was used. Then this was the picture after the stenting. Then it was dilated, post-dilated with a 3 balloon. So after the post-dilatation, you can see a very tight lesion appearing in the mid RCA. So initially, it was thought it would be a spasm. Then we decided to do a IVUS imaging. So what we saw was a large intramural hematoma at the mid portion. So you can see the still images. So then that area was covered with a 2.75 into 23 signs expression. And was then post-dilated with the 3 stent. There was some malapposition in the proximal, which was again post-dilated with a larger balloon. And this is the final angiogram. So the take-home message is that you should suspect intramural hematoma when you see such sort of new lesions which appear from the distal edge of the stent. And this can be confirmed with imaging, and it is a potentially treatable complication. Thank you.
A nice case, well done. And what made you do that imaging before? Did you give nitroglycerin before?
Yeah. Initially, nitroglycerin, everything was done. So then we thought of doing the imaging to see what is happening there.
It was not relieved with nitroglycerin.
No. With I think they gave 3 or 4 times and nothing was happening. So we did that, took the IVUS.
Did the patient was symptomatic at that particular
He
time?
had chest pain.
Just to confirm, it looked a little separate from the distal edge of the stent, was it? Or am I not visualizing
It
properly?
is little separate.
Yeah. How is it possible? But,
hematoma could have migrated down with the post-dilatation.
it need not necessarily start from the edge then,
It
probably.
could have started from the edge, but
And then,
it would have migrated.
because usually what we see is just at
Sometimes
the edge.
when there is hematoma, when you put a proximal stent, you can see the lesion migrating distally. So that could be the. I think you should have stented from the. And I think a longer stent covering, there was some plaque in that mid portion. So we should have put a longer stent and I would have put a longer stent covering that to the distal stent. I think 48 would have been better.
I think once hematoma happens, when you stent, it will progress either antegrade or retrograde. So ideally, you should use a cutting balloon and then cut it open so that it doesn't progress further. In this case, it did not happen because there are stents on both sides.
Yeah.
Yeah. Then another thing, in the first stent, then that port, before that port, it's better to take the wire from the PDA and wire that PLV, then remove the side branch, because if you, such a long stent, maybe if there is calcium also, then removing that side branch wire can be a problem. So once you deploy, then take the PDA wire and wire the PLV, then remove the side branch and put it
with the current wires, especially our workhorse wire is Sion blue, it comes out easily. But the BMW wire, I agree with you, you usually take it out. But with the hydrophilic wires, I think they come. BMW, you usually feel a resistance, but with the hydrophilic, like Sion blue wire, it comes off easily. No problem.
Raju sir, can I have it?
Yeah, please.
Please. This is what Raju has said, because the hematoma management always is not with the stent, because what can happen is your hematoma can still migrate
Because
proximally or distally.
There is a stent distally, you usually won't happen. And we
But
cannot.
But there is no guarantee. That is what I think. What's the opinion of
Between
that?
two stents, that's
It's,
why there was a guarantee.
look, as Mangalanathan, we all agree that hematoma management is not always a knee-jerk reaction of putting a stent immediately. But there are certain hematomas where you have to put in a stent, otherwise the vessel will close off. And it may not be at that particular time. You shift the patient to the CCU, after half an hour, you'll get a call that the vessel is occluded, ST is elevating. This situation, I think, stenting was the correct strategy.
No, I am not questioning the
But not
stenting,
for all.
but you should
Fully
give
agree.
a way for the hematoma to get out, like
Right.
with a maybe
And
a cutting balloon. That's why.
Praveen, I think
I think the cutting balloon at that point was not available also. Wolverine was out of stock for some time during that time.
Praveen, it was a long stent in the distal RCA, another short stent at the proximal RCA, and it happened in between. What is the reason? Is it calcium?
I think there was some plaque in the mid RCA. So when after
As
the post
Dr. Pratap suggested, it should have been two long stents stenting the normal to normal area, and still the PLB is pinched.
See, in Trivandrum, we have a very great advantage. If one guidance is not available in one cath lab, it is almost available 200 meters away. You can ask for a cutting balloon.
Wolverine was not available in the market for a couple of months. It was not available.
Like that.
Sir, we have heard that
we have heard in multiple forums over years that you use a cutting balloon for a hematoma. How is it really done, sir? How is it really done?
People actually claim that it is not really effective. That's what I'm telling. People just tell that, okay, I will use a cutting balloon and that it will not be effective. You can actually, through hematoma can be aspirated. Aspirated means with a microcatheter, if you have a dissection or spontaneous hematoma, aspiration is the only way out. And this is most of the time ineffective.
But hematoma is inside the vessel wall, sir.
No, I have used, but we are used with that microtome, blade.
Rajesh, I do not know, because most of these things are anecdotal experiences. We don't have data, we don't have recommendation regarding this cutting balloon. I am little skeptical about using cutting balloon. Many of the hematomas resolves, but it takes time. We have to protect the vessel till that time.
I have used in three cases.
Three cases.
One case is from mid-LAD went up to circumflex. I was wondering what circumflex is getting occluded for a mid-LAD stent, because hematoma came back.
The hematoma from LAD
came
crossed the
back
bifurcation
into
and went
the circumflex ostia.
Thank you, Dr. Praveen.
Just what size of the cutting balloon do you use based on the IVUS measurement?
1:1.
1:1. That is a normal. 1:1 is enough.
Okay, thank you. Thank you, Praveen.
We have to move on. I think at the end of the day, everybody agrees we will do exactly the same thing what you did.
We can go ahead with the next speaker, Dr. Umeshan sir. Yeah. Presenting a case of late stent failure and death.
Good morning to all. Stent thrombosis nowadays is an uncommon, but definitely it leads to life-threatening complications. According to the time frame, the stent thrombosis is classified into early, late, and very late, which is occurring after 1 year. Now, a new terminology has been reported in the literature, which is called very, very late stent thrombosis, which happens after 5 years of stent implantation, and it's mainly described with first-generation deaths. This is the story of a 63-year-old male. Actually, when he was at the age of 57, that is in March 2016, he had an acute anterior wall MI. He's hypertensive, had old CVA. The angio showed a single vessel disease, had a primary PCA with stenting with a 3 into 28 millimeter sirolimus eluting test. This was his angio. In 2016, had a proximal LAD occlusion. So there was a total occlusion LAD. It is a single vessel disease, 100% occluded, pre-dilated, 3 into 28 millimeter sirolimus eluting test was deployed, post-dilated with a 3 into 12 millimeter NC balloon, and that's the final result. This is the final result. He was doing well. He was in a regular follow-up with a cardiologist. LV function was normal. There was no angina. He was on regular medications. He was on dual antiplatelets for 2 years. And then after that, he was continued on aspirin atorvastatin combination, telmisartan, and metoprolol. In July 2023, that is after 7 years of his primary PCI, he presented with acute anterior STEMI. He was sick. He was with acute pulmonary edema. Heart rate was 110 per minute. BP was 170. Saturation was 86%. The patient told that he is taking the medications regularly, but his wife told that probably he stopped it for a few days. Maybe his review was due. He thought that he can get the medicines after consultation. And according to the wife, he used to do it like that in a few occasions in the past also. So this is the angiogram. Again, this is 7 years after his primary PC, almost like the similar picture which he had in 2016. So he was sick, so he was taken to the lab, and we did a pre-dilated with a small balloon, then 2 into 10 millimeter balloon, and 3 into 10 millimeter balloon. We could get a reasonably good flow. We stopped at that moment because patient was sick. Just he was on an IV, his blood pressure improved. So the plan was to do an angiogram. His creatinine was 1.2 at the time of admission. It went up 2. Then after 4 days, he was taken to the lab again. This is the angiogram. We did an OCT pullback. I'll just run through the pullback. This is angio-co-registered OCT. There was diffuse intimal hyperplasia. There's some white thrombus there. Just before the stent, there is some fibrofatty plaques with luminal narrowing. Lot of new atherosclerosis with the varying forms of fibrofatty mixed plaques. There are red thrombus. Probably after the balloon, that's why there are some plaque ruptures. So we are into the left main. So these are some of the measurements. So if you see the A, there is just before the stent. And there is a lot of new atherosclerosis and mixed fibrofatty and fibrous plaques. So this is just before this, just the distal part of the stent. This is how you interpret it like this. I don't know, you can correct me, the experts can come and correct me. I could notice some of the stents which are still unendothelialized. There are few stents still which are unendothelialized. Here again, this is after 7 years of stent implantation. There are few struts which are still unendothelialized. So we pre-dilated with the 3.5 NC balloon, did an dub with 3.5 to 30, and that is the final result. So stent thrombosis, there are different causes for stent thrombosis. The stent-related causes for the very late stent thrombosis, delayed healing, non-uniform endothelialization, and neoatherosclerosis. So probably the take-home message is stent thrombosis may occur many years after implantation of a DUS. Definitely imaging helps. This raises the question of use of DAPT. Now there are a lot of guidelines. We still don't know it should be individualized. Thank you for your kind attention.
Hi. The 7-year is a key thing. So because I think Rajesh himself has some data from SCT where 7 years is the time when most of the neoatherosclerosis and the recurrence of ACS occurs. So I think partly there is definitely an element of neoatherosclerosis
Definitely there is
happening.
neoatherosclerosis.
And I think the images are very clear that there is some part of, where it's not fully endothelized. So partly neoatherosclerosis plus an element of stent thrombosis may not necessarily be the
May not
reason.
be related to
Yeah,
the
may not be the reason.
unendothelialization.
Exactly.
It could be the plaque
But I
rupture
think
in a
the 7-year
neoatherosclerosis.
thing is very important. I think we should start, we should continue our high-dose statins for at least the first 10 years. Because it is usually seen this 5 to 10 years is the time when recurrence has happened.
Even there are reports up to 20 years. I was going through one of the literature. They have a series of 40, 45 patients. There one patient had presented after 20 years.
Just shows how little.
That was the first generation this.
Basically,
Basically, it's not basically stoppage of dual antiplatelets alone. I mean, you cannot say that, okay, it's just because of the dual antiplatelet, stopping dual antiplatelets alone. Because this patient also, they say that in between there are a few times they have stopped the medicine for 2-3 days like that. We also come across patients like they say that, okay, 2-3 days we are not taking it because the review is due or some other reasons or other.
what is surprising is on one side of the stent there is no endothelialization, on the other side
Side
there is
is
a malignant endothelialization. Some things we can't explain. Some part,
But not the endothelium. No?
Clean. Can't wipe it clean.
When we see such very late stent thrombosis, it's even if the patient is compliant to the dual antiplatelet therapy, sometimes it may occur because it behaves like a natural atherosclerosis and an accelerated atherosclerosis where the plaque ruptures. Since years imaging is after a balloon dilatation, we are not able to find out whether there is an underlying plaque rupture. That is maybe one reason, but quite unusual. One part is not endothelialized, but we could not see any microchannels, which are the forerunners of a plaque rupture. No microchannels, no macrophages, no cholesterol crystals, and no calcification also in that neoatheroma.
But I think it should be the plaque rupture only. It might not be
It
due
is
to the
likely to be a plaque
unendothelialized
rupture.
distance. Yeah, we finally we used DCP. 3 into 30. 3.5 30. I'm sorry, 3.5 into 30.
3.5 because
3.5 into 30.
the initial stent also seemed a little underexpanded, isn't it?
Maybe 3. It's measuring. I mean, we couldn't measure the exact diameter because it's all fibrous. But distal it was looking at 3.25 in the normal segment. Maybe it's a 3.5 vessel. Definitely. We did a 3.5 into 30 sirolimus cell.
Thank you.
Thank you.
Can we go on to the next presenter, Dr. Rajesh Muralidharan on PCI in a normal coronary artery? What are we coming to?
Respected chairpersons, teachers, colleagues, and my dear friends. Rajesh sir was blasting Namburi sir for teaching me how to do a PCI in a normal coronary artery. Actually, Abhilash has missed the normal inverted commas for normal. So it's a PCI in a normal coronary artery. So this is a 32-year-old gentleman. He's a software engineer in Mumbai. He does not have any traditional risk factors for atherosclerosis. He's a non-smoker. He's a bit towards the obese side. He has history of COVID 18 months ago. That is, this case was done around 1 year back. He came to us with complaints of atypical chest pain. He doesn't have dyspnea, chest pain, or anything of that sort. Troponin was negative, and echo was suggestive of an old anterior MI with a moderate LV dysfunction and ejection fraction of 35%. The LAD territory appeared echogenic and thinned. This was his ECG. There were poor R waves in the anterior leads, Q in lateral leads, as well as the T's were upright in V1 to V4. So the diagnosis was old anterior MI, moderate LV dysfunction. So we first sent him for a SPECT just to see the viability, because echo-wise it seemed the viability wasn't questionable. So the viability study showed an ejection fraction of 28% by SPECT scan. There was severely reduced to absent perfusion, that is a non-viable LAD myocardium in the apex, apical, and mid-anterior androseptal segments, and partially viable myocardium in the rest of the LAD territory. And other parts were perfusing normally and were viable. So we took him up for an angiogram, and I'm not sure how clear it is, but this was the angiogram, and I would encourage each one of you to have a look at it yourselves. There was some diffuse mild disease, as we would put it. The distal LAD after the diagonal, which is fairly a long vessel, narrow vessel, appears diffusely diseased, but there is nothing obstructive as we can see from the coronary angiogram. Although there was a suspicion of something, a whitish part, whitish or a hazy thing in the proximal part of the LAD. I'm not so sure how much appreciable it is. It was best appreciable in the iliocaudal view from somewhere in that point, this point. So the diagnosis at this point was that old anterior MI, moderate LV dysfunction, mostly a non-viable LAD territory, or flowing left antidescending artery, nothing obstructive. But there was some sort of a haziness. So we don't have an in-house Pradap sir's beautiful lady. So we called for a OCT, arranged for an OCT, and brought him back to the cath lab after a couple of days. And this was the OCT run. So there is diffuse disease. There is atherosclerosis. There is a homogeneous plaque. And as we come forward, the minimal lumen area from what we could calculate, I am no expert with this, but it was around 3.4 to 3.7 millimeters square. This was the tightest point. And then this appeared. So this was probably giving that white hazy appearance. So now the next question is, we have a recanalized thrombus, and I thank Deepak sir for his online help for this. The lower zone actually shows some sort of a flap-like thing, so I was confused between a spontaneous dissection versus a recanalized thrombus, but this is most suggestive of a recanalized thrombus, the classical lotus stem appearance. So the next question is whether to stent this or not. So I was not sure, we were not sure what to do, especially considering as part of this LAD territory is non-viable. So what we did was we put in a physiology wire, and the RFR was strongly positive. It was 0.74. We didn't bother to give adenosine because it is anyway going to come below this. And he is a young man, so we thought we will go ahead and stent. So it is stented with a 2.7533 DES, and it was optimized. And it was done on an FFR wire. And the post-PCI RFR value was 0.95, and post-PCI FFR was 0.86. And then we repeated the OCT, and this is the OCT image, which shows good expansion and reasonable apposition as well. So the learnings from this case are, so this is his echo. Actually, 9 months later, the LV function has improved. Now it is 43%, which means that we have done good work to him and that the myocardium was viable. So OCT identified the possible cause of myocardial infarction in this case. It helps us differentiate between a SCAD, which would have gone for a medical management, versus a recanalized thrombus. But the learning was that a positive FFR and RFR told us that this recanalized thrombus is obstructive and that the myocardium subtended by this lesion is viable. And OCT helped in optimization of the stented segment. And post-PCI further told us that we have done a good job. Thank you for your time and patient listening.
I feel that if you had not done anything to this, it would have come a couple of years later to Dr. Pratap as CTO.
Post PCA FFR was 0.86, sir. 0.86. We did do an RFR pullback, and there were no areas where we could have optimized further. Distal part was non-viable. Other part was partially viable.
Rajesh, why to do an OCT rather than an FR first time itself?
Sir, we didn't know that what is happening because angiogram didn't just showed some white thing. Probably streaming also we could have thought about that. So we thought we went ahead with OCT. A young man, MI, we don't have an explanation. We thought we'll go for OCT.
I had a similar case, you know, again, this is one of those things which we think, the hazy thing in the proximal LAD, which we are not sure. In the same day, that time also the FFR was very significant, it's 0.6. And,
Sir, I talked to this with the innovators of FFR. Then they told us, what they told me was that a recanalized thrombus FFR is always strongly positive.
And because you never know which part of the hole the wire is going through, in which case it will again be positive.
Not only that, sir, what they told us was that septae is probably obstructive. So that is the reason why it is always positive, it seems. I never knew that a recanalized thrombus FFR is positive. The other part is FFR also tells us that this is viable. So stenting that, we are actually doing the correct scientific thing for this. Follow-ups are 9 months, that is the 43% ejection fraction. And he had homocysteine levels that were high.
That doesn't mean that you should stent. If homocysteine level is high, you change the image and you stented it. You changed the image and then found out that there is a recanalized thrombus and it was flowing reasonably well. And the distal part of the vessel was very narrow. Distal LAD.
There is also a diagonal, sir.
That's a diagonal. And was he having symptoms of angina?
No, it was LV dysfunction only. And it is.
Should the house agree to?
FFR was positive, sir. That is why we stented. FFR strongly positive. I just wanted your opinion, because how many of us would have stented this just based on OCT?
These strands of recanalized thrombus can make the FFR positive. And they can also get dissolved later on with your treatment and homocysteine correction.
No, thrombus is not new, sir. Trop is negative. So it is a remote MI. And moreover, it is a scarred myocardium.
That is in the resolving phase, if I think so, that way.
Rajesh, Rajesh, it's a great thought process. We greatly appreciate your thought process because seeing the angiography with a flowing vessel, most of us would have ended our investigation there itself. Send with medical therapy. This is truly practical thing. Second, you did the viability. Then the thing changes. Mostly the LAD territory is mostly non-viable. There also a part of us will stop the investigation. But you went ahead because of your suspicion of that particular area in the angiography, and you did FFR and imaging. With imaging, a recanalized thrombus, as your Prasad sir said, is not an indication for stenting with a lumen somewhere around 2.5. Despite that thrombus, the lumen of the LAD, flowing lumen of the LAD was somewhere around 2.25 or 2.5.
3.4, sir. 3.4. I don't know how to...
The lumen, lumen only.
Lotus stem, I don't know how to calculate.
Not non-obstructed because there was a margin, the non-obstructed lumen. Fourth is the FFR. The FFR you cannot ignore, though there are limitations in the FFR because of the very small size of the LAD, the distal part of the LAD, non-viable myocardium, remote MI. So there are a lot of limitations. But what I finally agree upon your stenting is that the FFR after the angioplasty, it improved by 20 points, isn't it?
More than 20 points.
More than 20 points. So that is the proof of the pudding. Otherwise, there are a lot of things to debate. Lot of us, many of us may differ in their opinions.
No, sir. No, LV function has improved, sir. Time has told us that
LV has improved.
LV has improved,
Rajesh.
sir.
Yeah. Rajesh, in a purely non-viable area, because the decision to stent was based on the initial FFR. The initial FFR, you expect it to be low in a non-viable myocardium also. Wouldn't it be so?
No, sir. If it is fully non-viable, FFR is also a measure of the viability of the viability.
Now that is a baseline value. Yeah, it's a baseline value, right?
Yes, sir. So
What
baseline,
will the FFR be?
had it been fully non-viable, FFR would not have been this low. It
how
will be
low would-
normal. It will be above 0.8. That means even if you have some viable areas or very minimal viable areas, the FFR, if it is more than 0.8, it means that there is no point standing that.
And Rajesh, one more question is, what prompted you to go for FFR in a mostly non-viable myocardium? Because
It's
you
not-
are a master of FFR, I know that.
No, not only, not that, sir. Not that. Mid part is partially viable, non-viable.
Right.
Young man, and we should go all out to improve his myocardium.
So these nuclear perfusion scan viability, is it a myth or a reality? It's a myth. No, many of us believe that it's a myth. But the number of patients nowadays we are sending for this nuclear perfusion scanning has come down significantly. Great case, great discussion, wonderful thought process. Thank you. You want to?
Yeah. In this case, I think it's the diagonal is viable. Distal lady, generally, what happens is the distal lady, the apex will be non-viable, but diagonal territories, early septal, those will be generally viable. Then maybe they say 4 out of 6 is non-viable. It may not be 100%.
Extremely unlikely that the apical area is viable. I think we will close down the discussion. Great case, and it generated a lot of discussion. And we thank, on behalf of all the chairpersons, I thank all the presenters who have done a wonderful job and generated great discussion and thought process and learning for us.
Thank you, presenters, and thank you, chairpersons, for the array of exotic cases and the interesting discussions. Next session is on bifurcation stenting. May I invite the chairpersons for the session, Dr. Arshad, Dr. Madhu Sridharan, Dr. Sheba George on the dais.
Good morning, respected chairpersons, senior teachers, and friends. I am presenting a case of a complex calcified bifurcation done through a decay keloid strategy. So, introduction to the case: 59-year-old male, diabetic hypertensive with family history of CAD, presented to us with an ST elevation MI infraposterior MI on July 6th. He was taken up for primary angioplasty. Angio showed a triple vessel disease, heavily calcified vessels. Initially, we did a primary POBA to the primary PCI POBA to the RCA. Patient had TIMI3 flow. Patient was stable. So it was decided to do a rotablation PCI, rota-assisted PCI to the RCA, which we did later in the next week. On 13th, we did a rota-assisted PCI to the RCA. So today I will be presenting the case of the PCI, staged PCI to the LAD diagonal bifurcation using rotational atherectomy under imaging guidance with OCT, using a decay keloid strategy. So this was the angio of the left system. You can see LMC and LAD is heavily calcified. On the RI caudal view, you can see the osteoproximal diagonal is significantly diseased. Diagonal is also calcified. You can see there is a middle LAD mycal bridge and the terminal LAD is CTO, totally occluded. But most of the septals and diagonals are given before that CTO segment. So we went ahead with a OCT run, pre-PCI OCT run. At the mid part of the LAD, the tight stenosis, you can see more than 270-degree arc of calcium, almost 360-degree arc of calcium. Lumen area is around 1.1 at that tightest segment. Mean diameter of 1.1, MLA of 1 millimeter. So it's an angiographic correlation. Proximal LAD is calcified, but significant vessel narrowing is not there. Middle LAD is tight stenosis, the lower part. So angiographic correlation with the OCT. Heavy calcified, deep, thick calcification, you can see more than 5 mm thickness calcification can be seen. Almost 360-degree arc at the mid part. So we went ahead with the rotablation. Rotawire was passed. Then using a 1.5 bar, we did the burring of the LAD, as well as following that, we wired the diagonal with the rotawire, and we gave a rotablation to the diagonal also using the same bar, 1.5 bar. So both LAD as well as diagonal rotablation was done. Following that, pre-dilated with NC balloon after rewiring through the run-through wires. So as a first, we took this, assigned the side branch as diagonal, and we took a stent from the diagonal to the proximal LAD. A 3 × 38 everolimus drug-eluting stent was deployed. And the proximal side branch was optimized by pulling back the same stent balloon. Following that, we gave an initial port with a 3.5 into 6 dedicated port balloon. Then after recrossing through the distal strut, we gave the first kissing dilatation. That's the modification of the DK kilode, the double kiss. Here comes the first kiss using a 3 into 10 NC balloon at the diagonal and 2.75 into 10 at the LAD. The distal LAD, middle LAD was almost 2.75 by OCT. So the distal branch size should be used for the balloon to be used in the main vessel. Following that, we did the main vessel stenting. LAD was stented using a 2.75 into 48 everolimus drug eluting stent, such that it's just before that myocardial bridge. Following that, we did the distal recross. Then we gave an initial sequential dilatation of the side branch stent, side branch with the balloon, then the main vessel stent. Following which simultaneous second kiss was done. And this was the final port using a 3.5 into 8 port balloon. Now, this was a post-PCA bifurcation view of the LAD using OCT. You can see the diagonal ostium is well covered with minimal metal in that diagonal ostium, and stent is well opposed, well expanded stent. So this was the final angiographic result. We have very good Dimitri flowing vessels, LAD as well as diagonal, good angiographic result as well as the OCT result we obtained. So coming to the major steps in DK kilode, initially side branch stenting, then proximal side branch optimization and the initial port, following which distal recross and the first kissing dilatation. That is a modification from the conventional kilode. Then main vessel stenting, distal recross and the second kiss, and the final port with the dedicated port balloon. So take home messages. Complex bifurcation lesions with deep calcification of more than 270-degree arc can be successfully managed with meticulous planning, and it's better to avoid it as an ad hoc procedure. Adequate preparations of lesions. In our case, it was rotational atherectomy. Then with significant side branches where we require two-stent strategy, when the angle as well as the two vessel sizes, daughter branches have almost similar sizes, we can go for a DK kilode strategy, which have an additional kissing balloon dilatation. And when you do complex bifurcation cases, it's better to use under imaging guidance like OCT. Thank you everyone for the patient listening.
Excellent case, Les. Very nicely done. Just a couple of questions. One, in the diagonal, did you do an OCT of the diagonal or the ramus? I mean, is it a ramus or a diagonal?
It's a diagonal. It's a diagonal, early diagonal. It was an early diagonal. We did a OCT of the diagonal. It also proximal short part was calcified. I did not include that in the slides, that's all. We did a rotablation to the diagonal also.
Yeah. Okay.
So we did rotablation to the RCA. When we took up the patient for the PCA to RCA, even though the calcium was not looking angiographically very severe, but it was heavily calcified vessel.
And the first time you said after the side branch, you pulled back the
yeah, the stent balloon little proximal, the proximal side branch optimization was done by just pulling back the side branch stent.
Because when you pull back the balloon, it will come outside the stent. So it will not be an optimization.
No, we did a port also. After that, we did an initial port also.
Port is fine, but when you pull back and do a post-dilatation, especially when you're doing bifurcation, that can result in a proximal dissection. So I think if you're doing a port, I mean, just take out the balloon and do a port balloon.
Yeah.
Rather than
initial proximal side branch optimization, it is said that we can remove the, we can just proximally withdraw the.
That's for the DK crush.
I think proximal side branch optimization is at present advised for all two-stent strategies. It's almost like a DK mini kilode because the proximal side branch was only 4 mm was protruding into the main vessel.
Concept now is to have the side branch stent protrude into the main vessel as minimum as possible, or maybe, and then you are going to dilate it. Anyway, you are going to stent it when you are doing the main vessel.
Yes, but when you're pulling back and going to high pressures with that balloon,
I appreciate apprehension.
Yeah, because
it will be covered with the main vessel stent. So that will be overlapped little more into the proximal LAD.
Sure.
Excellent case. In fact, there are 2 points to ask. What was the preparation, in fact, you have done after the rotational atherectomy?
It was using non-compliant balloon. We used a non-compliant balloon. A 2.5 size non-compliant.
Though the OCT revealed a good expansion and apposition.
The image quality was not that very good.
There was some.
There was some slight slight blood stent was there.
Absolutely. And one more thing, in fact, how does this crush cool out? In fact, that will, the first kissing balloon help in this kind of mini cool out. In fact, we know the benefit in DK crush, but how the first kissing balloon will be beneficial in the
So the better coverage of the side branch of ostium as well as the minimal metal at the carina is ensured by a DK, that initial kissing balloon dilatation. That ensures that side branch is, that ostium of the side branch is well covered with the
that is
stent.
with DK crush, right? Cool out.
Yeah,
But anyway, you are not crushing the stent. In fact, the coverage.
DK could minimize the time taken for the PCA in compared to the DK crush. The time consumed is less, the radiation exposure is less.
Yeah, it opens the stud well, and the side branch ostium is covered. Yes, last.
Very good case, but the LAD, the mid portion, I think there was some under expansion.
No, actually, the gate was not properly engaged at that image.
So the OCT,
OCT, there was some blood at that point. That was why.
Some under expansion was there.
No, we had repeated the OCT. Actually, it was not taken from the into the slide.
There was no malapposition, but some under expansion was seen there.
Yeah.
Just after the bifurcation.
Almost expansion was more than 80%. Expansion was achieved.
Excellent case, Les. Thank you.
Thank you.
We'll have the next one. Is Ramesh Natarajan, double bifurcation IVUS guide.
Respected chairpersons and friends, this is a 72-year-old male with risk factors, presented with severe angina. Echo showed inferior wall hypokinesia. And this was the left system, left dominant, distal left main disease, tight ostial LAD, and the dominant circumflex. There was, at the origin of the LPDA, there was a tight bifurcation, stenosis, 111, left main it was 110. And in fact, there was another bifurcation distally in the OM also, which can be a 100 bifurcation. And the right was non-dominant. So if you look at the syntax score, calculator was about 29 in favor of CABG, but the syntax 2 score, which incorporates more clinical comorbid factors also, was similar for both PCA and CABG with similar 5-year mortality of 4 to 6%. So both was acceptable in this case. And after discussion with the cardiac surgeon and patient, we opted for the PCI. So initially the OM was crossed with a cyan blue wire. 7 French guiding was taken. And there was extreme difficulty in wiring that PDA. Multiple attempts were made. But later we thought the problem was there was no space there for the tip of the wire to enter that PDA. So we dilated with a low pressure with a 1.5 mm balloon, created some space there. And then a field FC wire was, after multiple attempts, it engaged the ostium, and with a slight reverse loop, finally it crossed the PDA. And then kissing balloon dilatation was given at the bifurcation, which opened up the left PDA. And then we took imaging from both the LPDA as well as the OM branch. So the PDA pullback, it showed, in fact, fresh thrombus could be seen. The distal reference was about 2.5. And this is the wire in the OM branch. There was a lot of attenuated plaques there at the bifurcation, and significant disparity with the proximal vessel. So here you can make out the fresh thrombus in the lumen. And subsequently, we did the pullback from the OM also. So OM, the distal reference was 275, and approximately it was almost a 4 mm vessel. This is the wire from the PDA. Proximal branch. And we pulled back up to the ostial circumflex was free of significant disease. We could get a lumen area of about 10 with an eccentric, with a plaque burden of about 45% there. So we opted for a mini crush stenting in this case. We took a 2.5 16 stent in the LPDA, which was deployed, keeping a 275 24 stent in the main vessel into the distal OM. So after deploying this side branch stent, we took out the wire and balloon, deployed the main vessel stent, and did a pot with a 4 balloon, followed by recrossing and kissing. And this was the picture, and we took a the IVS image showed the neocarina there and a well expanded stent. And subsequently, we turned our attention to the left main bifurcation. Initially, it was dilated with a NC balloon 2.5 and took a IVS run, which showed a very tight osteal disease of about 2.6 was the lumen area at the ostium. Almost 270-degree calcium could be seen in the proximal LAD. On left main, distal left main, the polygon showed an eccentric calcified plaque. Distal reference, the LAD, it was about 4 and in the left main was about 5 So we took a Wolverine cutting balloon to prepare the LAD and the ostium better. And was followed by a 4 stent, 32 across the circumflex and post dilated. The pot was done with a 5 NC balloon, and the proximal LAD also was post dilated with 4 NC. Then we recrossed into the circumflex, did a kissing and a repot. And this was we got good stent areas in the distal, in the ostial LAD almost 12 millimeters square, left main was about 18. And we took a pullback from the circumflex also. We had almost 8.3 at the lumen of the circumflex. So this was the final images. So basically this is a double bifurcation, which was treated with 2 different strategies. Thank you.
Excellent case, Narajan. Very well done.
Very well done. Congratulations. We'll call upon the next presenter if there are no questions.
Yes. Next is Karnadas, bifurcation, LED D1 cloth.
Good morning. After seeing those perfect bifurcation PCI, I'm going to present a imperfect bifurcation PCI, LAD D1. Actually, we dug up this case done 3-4 years back, as Ashish as well as Abhilash wanted cases with learning points. So that is my anticipatory bail for the criticism that is going to come. It's a 62-year-old male, NSTEMI, hypertensive and diabetic, T inversion V3 to V6, troponin positive, echo showing no RWMA, good LV function. The angiogram had shown mid LAD D1 bifurcation lesion. So for PCI, a femoral axis was chosen, a 7F 3.5 EBU was taken. LAD was a 3.25 to 275 vessel and D1 was a 2.5 vessel, Medina 111. D1 was wired. The initial and LAD was also wired with a 0.014 run through extra floppy wire. The initial plan was just to stent the LAD and come out, leave the D1. So LAD lesion was pre-dilated with a 2.5 into 12 NC balloon and stented with 275 into 33 DES. At that time, the patient started having pain and we found that the D1 ostium is critically narrowed. A pot was done with a 3.25 into 12 NC, hoping that the D1 flow will improve, but it did not happen. So we thought we will dilate into the D1. the LED wire was withdrawn and D1 was wired with the LED wire with some difficulty. And the D1 wire was then pulled out and it was passed into the LED. So after that, the struts across the D1 ostium was opened up, initially using a 1.512 Rayuri balloon and then a 212 sapphire balloon. But there was dissection at the ostium of the D1 and the D1 was stented with a 2.5 23 des. I would like you to look at this picture, the stent chosen and how it is kept. There was TIMI3 flow into D1. A pot was done with a 3.25 into 12, the same balloon used previously. The LED recross was done through the distal strut. And the LED wire was passed into D1. LED was opened up with 1.25 into 10 and 210 balloon that were used previously. And sequential dilatation was done. That video is not there. Keeping a 275 15 NC for 18 at 18 atmospheres in LED and 2.5 15 NC 18 atmospheres in D1, and then a simultaneous kissing inflation was done at 10 atmospheres. And this is a report was done, and that is the final result. So that's what I wanted to say. In this era of mini DK culotte or even nano DK culotte, actually the second stent chosen was too long. It was a 23 mm stent. When it was asked why that stent was chosen, the reply was that was the shortest stent available of the same, from the same company, from the same manufacturer. And second thing, it was chosen thinking that it could be pushed down into the D1. But the D1 was bifurcating and the branches were small. So it had to be left like that. No. So that's why I wanted to say now nobody does this. Even previously in the era of culotte also, this was too much protrusion into the main vessel. When choosing the second stent, we have to be very careful. Nowadays, it is the era of mini DK culotte or even nano. Just keep one strut across and do the culotte. That's all. Thank you.
And it's nicely done. It's hardly an imperfect one, but yes, as you said, the length of both the stents could have been shorter.
Yeah, yeah.
It is a fairly discrete lesion, and you could have. It doesn't necessarily mean that you have to take the stent of the same brand. I mean, you can take.
No, I didn't take actually. I asked the next day and said that the person who did thought that he should choose the same company stent.
Now, in case you're doing it, if you have this 111, would you do anything for the side branch before? I mean, you had just kept a wire. As per the guidelines, you just have to keep a wire. But if you have a tight lesion in the side branch, the chance of it closing is higher.
Yeah, yeah.
So you can do some kind of protection. Either you can keep a balloon or you can probably dilate or whichever. Otherwise, the chance of it blocking is quite high. But otherwise, you've done very well.
I think.
Maybe not. Maybe not. I always go for a provisional stent
You
strategy.
can always keep because it's just an ostium. You can always keep provisional, but you can probably do something for the ostium of the diagonal.
Yeah, in this case, the diagonal is a huge diagonal, lot of territory. Even otherwise, diagonals are notorious to cause problems because it is much more than the territory which apparently it supplies. So I have great respect for diagonals because I have
Not only diagonal, OM also.
So you will go for a upfront two-stent strategy.
Upfront two-stent strategy.
By definition, it is not upfront two-stent strategy because it is less than 5 millimeters.
Yeah, into
But
the
only
just
thing
an
is
ostium.
actually a larger area of territory. That is the point. And you told that you put a wire down, and there was a patient developed pain. But I did not understand.
No. After doing the stenting of the LED, the patient started having pain.
But that same pinching and the same lesion was there before also. Why the patient did not
It
have
had
a
closed
pain?
off. It had closed off. Diagonal had closed off.
Worse.
Diagonal is not closed off. You just look at
Not
that.
closed off, but the flow was less.
Flow was less. But you could pass 2 wires through that.
No, no, no. I didn't pass 2 wires. I pulled the LED wire back.
No. You have a jailed wire. That space is there. You could take another wire there. So that 2 wire space was there. That's what I'm telling.
The one is jailed wire, no?
That's okay, but the space was occupied by 2 wires. So my question is actually, after balloon dilatation, did you have a dissection or not?
Yeah.
That actually, that angiogram.
It's not there. It's not there. So this was a case done 3-4 years back, so I couldn't get all the videos. Now, I will still go for, even though Rajesh said we should do a 2-stent strategy, I will still go for a provisional stent strategy. And if needed, do a mini culotte.
You can have a shorter stent and any company is fine.
Yeah, that's right.
Do you do it differently today?
Balloon embedded technique, actually, Vinayan is not here. We have done a slight modification for the balloon embedded technique. Myself and Sibu have done a slight modification. We keep a balloon in the side branch, keep a 1:1 NZ balloon in the main vessel, just inflate the side branch balloon a bit. That is pre-dilatation itself, not very high pressures. Say 4 atmospheres, keep it there. Then dilate the main vessel with a 1:1 NC balloon. So if it's a 3 LED, dilate it to 3. Keeping that balloon across the ostium of the side branch. Then we pull out both the balloons and stent the main vessel.
No, that is not simultaneously embedded.
No. See, when you pull out the embedded balloon, you're rubbing it across the outside surface of the stent. Is it not so? According to Vinayan's technique.
Actually,
so we wanted to avoid that and deforming the stent in any way.
You're doing a kissing balloon before you put the stent.
Yeah. So any plaque shift that occurs would not occlude the ostium. The balloon is still there, no? So it will go around the ostium. And we think in many cases Sibu has done, I have done, it is very successful.
We've done so many cases and actually very successful. The idea behind that is we do a non-complete balloon to the size of the distal vessel and go to the appropriate pressures. And if plaque shift does not happen now next when you stent it, why should it happen again? Because we had that balloon partly inflated at low pressures in the side branch, just into the side branch. So it is not at high pressure, there won't be any dissection in the side branch, we hope that. And after that we stent. Our fear is that when you put a balloon into the side branch and embed it, when you pull out, we don't do imaging always. There can be some stent distortion. That is always in our fear. That is the reason why we started doing
We started this, but it's doing very well.
This is just like a pre-dilatation of the side branch before you do it.
Yeah.
But that is
No, not to very high pressures. Just keep the balloon there to avoid dissection of the side branch.
Now, Madhu, can I make a comment? I'm doing balloon embedded technology quite often in my lab. That I do simultaneously keep one small 1-to-1 size balloon or a one size smaller balloon at the side branch, keep it inflated to 4 atmospheres and then implant a stent. Then I pull back the stent, the balloon from the side branch and the wire, and then, or not the wire, and then go for optimal pressures for the stent again. The concern that you raise, that you are distorting the proximal part of the stent, is now removed because I have gone to optimal pressures, then recross in case needed, and then go to do the procedure. And what I have seen is recrossing is very easy when you do this. Second, the point which you said in the first slide, if you have a fibrotic little calcified lesion in the main vessel and you use a smaller balloon on the side branch and you use an NC balloon, go up to optimal pressures, you may watermelon the balloon inside the side branch.
That can happen. That has happened. If you use a short balloon, it just goes in.
It will go inside and it will not serve the purpose which you intended.
That has happened. Especially if you keep a short balloon.
So one point is, once you implant a stent, the morphology of the bifurcation changes. So taking what Sibu said, so even if you predilate, plaque shift, see, because the entire morphology changes once the stent comes in.
Yes, plaque shift, this we had tried and then we found that it was useful. And when pulling out the jail balloon once, in the stent boost, I thought that there was some deformity of the stent. Even if you do a pot, there can be some deformity.
Actually speaking, what they are doing, just a pre-dilatation of this side branch. That is only thing. And if you have a insignificant lesion, I'm telling you, insignificant means less than 5 millimeter lesion, not having a tight plaque of calcium and all, you will have no problem and you can come out. That is actually the basis of this provisional stenting. If you have a longer lesion of more than 7 millimeters, larger territory,
You go for
very
a-
bad vessels, 2 vessel stenting. This case, it is actually look like a less than 5 millimeter.
Yes, less than
One
5
one
millimeter.
point, this is not the morphology of the ostium, but there is a snow plowing, that is the plaque and shift. That does happen when the initially a pre-dilatation is done with a non-compliant 1:1 balloon. So the other balloon in the side branch was protecting it. So the plaque shift happened to it to some other area. Now you stent it, then plaque shift does not happen that much to the side branch. Karina can shift. That can
Let's
Karina can shift. That is not prevented by keeping a stent there.
Continue the discussions outside. We can have two short comments from two of them. And
See,
then
we often do this balloon embedded technique, and we never had any problem in pulling out the balloon.
this is an accepted technique. So
Yeah.
I think
So
that is fine.
when the stent is implanted,
No, this is only a
we often keep
modification.
the balloon as well. So there is no point to worry.
The last comment, Vishnu.
Sir, my question is regarding the DK culotte.
No, not clear.
Just fast. It's okay. You can just say.
My question is regarding DK culotte. In DK culotte, we are doing that first kissing balloon inflation. There, we are not doing a crushing. Then what's the advantage we are getting by doing a first kissing balloon inflation?
No, that was told last time by the chairperson.
It's to open up the ostium of the side
Yeah.
branch. All the problems happen with the ostium of the side branch. So when you do a kissing balloon, the side branch is well open and the struts are open as well.
No, for side branch, we are just pulling the balloon back and we are opening the side branch.
No,
The
the
side branch we are putting
in
the
any
first
case, the first case is to just open the side branch and make sure the side branch opening is well open, because you have all the problems in a bifurcation in the side branch ostium. So this just to make it better.
Can I just Yes, sir. Can I just explain that? Many times when you do a culotte technique, you end up having, at the confluence, you end up having a napkin ring. So when you do a kissing balloon dilatation, there are two studies. It's all bench studies. They're made out from fluid dynamic studies as well as micro CT studies, that the opposition is much better and the confluence looks much wider. So that's why two modification has been made. One, you have minimal protrusion, less than 5 millimeter protrusion. Secondly, you do a proper kissing balloon dilatation so that the initial stent is properly, very well deployed at the bifurcation as well as proximal to the bifurcation, so that you wouldn't end up having a napkin ring at the end of the procedure. So it's been proven in studies, but we do not have any clinical studies comparing the classic culotte versus DK mini culotte.
Napkin, you need to have the type of stent as well, because all stents will not be opened up. So it depends on the type of the stent. So with some stents, you can have a larger thing, so you don't have a napkin. But in many others, you can still have a napkin. You can't do anything about it. But this is to reduce the happening of a napkin. Can we have the next one?
Okay, thank you.
Madas. A lot of discussion regarding that. Venkatesh, crush an AMI.
Next, inviting Dr. Abhilash SP to present distal cross versus proximal cross.
Yes. Good morning, respected chair, and good morning, everybody. It's a privilege to be here, and thank you for the opportunity given. Since yesterday, I'm seeing all the presentations, so I want to change my title. All the presentation titles are very good, so I just kept away bifurcation stunting and like normal technique. So I have done a case. We have done a case in bifurcation in acute MI settings. Coming to the case, for 47-year-old male, active smoker, hypertension, presented with local hospital with angina, diagnosed as an anterior MI and thrombolized with STK, and they referred for further management to our hospital. ECG showing evolved anterior MI and echo, there is RWMA with mild LV dysfunction. We have done an angio showing there is a thrombotic lesion in the proximal LAD and 90% stenosis in the major diagonal. LCX and RCA was normal. So we have done a OCT run on OCT showing there is a lipid-rich plaque and red thrombus in the LAD with the length of minimum lesion length of 20 millimeters, nearly 22 millimeters, and the distal vessel diameter of 3.75 and proximal vessel diameter of 4.3 millimeters. So what is the plan? Since we had a significant lesion in the LAD and major diagonal, so we need to protect the major diagonal. So we plan to go for either two-stent strategy, either DK crush, QLate, or mini crush, like that. So we opted to go for a DK crush. We have taken our 7 French guide with the XB catheter 3, and two vessels are lesions are crossed with the guide, run through guide wires. Diagonal pre-dilated with 2.5 and LAD pre-dilated with 3 balloons. And the diagonal vessel here after dilating the diagonal, we have run an OCT on the diagonal branch, and we got the diagonal distal diameter of 3 mm. So we have taken the 3 mm everolimus stent, and we stunted with the 3, and after that we removed the wire and balloon and wire, and the diagonal stent crushed with 3.5 mm NC balloon in LAD. Then after crushing wire, side branch is rewired, vessel is rewired, and diagonal stent first kissing balloon done with 375 and 35 with low atmospheres. Then main vessel stunt deployed in the LAD, and then first part done with the small in the proximal stunt with small balloon with the 4x8. After that, diagonal wire recrossed and LAD stunt recrossed, and then second kiss balloon done with the 3.75 and 3.5 in the diagonal, and then final part done. Then post stunting OCT showing there is stunt is well expanded. There is no medial dissection, no malopposition, and there is an appropriate lumen achieved at the side branch. This is the final angiogram showing there is no thrombus and no lesion, and there is a TIMI3 flow achieved. Let's conclude. Even in acute MI situation, DK crush technique will provide an excellent result if inappropriately selected anatomic substrate. Based on the available evidences, DK crush technique provides a superior when compared to provisional stunting strategy for all complex bifurcation lesions with a significant reduction in MACE and a rate of revascularization, target vessel MIs. Thank you.
Good case. Is it an acute MI? There was no thrombus in the vessels.
Thrombus is there, ma'am. I will show that thrombus is there in the.
Was it thrombolized or it just came as acute MI?
It thrombolized in outside hospital one day before, ma'am.
Now, by the definition criteria, yes, two-stent strategy is good here. But here it's only restricted to the ostium. So when you have a thrombotic lesions, is it good to, I mean, yeah, excellent. Final result is good, excellent. But you may not have this kind of results in all cases when you have a thrombotic lesion. And when it's restricted to the ostium and in thrombotic lesion, it's better probably to have a single stent because more number of stents and higher chance of stent thrombosis is there. But here, of course, it's OCT is done. You have a good result. But not all cases should be done with two stents.
Main thing why we want to go for two-stent strategy after dilatation of diagonal, we have done a OCT run, sir. That OCT run also showing we have a thrombus in the diagonal. So we need to go for stunting strategy in diagonal also.
What is the size of the side branch stent?
3 into 8 mm.
And you have postulated, when you given the kissing delta, I saw you giving 3.5 balloon to the side branch.
Yes, sir. We had 3
The basic principle of decay crush is used to one-to-one size in the side branch while giving the kissing dilatation, and you match the main vessel balloon to the distal vessel diameter in the main vessel.
Sir.
And why did you think that you should be over dilating it? And you have a super expansion in the OCT.
Yes, sir.
But if you follow the principles of, first of all, I agree with Madhu that in a thrombotic milieu, I will reduce the number of stents. Second, that's okay. You have gone for 2 stents. And why did you select a super expansion? The problem there in these cases are no reflow with acute MI. When you go for higher pressures. We are all afraid to give pressures to very high levels during an acute primary PCI. Just a words of caution. You got away good result, but this may not be the story always.
Yes, thank you.
Thank you.
Thank you, sir.
Dr. Lakshmi, image guided decay crush.
Good morning, respected chairpersons, seniors, and my dear friends. I'm just revisiting the fundamentals of image-guided decay crush, just extrapolating it to the non-LM bifurcation. So this is a 62-year-old diabetic hypertensive with history of recent NSTEMI, status post PCA to proximal RC, other investigations essentially normal. Going ahead with angiogram. Angiogram shows a type 2 LAD with proximal to mid, diffusely diseased with maximal stenosis of 80%, from which a D2 arises with osteoproximal 90% lesion at a bifurcation angle of 60 degree. It's a diffuse disease in D2 also. So we can see severe calcification and moderate tortuosity of LAD noted, non-obstructive oscillation in non-dominant circ. So we have come across a LAD D2 Medina 111 classification, prognostically relevant side branch with definition criteria fitting for a complex bifurcation lesion with a result score more than 12, suggestive of increased likelihood of side branch occlusion. Decided on a decay crush, IVAS guided decay crush strategy. We sequentially wired the vessels with run through, serially pre-dilated with 210 NC and 2.5 NC. And we went ahead with IVAS of LED, which revealed myocardial bridge at the level of mid-LED distal to the lesion. You can say persistent equilucent area, juxtaluminal with systolic compression, suggestive of, as can be depicted as half moon sign. And proximal to that, we can see an eccentric fibrocalcific lesion in LAD, progressing to a circumscribed high-grade stenosis with superficial dense calcium of 270 to 360 degree, income up to the proximal LAD, more on the bifurcation core, and involving the diagonal ostium with severe calcification and significant stenosis. Measurements at the distal reference was 5.89 millimeter square with a plaque burden of 29%, tight lesion at the bifurcation with an area of 2.88 and LM LAD bifurcation point of 14.9, adequately sized with a plaque burden less than 45%, and it is 20 millimeters from the distal lesion. So here we embarked on IVAS of D2, here which showed a another circumscribed fibrocalcific lesion with negative remodeled D2 ostium with moderate calcification, with a diagonal ostium of 2.39 millimeter square, significant stenosis. At this juncture, we decided to go ahead with the focus force dilatation of the D2 ostium with 2.5 into 15 Scoflex at 8 atmospheres. And then we decided to go ahead with stenting of the diagonal with 2.5 into 33 Des in side branch against a backdrop of 310 NC in main vessel with 1 to 2 millimeters protrusion into main vessel. Stent deployed at nominal pressures, proximal optimization of D2 done with stent balloon, and the protruding segment was crushed with the 310 NC balloon and then 3.5 NC. Distal, that D2 was re-accessed or rewired through a non-distal strut. After accessing D2, we optimized the side branch OSTEM again with 2 and 2.75 10 NC balloon. And we went ahead with first KBI with 2.75, 2.75 10 and 2.75 10 8 and 310 NC in main vessel at 3 atmospheres. Then scaffolding of the main vessel was done post proximal to mid with 3.8 des, and which can be considered as a second crush. Then we were ahead with a pot of main vessel stent with 3.6 NC at just proximal to the carina. Again, D2 was rewired through non-distal strut and optimized. D2 OSTEM again serially optimized. Then final kissing balloon done with 2.758 NC and 310 NC. And again a report proximal to the proximal position with 3.56 NC. So we have undergone DK, DC, port, SBA, KBA, and report. The post-IVS run was taken, which shows longitudinally well-apposed stent in LAD, optimal stent expansion, no edge dissection, adequate lumen gain, and diagonal OSTEM is wide open with good stent coverage and no overhang strut. Circ OSTEM is also wide open. There is no carinal lesions previously, no carinal shift currently, and LMCA was adequately sized LMCA with minimal lesion that was confined to the lower quadrant, mostly to the right lower quadrant, and no edge dissection at that point. So we have a luminal gain of 6.3, which is more than 100% of the reference diameter, and that at the point of confluence it was 9.96 and proximally 7.64. So this was a final result of the IVS gated PCA. Points, focusing on the meticulous procedure, definitely, and in non-LM lesions also, IVS facilitate precise pre-PC assessment for lesion morphology, lumen dimensions, device selection, especially port balloon, guide wire rewiring, and calcium modifying strategies, assessment of the landing zones, and more now on side branch ostial lesions, and in assessing the management strategy. Thank you.
Excellent cases, Dr. Lashmi, and a very nice result at the end. I just want to make 2 points. One is when you are assessing the calcified lesion, in fact, especially with the 180-degree arc, you are measuring the plaque burden, in fact, because the most of the margins were, in fact, arbitrary. In fact, that is not like in the proximal area with the calcification of 180-degree. In fact, you were saying there was around 42% plaque burden with half of the outer margins were imaginary, right?
Yes, actually, LM, there was a distorted view. Actually, rotational distortion was there. It was done with optic rose. Rotational distortion was noted at that point.
And definitely there was 270-degree calcium, and the only preparation you did was with the Scoreflex. But the final result was excellent with a good MSA and all. In fact, that was the only that was the your strategy also. In fact, to do with the Scoreflex balloon.
Yes.
Right?
Only
pre-dilatation.
Yes, pre-dilatation was with 2 and 2.5, and then only Scoreflex. Thank you.
No, just couple of things. Sorry. No, how much the stain did come into the left main? Did it come to the left main, or was it away from the left main?
It was away from the left main, sir.
But the circumflex ostium was there. Lesion
White
was there
pattern. A lesion. There was a superficial rim of calcium.
The circumflex lesion was there before, because that last shot when you showed, that showed kind of circumflex.
Can you show the last shot?
Last picture. Possible?
Yesterday we rewinded everything. Can you just rewind?
The last slide. Before, yes, that one, yeah.
But we cannot see that, Madhu.
Oh,
okay.
No, the next one.
So.
Next.
Last angio shot, huh?
This is a pullback
last
from
angio shot. Next.
Angio is showing a haziness.
The last shot. Next. Yes, this one.
Here we have haziness shown in Circ, but that IVS showed that wide open, that Circ ostium was wide open with no carinal shift. Can I?
Freeze that part.
The next
one, freeze. No.
this one.
This
Play
one, freeze.
Play this
The
one.
image freeze.
Stop. Yeah. So till where is the stent come? This one. Yeah.
Oh, sorry.
Rajiv, whoa. Okay.
Stop.
Okay, stop.
Yes. So where is the stent coming? Is it coming into the first diagonal or is it coming back into the left main?
Up to the first
Not into left main actually.
So this lesion was there even before.
Yes, sir. There was a non-obstructive or 40 to 50% lesion already in the circostem. Can I show that I was pulled back?
Yeah, sure. Which one?
No, Madhu is asking up to the LED osteoproximal part.
Yes.
She is telling about the diagonal part.
She's saying it's not coming till the LED ostium or the left main. She's
No,
saying it's
if
stopping
you are
before
telling
that.
a 40 to 50% means you have to stent is cannot be placed at that point. Your stent should be in a place where less than 40% of the plaque.
So this is the circostem.
Yeah.
This is the LED stent, bell opposed. Moving proximally. Stop short of circostem.
So the calcium is in the superficial part of the ostial LED.
Yes,
and it's
yes,
stopped-
yes, sir. And it's wide open and the carene is paired very well. Thank you, sir.
My question is different. When you did an IVUS from the diagonal LED distally to the proximal part, why didn't you do an IVUS to the diagonal
Diagonal was done, sir.
independently in the previous part
Yes, sir.
first, and then final IVUS also done to the diagonal?
Not done.
This is actually that everybody tells side branch to be done. That is why yesterday also I was objecting the OCT. OCT cannot be done to the side branch many times, but IVUS can be done. That is the advantage of IVUS. Again, please stop it. That's all.
Madhu, again. See, why so much stress on a short pot balloon in DK Krish? But there's no protruding carena like a tap stenting. So, I mean, the carena, it's like for any bifurcation. In a tap stenting, there is a protruding stent from the side branch, and you should be very careful not to go and crush that. So the pot balloon should be really short.
Yeah.
But for DK crush, why there is so much of, there's nothing protruding there.
It's really not there. It's only for tap, really. And here, because they had used a 3x18, the stent itself was short. So that's probably why they took a 6 balloon.
Yes.
Thank you.
So like yesterday, we will have a detailed discussion on one of those cases, and that is 20 minutes we'll have, because we are ahead of schedule, and the case will be discussed by Dr. Madhu. It is Abhilash. So you have the liberty to take more time, and controversies are always welcome.
Yes, Abhilash, all yours.
Good morning, respected chairs, Ashish sir, Pradap sir, all teachers and friends. Ramesh Narayan sir's last question was, there is not a neocarina in DK crush. And it is usually the problem with the provisional stenting. Let's see. Distal cross versus proximal cross in DK crush. Does it matter? There is a title. 54-year-old male, diabetic. He is the father of a medical student. That added to the stress and drama of the case. Pain of 5 days. It was not a STEMI. He had some sort of a balance sign. Trop was around 300, 400, that range. He is not fully infarcted. He was having rest pains. And we took a radial access. We didn't know what is waiting for us at that point. So we took a radial access, 6 French access. And this was the angiogram. He is not fully infarcted. He was having pain. I'll show one more view. He has a very large diagonal and a LED that is near total occluded.
Madhu, Abhilash, if you could pause. What will be your strategy, Madhu?
Yes. Here, you have a large LED and diagonals, and you got involvement of the diagonal ostium as well. So it has to be a complex bifurcation. So you would probably be needing a
first you would need imaging. Either way, you have to open up, see the size of the main vessels, size of the side branch, and then plan your strategy. But most likely, it would end up in a two-stent strategy.
Okay, sir.
Yeah. 6 or 7. Or a 7.
Now, here, yeah, in fact, I was you have a sixth French. You started with a sixth French, and you know it's going to be a complex thing. So you can always change into a slender sixth French, and that way you could have a 7, because you should essentially, when you're having a complex strategy, and particularly if you are concerned about the patient being a important person, you should be comfortable doing a procedure, because at that stage you
Yes,
should
sir.
not be struggling for things, because if you have six French, you are quite limited in what kind of hardware you can take.
Sir.
So if you have a problem, if you say probably you open up the vessel and you have a dissection, and then you need more hardware, and the six French is causing you trouble, then it would be difficult. So it's always better to plan ahead. And I would have probably changed to a 7 French slender and taken a 7 French sheath. Or if that's not possible, then probably go femoral.
Yes, sir. Fully agree, sir. But two issues were there. One, we didn't have a slender sheath available at that time. Radial access was already taken. Second, he was having pain. So we wanted to do something. At that time, we were hopeful that if we can predilate the diagonal, we may even escape with a provisional stenting. So going to the, provisional, all plans were open. We will either do provisional or two stent. If it is two stent, should it be a TAP or a decay crush? Yeah. So decay crush will be more feasible with the A6 French. Then the points were diagonal osteolytic lesion, as sir told, angulation, and it's an acute coronary syndrome, and 6 French guide. So we wired. The wiring diagonal was difficult. So normally we don't have to routinely predilate the side branch, but since the wiring itself was difficult and the lesion appeared tight, we thought we will predilate the diagonal. LED wiring was not difficult, but the lesion was much tougher. 2 balloon did not crack it. So we used a 2 NC balloon to crack it. You can see the waist in the angiogram. Going back to previous. Sorry. You can see the waist here. It is not yielding to a 2 balloon. So we went with a 2 NC balloon. You can see a hat.
Why? Is
we
when
pause.
it's not opening with a 2, would you be doing some specialized balloon, or would you be just going with a higher non-compliant balloon?
No, we used what is the normal NC balloon available to us.
A cutting balloon?
No, it is not a cutting balloon.
No. Why will you? I mean,
No.
if you have a chance to do it again.
No, it didn't appear that hard. Not calcium. No, it was hard for a non-compliant
The problem is
pre-dilatation balloon and compliant pre-dilatation balloon.
When you have a waist with a 2 balloon and you take a higher balloon at higher pressure, the dissection that you cause would be much more. If, like,
True.
for example, if it extends proximally, then you would be in trouble.
Yes, sir.
If a cutting balloon is, say, it's a localized dissection, which would be relatively safer.
True. Agree, sir.
Madhu, now would you have committed to a 2 stent strategy? Because looking at the diagonal is a very big diagonal, huge territory. So what would...
It has to, but yeah, again,
At this point.
Actually, is it a complex bifurcation? That's by definition, is it a complex bifurcation?
It is extending more than 5 millimeter, and you have a
5
significant...
millimeter or less than 7 millimeters.
Yeah,
The
you
definition is 7 to
and you
10
have a
millimeters.
dissection and the
You can
proximal.
actually take it as 7 millimeters a point.
Large territory.
He is now 10 millimeters. Okay, we can make it 10 millimeters. If it is
Large
10 millimeters,
territory.
definitely it is not. Number one, it's a calcified lesion, severe fibrocalcific lesion. That is what you are having a trouble. In that situation, if you dilate with a balloon of high pressure, definitely you are going to create a dissection.
Yes,
So
sir.
will you go with a cutting balloon? You told the cutting balloon is not available, accept it. If available, why it is not done?
The cutting balloon was available, but at that point, like we had much more struggle with the 6 French support system. We want a balloon which
That
can
is the same thing we told initially by seeing the angiogram. We requested you to change. You did not change. Now you are struggling.
So retrospectively, I am also wiser, but at that point, I persisted with the radial. Guide was
I will,
chosen.
I will definitely go with a 7 French catheter in this case.
Yes.
I think if you just take an voting, how many people, I don't know, this actually that fanatic radialist only will do with a 6 French. No.
You can take, you can.
Okay. Then it is, no. Some of the people we actually now slender sheet is not there,
Yeah.
so there's all problems. You know why it is not? We
No,
should be
it was not the 6 French alone, sir. The support offered by the radial was not enough. Not enough. Not enough. Probably if it was an elective procedure, would have gone femoral, 7 French, no questions.
No, but you can still change. No, after the angiogram, we can still change. What?
No, at that point, didn't think about it, sir. We thought we will go ahead. And we didn't anticipate the subsequent drama at that point. then we, with that NC balloon to NC balloon, we produced the dissection. Now the strategy is clear. It is two-strand. And looking at the angulation and 6 French.
Now imaging at some stage.
Pardon?
Imaging.
No, not done at that time.
Oh.
Not done, sir. So we produced, even though it appeared simple here, sir, every step was taking time with bad support, everything. So we were also like doing a tough time there. Then now the strategy is clear. 6 French, you are going with the DK crush. Provisional you can't do because already we dissected.
But Abhilash, why not imaging?
No, it was not done at that point, sir.
And then
he was having pain with the with the diagonal dissection. Again, he is not a fully infected person. He came with the Wellens sign with rest pains.
No, when you have a complex bifurcation here, especially when you had a fibrotic lesion and you had difficulty getting this, I mean, it's always good to know what the sizes is, because you have to have a good job.
Yes.
So if possible, I mean, you should have imaging at the stage, whether it's OCT,
moreover, a Dimitri flow here with a minimal pain, you can take an IVS catheter and finish it off in 1 minute, one imaging, just to understand what is the size of the vessel, that's all.
Yeah, but it was not done, sir. Yeah. Then
Madhu, will you do an imaging in this case?
Definitely would do, especially if it's an important person. I 100% would do.
Yes, sir. Agreed.
One more. Do you always work in this view, or is this your favorite?
No. I have selected some of the.
High radiation view. High radiation.
Sir, it had some 30-50 loops. I selected a few which demonstrate the vessels and overlaps. So 6 French, sir, and ostium has to be anyway 2-stent strategy and 6 French sheath.
Two things actually. No, two things.
Yeah.
SKS not
two stents cannot
actually that is actually even Samin K. Sharma stopped it. SKS is actually named as simultaneous kissing stenting introduced by Samin K. Sharma. SKS by SKS. That is what I tell, and that he also stopped now.
2 stents cannot.
SKS, two things actually. Like if you don't have a slender, you can go sheathless with a 7 French. The other thing is you can do step crush.
Yeah.
That can also do. You did not do DK crush. You can do step crush. That will have lesser steps.
Yeah. So
actually, Arun wanted to reduce the steps. He wanted to be perfect.
So we kept the balloon across as the routine precaution, and then then we removed the wire to avoid wire entrapment.
What is the size of the stain?
It was 2.25, deployed around 2.4. 2.25 size stent. 2.25. Around 2.3.
Before taking the wire, actually, did you do an injection to see that the distal to the stent, anything is there or not? I always do that because when you put a stent into the side branch, take an injection, the distal to the stent, any dissection or anything is, you are not doing an imaging, but you should take an injection to see that distal to the stent, anything is done or not.
Sir, it was done. It was done. There was no distal dissection.
Abhilash, 1 minute. Madhu, the sizing of the stent, would you have gone for a larger size stent in the side branch?
Yeah, because this looked like almost 2.75. I mean, from the first view.
You take a 3 or not? That is what he wants.
No, I would have definitely. I mean, that's why I said imaging, because here it's all guessing. So when you have a thing, I mean, imaging really makes things much better. And 2.25,
Imaging is done less than 6% of the interventions in the country.
But we have
And wire was removed from the side and did the first crush. And after the first crush, it's time for the initial recross. even though there are some recommendation to do a pot at this point, I routinely don't do the pot here because there is no proximal metal. I just recrossed. Assuming that because the LED was dilated with a 2.75 balloon, I assumed that there will be enough lumen there.
Back and dilate the side branch balloon after the stenting.
Yeah.
Back and optimize the side branch.
Optimize the side branch. I have selected only a few slides. Then recross. It was crossed, as we know, for decay crush. Everyone accepts that has to be proximal. I am coming to the core part of the problem. When I cross proximal, non-distal. Yeah. Why it has become non-distal from proximal is the core of this talk. Proximal versus distal. I think I cross proximally. And which wire was another thing?
Can you show the wire showing that it is proximal?
Sir, I can only play
No,
it.
but that is actually the core of the presentation, you know.
Sir, I will show you what happened after that. Which wire? I tried with the same wire, which took some time to cross. Maybe if it is taking time, one suggestion from me is to use a polymer wire, fielder FC or something. It is much easier to cross with a new wire. Then I did the first case also. Everything went smooth like a decay crush. Standard procedure. The problem started after that.
Abhilash will stop.
Yeah.
So Madhu, what do you think would have happened? Yeah.
Again,
What would have
anticipating, I am going to...
Because the stent of the balloon cannot be tracked to the main branch.
Yeah. Nothing goes to the main branch.
Yes. Yeah. Madhu, mic closer.
This is a 3.5 vessel. You're crushed with a 2.5.
2.75.
2.75. Yeah. We crush with a 2.75. It will be only partly crushed.
Correct.
In the second wire, when you're crossing, it would have gone in between the two layers of the stain. And when you kiss...
No, this wire was never taken out, sir. I am telling about the LED wire. That was never taken out.
No, LED wire is there. When you're wiring the second time going into the diagonal, that would go in between the layers of the stain.
Yeah.
And when you do the crush, that would open up. So the wire is there in the LED, but this stain is protruding into the LED. And nothing will go in. This is the problem with the decay crush. When you have a decay crush, you have to crush the stain properly. If the stain is not crushed, nothing will go in. You have to take out the wire, go in and make it into a culotte.
Yeah.
That is the only thing you can do here.
Madhu, also, do you think it's because just the stent is not adequately crushed, or is it because it's too far? It's a combination of the two.
More protrusion.
More protrusion into the main vessel, plus an inadequate crushing of the...
Now, inadequate crush, which is now opened up, and this is now protruding into the left. You can imagine the stain is just going from the LED into the diagonal. You have a wire by the side of it, but the stain is protruding in. Now nothing will go into the LED because this protruding into the LED.
Yeah.
That is the only reason that they are telling that two crush is ideal, and that's a pot crush to be done for making a. That is always actually the decay crush tells that if the person does not have time, if the person does not have expertise, better not to do decay crush, just do a tap stand and come out. I'm just telling you should spend some time for these cases. Decay crush is, I think always bifurcation standing takes more time than CTO.
I think Madhu had shown
yes,
a case.
Say, because this happens so many, and you in every conference you have this, and they say nothing is going into the LED. Now I use the guide cylinder. Now I use the guideline. But this is because the stain is not crushed, and it happens.
Madhu learned hard times, so you also.
We also learned it the hard way. Yeah.
Sir, why you want to change to Madhu sir? Rajesh here, sir. Why you want to change to culotte? We can pull out the wire now, and then take a 3.5 stent, size it to the proximal LED and crush it, sir.
Sorry.
We can pull out the wire now.
From where?
Now that he has already done this.
Yes.
We can pull out the wire from the diagonal.
From the diagonal.
Yeah, and take a 3.5 balloon into the LED and crush it with a 3.5.
Nothing is crossing, Rajesh. The problem is nothing goes to LED.
Nothing will go into the LED.
The one point against it has gone through side is everything goes easily into the diagonal. So the wire was not going through the sides. I have another postulate after looking at the fluoro. This is because entry into diagonal was not an issue. If it was gone through the sides, entry into the diagonal should have been a problem. This what we learned from the fluoro. So the crush, this was the initial crush. We got a, say, it was optimized to the distal vessel. I thought at that time it was 2.75 at that point, used and a crush. Then I crossed proximally, opening up a neocarina, because I crossed two proximally. It should be non-distal, maybe only if it was distal, we don't cross distally because our concern is exposing the carina. So we don't want a very distal one, but non-distal, slightly proximal would be ideal in a decay crush. That is the point I wanted to stress on this presentation. So I crossed significantly proximal. Then I told you I have very poor guide support. I tried to push the stent into the LAD. It pushed the neocarina into the main branch. Because until then, it was easy to go. The balloon was there.
No. I think this is not correct, Abhilash. Now, what happened is, can I have a pointer?
Yeah.
See, can I tell one? See, Abhilash, what you have shown is actually distal, no? That wire crossing. You are all along telling that it should be non.
Sir, I crossed here. This only graphical representation share that once I open up from here, this much neocarina is formed if you cross proximally.
No, it's because this is not what happened. Here, you have a stent here.
Yeah.
You have the second wire has gone in between this. So this part has gone towards us. So you have one part here. It's not here. There's nothing crushed here. There's one part here, and the other part is protruding into the LAD. So you can go take anything into the diagonal, but nothing will go into the LAD because this stent is open now.
Yeah.
So it is not the proximal or the distal. It is the stent which is opened up and that protruding into the LAD.
Okay, sir. And
I think in this case, like when you want to do only one crush. Yeah. When you want to do, say, decay crush, the issue happens because you are sizing your balloon to the distal vessel.
Yeah.
Either you do two crush, as Pratap sir said,
Yeah.
do a pod crush. So if you want to do only one crush, preferably put the balloon at the carina and do a pod crush only. Because your purpose is to crush the protruding stent and it has to be sized to the proximal.
yeah, that is what I also want to stress. Before attempting a recross,
Pod crush is important, but
yeah,
you have
before, that's what, before, yeah, before attempting,
no, because again, Arun, because if you do just a pod crush, there would be something within there, and that would be again protruding into the LAD, into the main vessel. You have to make sure that nothing is going into the LAD. It has to be the pod crush, definitely, but when you have the pod crush, it cannot be exactly the pot at the carina, but there might be something which is protruding into the main vessel. So you crush, make sure that nothing is into the main vessel in the distal part, and the pod crush to make sure that this doesn't happen.
Yes, sir. Yes, sir. Like what Arun has mentioned, even I feel, Arun, when you do a pod crush, the problem with a pod crush is there is a small chance that your balloon can melon seat proximally, then you would find it very difficult to get another balloon distally. So when we try doing this, we always take a longer balloon, never an 8 mm or a 10 millimeter, because it can either proximally or distally it can melon seat. So we take at least 12 or 15 millimeter balloon, size it for the distal balloon, always, because with the decay crush you can always encounter challenges, problems, troubles, and also always take two-step crush. The first one, a long balloon so that it doesn't melon seat, a 12 or 15 millimeter, match it for the distal vessel size. Then the second one, probably a much bigger one, a 4.5, because we've had a lot of, even during live cases, 3 hours we had struggled with decay crush. So it's always better try all modifications of crush. See, it's not the classical decay crush. The later on modifications like two-step crush is always better. One distal, then proximal, and then probably that.
Well, actually, Deepak, even if you're an 8 millimeter balloon, your balloon placement is the most important.
Correct. It has to be just proximal to the
should be
carina.
Not in the pot alone. You should actually keep little more distally.
Distal.
Inflate first. Then you take the same balloon, pull back, and dilate at a high pressure.
True,
That actually Arun was telling, even a single balloon can do the pod crush as well as the crush, but with the same balloon. But you should, as Deepak told, it should not be too proximal, then you may not be able to take it out. But you should actually, both the distal as well as the proximal should be crushed.
Yeah. In hindsight, I should have completely crushed it by a pot balloon, keeping the balloon as such suggested, somewhere just proximal to it, so that this neocarina, which I assume it was, to be onto the side. Then, luckily for us, a 1 into 5 balloon cross. Subsequently, it was all straightforward decay crush. I will go faster because there is nothing new. Serially dilated, distally stent was tracked. This time also I will tell you why the grade liner was hard to be taken, because the stent again was difficult to track. I didn't want the whole drama to repeat again. So I used a guide liner. With guide liner support, it went in without drama. No, serially dilated, sir. Serially dilated. So not one balloon. Then strut opening was done, distal optimization was, and nothing. This subsequently everything was standard decay crush. Second kiss was done. This also I struggled because the 6 French sheath with poor support, tracking a 2. I wanted to track a 2.5 balloon into it. It was very difficult to track. I strongly recommend a 7 French and a femoral.
It is difficult to track here because the stent is distorted. If you had done imaging, you would have found the whole stent crumpled in the diagonal.
I will show it, sir.
2.25.
2.25 deployed at 2.4. That was around 16, sir.
That is why actually I've taken nearly 6 millimeter into the main vessel, almost 6 or 4 millimeters inside the main.
Yeah, but we have some 7 millimeter to cover distally, sir. Dissected region. Yes, sir. Okay. So this is the result finally. If you carefully observe, you can see the folded, that neocarina thing is gone into the upper portion. It has gone upper portion. It was here with dilatation, serial dilatation, it folded to become the upper portion. You can see it when it is not playing. It has gone up to that side. Gone up to that side. Neocarina was pushed up. And this was the final.
Rather than the neocarina, it's the extra length of stent that was protruding into the proximal main vessel that is crushed over there.
Yeah, now 2 layers have come there, sir. That's why it is becoming very prominent there. Yeah.
See, that's what Pratap sir. See, you had almost 6 millimeter proximal into the main vessel, so that's crushed over there, making us feel as if there is something extra opacity over there.
Almost similar case was shown in yesterday's Vinay Kumar's case. Almost similar in that level.
Okay, that is it, sir. Take home for me was non-distal. Rather than proximal, for me it is non-distal. Do pot prior year. I don't routinely do it, but I think very first recross, it's a good practice to do a pot. Because since there is no proximal metal, we generally may not do it. In crush technique, a non-distal stent is used for initial. Be careful about protrusion in the main branch, or as sir told, like deforming the stent. Thank you.
Actually, Madhu, even if the imaging was done, this will not make a change. Actually, you are protruding the stent to the proximal
Imaging. A few things here. Like if you look at the last slide, can you put the last slide? You can still see that the diagonal is still undersized. You have taken a 2.5 balloon. It's a 2.75 vessel at least, 2.753. If you had done as per the October trial, I mean, if you had done the OCT, you would have found that this wiring is not correct. You wouldn't have gone ahead with everything because you have supposed to do a OCT or an imaging after each rewiring. If you had done the rewiring, you would have found that it has gone in between the 2 layers of the stents. You wouldn't have dilated there. You dilated the stent, and that stent is all mangled up, which is lying on top of there. And it is undersized, and if the patient doesn't come back,
let's see. So, 3 months back I did
Well,
this.
basically, you know, weakness to the side branch without affecting the main branch with a minimal flow to the side branch. The patient may not come back, and you will be happy, we will be happy.
Yeah.
Madhu,
Thing
also-
is that the stent is 3 millimeter. You compare the 3 to the size of this. It's not 2.743 diagonal.
Yeah, Abhinash. So, Madhu, one thing more. See, for your thoughts on that. See, when you have a 3 millimeter side branch stent, and you know what the cell size is, how many struts will be across the side branch ostium? So we always talk about distal cross or a so how many struts can theoretically be there? Because it's a 3, if it's a 2.5, it is 6.25.
Here, the whole thing about the proximal distal is that's probably not the reason why this happened.
Definitely not.
Now, when you're talking about a proximal or a non-distal cross for the decay crush, it's only because if you go all the way distally and you crush it, then that stent will come into the diagonal. For example, if the LED diagonal, it will come into the diagonal, and there'll be an area of the diagonal without a stent. It's only for that reason you say it should be non-distal, so that there'll be at least some stent on all sides of the diagonal. It's only for that reason. Now, between you asked whether it's distal cross versus non-distal cross, I
I think actually
I
there
think
was
it's too much of hype on the, because sometimes it is by sheer chance
Yes.
that you have two struts across.
Actually,
Otherwise,
Ashish, there was a Tejas Patel was actually going to present a paper. He's almost on the paper. 100 cases he has done. He is telling proximal and distal cross. There is no difference in the outcome. And now he has done a follow-up angiogram of 50 patients. And he is telling this is actually bullshitting by the foreigners and making you confused about the distal and proximal crossing. No difference. You cross and do the work rather than proximal, distal. See, looking at the OCT, making 10 runs, destroying your time. Don't do. But you cross. You should not have a tough situation like this. You crush and make the way opened up for the stent.
Deepak certainly won't agree to this, but again, if
Deepak will not agree, but after the paper, the Deepak also will show Tejas Patel's paper.
I'll just one sec. There's one PCR and Jean Fajadi, he was doing a case, and so someone was asking about the proximal cross versus distal cross. His words: "I'm doing angioplasty for last 30 years. If I'm able to get into a side branch, I think it's good. But it's a proximal or distal, I really don't care."
Sir, I would also agree with Pradap, sir. Doing so many OCTs in these sort of side branches, you would just see one strut across the side branch. You can either go proximal to that strut, proximal cell, or a distal cell. And again, doing left main bifurcation, we have deliberately taken the wire through the more proximal cells. The balloon wouldn't go in. Take another wire, go through the distal cell, the balloon goes in. Those things also do happen in the patient too well. So probably ultimately at the end of the day, Tejas sir's paper would
Tejas is
be
actually
ideal
telling
for-
everywhere. Actually, now Tejas is telling, I will show this paper and make you understand that it is a waste of time. And I don't know whether that after seeing the paper we'll see, and he is going to publish the paper with angiogram follow-up. That's what is important.
I think we had that. I never do that. I never do that. But I tried doing that in a live case when I was doing it, and it went to the same branch. And I just said, "It's okay."
No, Madhu, I have done many times because actually any of my colleagues telling that, sir, it is proximal, can you just cross? I take the wire. And I'm telling you that people will not accept. None of the time. I had any problem of recrossing to the side. I will draw. No, I will draw. I demonstrate. I just wanted to show people. Actually, in a one live case, they told, can you take the wire? That fellow, that TCT, they told 10 seconds I recrossed and told. Actually, this is actually, if you that good crush, and you have a good space, the wire will go inside.
I think we had an excellent discussion. Thanks, Abhilash. It's a very nice case. Thanks, everyone. All the presenters are very good. Thank you. Thanks, Ashish sir.
Thank you, speakers and
Thank you.
chairpersons, for a very educative session on bifurcation stenting. We now move on to the next session, left main coronary artery interventions, the journey. I request the chairpersons, Dr. K.U. Natarajan, Dr. Rajiv C., and Dr. Venugopal to please come on to the dais. Over to the chairpersons.
Respected, good morning. Before Rajesh starts his talk, as an old timer, when we started angioplasty, left main was persona non grata for the interventional cardiologist. The moment you find left main, it goes to the surgeon. The first paper on left main intervention started with Park from Korea. He was the first person to introduced the concept. Even the Westerners didn't touch left main till Park published his landmark article from Asan University, Korea. That turned the tide in front of interventionalists going into the left main. And I'm extremely happy to sit here because I'm probably one of the oldest guys sitting here, because this is a Amrita old, it takes me back to my old Amrita days when Rajesh, Rajiv, Natran, all were, I was working with them as my colleagues and friends. So with this introduction, let us see what Dr. Rajesh has to tell us about the interventions in left main, the past, the present, and the future. Over to Rajesh, please.
Thank you, sir. It's a great honor to be standing here to be presenting this data on left main interventions from our institute. I want to thank Dr. Pratap Kumar, Dr. Ashish, Dr. Abhilash for the opportunity. Let me take you all back 25 years before, in December 1999, when a 43-year-old young man with diabetes presents with an ACS. An angiogram showed a critical ostial stenosis of the LAD. He underwent a PTCS stenting of LMC to LAD, and this was the hardware used, 0-4 choice intermediate wire. The lesion was pre-dilated with a 3x15 Maxim balloon, and was stented with a hand-crimped Proling stent on a 3x15 millimeter balloon. The result was good, as you see here. The patient had a good outcome, and he was doing well for last 21 years. And he comes back with a recurrence of in-stent restenosis of the LMCS stent, and he underwent a repeat procedure, that is in 2020, is doing well for the last 25 years. If you look at the evolution of left main PC over the last 25 years, there's been significant technological advances. Intravascular imaging has been the highlight. It has significantly impacted the way left main PC has done over the last 25 years. Not only it helps you optimizing your stent outcomes, it helps you identify dissections and hematomas which cannot be identified by the naked eye most often. A stepwise provisional approach is the rule these days, as was shown in the EBC main study which was published recently. And drug-eluting balloons also have been significant technological advances in treating patients with left main bifurcation disease. If you look at the technological advances, guiding catheters have become more friendly. We have 7 French guiding catheters can be taken to radial axis by using sheathless or a slender sheath. Guide extensions have been very useful, which is not available in the yesteryears. Double human catheters, we found it pretty useful when you're having angulated circumflex, and crossing angulated circumflex can be useful with the Crusade double human catheters. Wire technology has advanced considerably. The smaller profile balloons helps us cross critical stenosis more easily, and high pressure balloons like OPN has made a difference. The pod balloon is also very useful in certain situations. Not only helps you land the distal carina and prevents and reduces the risk of side branch distortion. Calcium modifying technology like rotablation, orbital atherectomy, cutting balloons, and Schofield lithotripsy, which is a disruptive technology, has significantly impacted the way people are treating left mains these days. This is an example of a pod balloon. Normal balloons have a shoulder length of 3.2, but this pod balloon has a shoulder length of 0.6, helps you position it exactly at the carina and prevents vessel injury when you're doing the complex distal left main bifurcation disease. Well, as I mentioned before, imaging has significantly impacted the way left main PCI is done these days. It still remains a 2A, a level evidence B indication as far as left main PCI is concerned. Yesterday we had a wonderful debate comparing I versus OCT. I believe both these technologies should be used in almost all patients when you're treating left main PCI. Again, stent technology advanced considerably. You have an example of an Ultimaster 2.25 stent, which can go up to 4.5. So when you have significant disparity between the main vessel and the daughter vessels, having a stent technology which can go up to as high as 4.5 and distally 2.25 vessel, it makes it a lot easier. And it's important that a person who does left main PCI has adequate knowledge of stent expansion sizes before they address complex distal left main bifurcation disease. I'm here to present the data of our institute. We've done about 389 left main PCIs over the last 25 years. After excluding primary PTCAs to LMCA for 28 patients, iatrogenic LMCA dissections in 10 patients, a protected LMCA in 64 patients, a traumatic LMCA dissection in 1 patient, arteritis in 1 patient, and aborted PCI in 2 patients. We have unprotected left main PCI in 283 patients. The presentation was chronic stable angina in majority of patients. Patients who present acute coronary syndrome, unstable angina in 28 patients, and STEMI in 51, and STEMI in 32 patients. The person who actually started this saga was the late Professor Icck Haridas, and this presentation actually dedicated to him. This passion for driving left main interventions in the early years when it's considered taboo to do left main PCIs, this man single-handedly started this process, and here we are here to present this data. The left main PCI, if you look at the etiological distribution, elective PCIs were 90%, primary PTCAs 7%, and iatrogenic LMCA dissection 3%. The majority of were unprotected LMCAs. Protected LMCAs were only in 17% of patients. If you look at the mode of presentation, majority of patients had stable angina, and the patients who presented acute coronary syndrome, about 18% had non-ST elevation MI, 10% unstable angina, and 11% a recent ST elevation MI. This is an example of a traumatic LMCA dissection, a young man who presented with a road traffic accident, and it is the dissection of the left main, and he underwent a successful stenting by Dr. Prakash Kamath at PI, and the patient is doing well for the last 21 years. This is an example of a young lady who was a proven case of Takayasu's arthritis. She presented with chest pain and a critical osteal stenosis of the LMCA, just treated with a stent, and the patient is doing well for the last so many years. What about the use of mechanical circulatory support in the elective patients? 97% of them did not need an MCS, and a handful of them did require an intra-aortic balloon pump, and 1 patient had to be converted to an ECMO machine. Look at the risk factor distribution, more or less equal, all these groups. If you look at the location of the lesion, majority of patients had a left main bifurcation disease, 75%, and the second followed by the osteal, and the rest were the shaft lesions. This is surprising because initially we started with osteal disease and shaft lesions, subsequently we migrated to bifurcation disease, which was quite complex, and it's heartening to show that majority of them had left main bifurcation disease. What was the stenting strategy used? The provisional stepwise approach was the most preferred strategy. A two-stent strategy was used in 17% of patients. What was the technique of bifurcation? It was predominantly culottes, a mini crush followed, and DK crush was not that popular in those days. If you look at the penetration of imaging, this is the drawback of our registry. Only a handful of patients had imaging predominantly by OCT and rest by IVAS. If you look at the procedural outcomes in the elective PCI arm, procedural success was 99%. 6 patients developed hypotension, of which 4 patients were put on intra-aortic balloon pump, and 1 patient had a VA ECMO support. 11 patients required mechanical ventilator support, with 4 patients developing pulmonary edema during the procedure. 1 patient had aborted cardiac arrest. In-hospital mortality was 1.41%. If you look at the primary PCI left matrix, example of a young man who presented with a acute anterior wall ST elevation MI. He had a total occlusion of the mid-LAD, a proximal LAD, and a critical stenosis of the osteal circumflex. This is treated, both regions were wired, predilatation with 2.5 15 NC balloon, and 1 stent was placed in the osteal circumflex, and the long stent was placed across from the LMCA into the LAD. It was, the circumflex stent was expanded first, followed by LMCA stent, and the rewiring of the circumflex was done, and then a predilatation of 2 balloon, a final kissing balloon, and a final port. This is the outcome, and the patient did well in an acute ST elevation of anterior wall MI situation. If you look at the data of primary PTCA in our series, 28 patients underwent primary PCA to LMCA, 3 patients underwent PTCA for LMCA procedure-related dissection, 1 patient had a protected LMCA, and 1 patient underwent emergent bypass surgery. Mean age of patients was 63 years, 78% of patients were men, 22% were women, 60% were diabetics. 10 patients had cardiogenic shock during presentation, 5 patients had pulmonary edema, and 30 patients had severe systolic dysfunction, time of presentation by echo. Among 23 patients underwent primary PTCA to LMCA, 8 patients had in-hospital mortality of 35%, 48% acute kidney injury, 4 patients required intra-aortic balloon support, 9 patients required mechanical ventilation. Significant correlation was seen between in-hospital mortality and cardiogenic shock, severe LV dysfunction, and the need for intra-aortic balloon support. 68% of patients with LMC bifurcation lesion had in-hospital mortality. So the in-hospital mortality in the primary PCI series in the left main was 35%, and patients who had a distal left main bifurcation did not do well compared to patients who had an ostial and staph lesions. Some simple tips and tricks when you're dealing with ostial lesions: select good guiding catheters, sometimes prefer side holes, use additional wire as an extra support wire. Critical ostial lesions might require ultra-low profile balloons for dilatation. Cutting balloons is the rule in patients you're treating LMC ostial lesions, and few millimeter projection of the ostium, preferred flaring of the ostium required, balloon pull back, and select a stent with good radial strength and less longitudinal deformation. The example of a 67-year-old female with a critical ostial stenosis, the LMCA, was actually referred for surgery. It was treated with bifurcation disease and initially dilated the NC nano balloon, followed by a 2.12 NC balloon, significant recoil, treated with the cutting balloon in the ostium, a 412 onyx stent in the ostium, and post-dilated the 4.58 NC balloon. This was the final result. This is a patient doing well on long-term follow-up. So among patients with LMC ostial or staph disease, the 1.3% in hospital mortality, 4 patients were lost to follow-up. All-cause mortality and mean follow-up period of nearly 5 years was 14.7%. 2.7% patients underwent target vessel revascularization, and 1.3% underwent target lesion revascularization. The 1 year, 3 year, and 5 year survival rates were 98%, 95%, and 90.6% respectively. Among 27 eligible patients who were eligible for a 10-year follow-up, only 50% of patients were available for follow-up with a survival rate of 71.4%. Another example of a young man who was treated with the LAD ostial standing other institute. The patient, somehow they could not cross into the circumflex ostial lesion. He was referred to our institute. The patient was treated with a 1.25 and 15 balloon initially, and subsequently treated with a 3 to 15 drug-eluting balloon. And the final result was good. We left it at this. Patient is doing well on a long-term follow-up. This essentially shows the utility of using a drug-eluting balloon when you have isolated ostial lesions of the circumflex. Another elderly lady who presented with a catastrophic acute pulmonary edema. She had a previously LMCA LAD stent implanted. The patient was put on an intra-aortic balloon pump and treated initially with a 3 to 15 NC balloon, followed by multiple dilatations with high-profile balloons, and a cutting balloon on the distal mid-LAD lesion, and a cutting balloon on the ostial LMCA and the shaft of the LMCA. And the final result was good. Patient did well on long-term follow-up. So this is another example of how imaging has significantly impacted the way we treat LMCA patients. This is a patient with diabetes, long-standing with renal failure, a GEGFR of 8, who presented with acute LVF, treated, stabilized, and subsequently was taken up for an intervention. This was an angiogram showing a critical ostial disease of the LAD and a significant disease of a very dominant circumflex. Patient was treated with an ultra-low contrast angiogram. No angiogram was used during the procedure. With IVA's guidance, we could do a great job, and the patient did well on long-term follow-up. This is the IVA studies. We could exactly determine the distal landing zone, the size of the stent exactly, and then position the stent without the use of a single drop of contrast. This is LAD. I was, again, because short of the time, I have to rush through these images. The patient had significant calcification, was treated with shock wave lithotripsy in the LAD and the left main, and subsequently a long stent was deployed from the LMCA to circumflex, and then the LAD lesion was recrossed, pot was done, and this was the final outcome. There was some distortion of the LMCA stent, which required another stent to be placed from the LMCA, from the ostium to the proximal LMCA. This is the final result. There was some under expansion of the LAD stent. This is just about 5 ml of contrast for the entire procedure. Just imagine when you're doing such complex lesions in a patient with dysfunction, with renal failure, how intraocular imaging has significantly made it easier for us to use this to finish this procedure. If we look at the results of bifurcation lesions, distal LMC bifurcation, around 212 patients, 1.4% hospital mortality, 5 patients were lost to follow-up, mean follow-up period of about 6 years, the all-cause mortality was 12%, 9%, 8% underwent TLR, and 1% underwent TVR. 1.5% underwent TLR, and the 1 year, 3 year, and 5 year survival rates were 96%, 91%, 90.8% respectively. The 10-year follow-up was about nearly about 20%, and the year's survival rate was about 70%. Just to conclude, technological advances have improved the outcomes of left main PCI. Intravascular imaging is highly recommended left main PCI. A stepwise provisional approach is still the preferred strategy. I was fortunate to get a presentation of Dr. K.K. Haridas, who was a single man who actually proposed and started this whole process of saga of left main interventions. He's the first person to do LMC interventions in our country. This is his presentation.
And reduce TLR.
Can I have sound here?
Technique of left main stenting. I'm not going to touch into the details, but I'll probably give you some of my viewpoints. And what I'm basing my talk on is the experience of about 300 left mains. This is the registry. I'm not going into the details for want of time because we are already late. If you really see that majority of the lesions of the left main occur, this is an operator driven, and we were doing mainly ostium and shafts in the years. We do more of distal left mains. Almost 2/3 of the cases of left main stenting are done in the bifurcations rather than the ostium, or maybe more, and the shaft. This was the distribution of some of the techniques that we used, and this is the follow-up results of the registry from the Amrita Institute. And what you see on the red, this strip is what was lost to follow-up. We had a 95% follow-up, which is pretty good for any data. If you look at the...
I'll just stop short because short of time. Just want a brief description of the late Professor K.K. Haridas, one of the earliest cardiologists in India to start coronary angioplasty and allied interventions, left main PCI and CTO and saphenous vein graft intervention in our country. He has such a passion for doing CTOs. There's been instances where he used to sit on, he had designed a specific chair for him to sit for long hours to perform CTO angioplasties. In those times, the hardware available was very crude. We just had one Shinobi wire to cross very complex CTOs, and it used to spend hours and hours doing complex CTO interventions. The first operators to perform intracoronary stenting in India, the first to perform carotid stenting in southern India, the first in India to be accredited to perform directional atherectomy and rotablation. I have seen him performing a patient who had a pseudoaneurysm of carotid artery in both carotids, and he had performed it beautifully. He was the first to perform the amplifier device closure acquired VSR following a elevation MI in India. And he is the largest series, I think after Pratap, is the second largest series of left main PCI in India. And at those years, he had organized an imaging workshop with a group from Netherlands, where Dr. Wellens was part of this group, and he had the foresight to start an imaging program as early as 2006 in our country. He was also had a passion for radial access interventions. This is Dr. Shigeru Saito inaugurating the first Amrita Transradial Summit. He was awarded the FRCP in 2010. Unfortunately, he was with us no more. He passed away 10 years ago with a brief, long disease, the cirrhosis of liver, which he ultimately succumbed after a liver transplant. What are the qualities which stood out? Late Dr. Haridas was hard work, courage, and to do what others have not done in the past. The left main intervention is the example of where he had the first pioneer to start left main intervention in our country. In calmness and difficult situations, there have been a couple of instances where he has bailed me out when I had a crash during a procedure. His most commonly noted words was not to worry. He would make us the operators at ease, and he would bail us out of complex procedures. The findings, he had a great dexterity of his hands. His hands were so good. And when you are doing a procedure, you hardly see blood spilling out on the floor, like most of us would do. We would see the entire floor would be full of blood. An outstanding teacher, many of his students would attribute his teaching skills, excellent communicator as to his patients and to the cardiology community in general. As a mark of respect, the patients have formed a K.K. Haridas, late Dr. Haridas Foundation. Every year, Dr. Venugopal is one of the starters of this foundation. And every year they assemble during his death anniversary, conduct a camp, and treat a lot of patients with free of cost. And this is the amount of affection his patients had for him is a mark of respect for this great man. I just want to conclude with a quote by Ralph Waldo Emerson. Do not go where the path may lead. Go instead where there's no path and leave a trail. And I'm sure Dr. Haridas has left a trail for all the younger cardiologists to follow. Thank you so much for your attention.
Thank you, Rajesh. I think it's the right stage to remember a person like Dr. K.K. Haridas. He was one of the pioneer interventional cardiologists in the state. He started his career in cardiology along with me in Alleppey Medical College. Then he left to Coimbatore, and then he joined Dr. Cherian's team, Vijaya Heart Foundation. And from there, he came to Amrita to head the Department of Cardiology. So I had a very, very close association with KKH, as we used to call him. We used to call him as KKH, not as Haridas. And the qualities that you have already highlighted, for the younger generation, you should remember that whatever things that we do today are all being done earlier with hardships, very crude materials, and they developed this technique. So there is a saying that you stand on the shoulders of great men who have passed by. So it's very opportune for us to remember Dr. Haridas in this forum. And he was also the first person to conduct the NIC meeting in Kerala in Cochin. The first NIC meeting in Kerala, he was the organizing secretary, and Dr. Anil Kumar was the president of the CSA at that time. We still remember in Taj Malabar, we all held together. Any comments?
Yeah, what you said about Haridas is very correct. He, in fact, was like, what is Kapil Dev to Indian cricket is he to Kerala interventional cardiology. Because in 1998, when he came to Amrita, there were only few centers, Chitra and Medical Trust and SUT, I think. And Chitra, again, being a government setup at that time, he will do maybe 8 or 10 cases per day and stop at 5 o'clock. But he completely changed the attitude because there is no waiting list. The case stops when the last case is over, which was commonly 4:30 in the morning every day. So that I used to have 2 cath labs simultaneous days. So on the third day, many times I will be sleeping with the steth in front of the patients. Once I could not recognize Natarajan when he came back in the morning because I was so sleepy. So that was the culture that he set, and he set a pattern for everything. Everybody obeyed him, right from the sweeper to top cardiologist. Because that is not, he's doing it himself. He's coming at 7 in the morning, going at 2 or 3 in the morning. So he will say 9 o'clock, Rajiv, I'm going home. There are 5 or 6 angioplasties, you do. But when I go home at 4 o'clock, he's still in the carpool. He's not got into the car. So that was the amount of hard work that he was doing. And he was very intense and fiercely competitive. And it is common practice to have a case. Suppose they call a lot of foreign operators. Then after they go, some of the cases fail. Then he used to sit and then make it successful. That is something which gave him a very high, especially for CTOs. And I was wondering, this anti-grade CTO success is unbelievable if I remember it now. Because of perseverance, and he has that 3D view. You didn't have OCT, all those things, but he had that mental 3D. So anti-grade CTO success was tremendous that time. So there are a lot of good qualities, and he was from the outside he looked very tough, but Natarajan will know in close communications is very simple, a very happy person, and will be happy to have some interesting stories, gossips, everything. So he like that also. And to the patient's communication, as Rajesh said, communication is a top class communicator. So he is comfortable, equally comfortable with the highest, topmost cardiologist in the world to the simple, common person. And every patient thought that he is a special, Dr. Haridas is my special patient. He had a special interest in me. So after his death in 2012, September 9, at the age of 54, many of his patients used to come to us. Then every patient used to come and say, I was a special patient of Dr. Haridas. I said, I am hearing it 1,000 times. Because every patient thought that he made every patient feel that they are very important. So I've seen many uneducated, young, and not old persons. Then he'll be asking, Icck enda prayasam. So they will think it's very high. So such a big person is asking, such a humble manner is behaving. So he had that exceptional communication capability. You heard him talk now. So that is not the accent when he talks to somebody else. So this is a foreign crowd. So that is the accent. So that's a very interesting person. And his character also changed over time. He was so-called tough in the initial phases, but then by the end of, say, 2007, 8, he became a very nice and very jovial person. And Natarajan will definitely have some anecdotes to narrate about him.
Running short of time. So I was working for 6 months in Apollo Hospital under Dr. Matthew Samuel before I came to Amrita. I was tired of pressing groins. The day will get over by 6 o'clock, but the last sheath will be removed by 3 a.m. The 9th sheath, all you have to do. He was very particular that angioplasty groins, you only have to press. So I was so sick of pressing. So when Amrita, the opportunity came, I grabbed it and I went there. Then I was talking to Dr. Haridas and he was asking me, what are your demands? And I said, what is the expected salary? And I said, I have no expectations about salary. Only one question I want to ask you. Who will press groins? Who will press groins after angioplasty? Will the operator press, or should the assistant press, or the nurse? Whoever does the angioplasty, they only should press the groin. Then I didn't leave him like that. I said, that means if you do, you will press. Then I said, I suppose so. He has a way of telling. And I didn't leave it at that. I joined. That first angioplasty press thing, no? I was looking for him. Anyway, then he talks in Tamil whenever things go beyond a particular level. Nee pannidupa, right? Anyway, the first left main angioplasty, I think I assisted him in 1999. We were looking for a good case because that time distal left main involving the ostium of the LAD, circumflex and all is very, very difficult. So ostium also is a little tricky. The mid shaft used to be the juicy case to do. And if you remember correct, that is the greatness about Prakash Kamath. So we got a case. If you remember the name of the patient, it was Tangappan or something. And it was a nice laddu lesion in the mid left main. So Kamath, immediately after the angiogram, myself and Kamath, together we went to Dr. Haridas. He was in the OPD and said there is a case. And the next day we did that particular case without any imaging, and a lot of good qualities have already been alluded to. It's a great man and it's a pleasure working with him. Pradap and all has a personal relationship with him. I know that. And anyway, it's a nice tribute to Dr. Haridas, and it's a pleasure that Rajesh spoke so well about him. And some of us even now try to emulate him in whatever little way possible. And Dr. Magesh, he was his first student in Amrita. Right?
Yes,
thank you.
A couple of anecdotes in a minute. See, one patient was waiting overnight fasting till 9 o'clock at night the next day. So he was furious. The nurses came and told that he is running away. I said, I can't manage him. So then I told Haridas, he said, he came down, sat beside him and said, Gopalan, this വളരെ ഡിഫിക്കൽട്ട് കേസാണ് ഗോപാലിൻ്റെ, അത് ഞാൻ തന്നെ ചെയ്യണം, എനിക്കൊരു ആഗ്രഹം ഉണ്ടായിരുന്നു, അതാണ് ഇത്ര താമസിച്ചു, ക്ഷമിക്കണം കേട്ടോ. പുള്ളിയെ ഫുഡ് അത് കഴിഞ്ഞ് കഴിക്കും. ഫുഡ് കഴിച്ചില്ല എന്താ ഒരു മനുഷ്യൻ ഫുഡ് കഴിച്ചില്ലെങ്കിലും കുഴപ്പമില്ല. So that's how difficult situations are made in his favor, that way.
I want to thank Dr. Pratap, Dr. Ashish, and everybody who made this opportunity. Thank you so much.
Thank you, sir. It was a great session. I have an important announcement. Checkout time is 12 noon. I requested the Hyatt management to extend it to even 1 to 2 hours. The answer was it's an automated computer system which won't allow. They will ask us to pay half day. So request is to check out by 12 noon. Requesting all. Check out.
So the next session is on calcium management. The chairpersons for the session are Dr. Arun Gobi, Dr. Deepak Davidson, Dr. Jayesh Bhaskaran, and Dr. Enju Kumar.
Let me request Dr. Arshad to please comment. Start off with the first case, OCT guided orbital atherectomy in calcified lesion with ACS.
Good morning, everyone. And at the outset, thanking Ashish sir for giving this opportunity and Dr. Abhilash for the wonderful arrangement he has made. And the case is about an OCT-guided orbital atherectomy in a calcified lesion with acute coronary syndrome. This was an 83-year-old female diabetic hypertensive who came to our emergency room in the midnight hours, 1 o'clock, if I remember. And she presented with an acute anterior wall MI. And just before getting into the cath lab, her record revealed an ejection fraction of 45%. And her coronary angiography revealed a triple vessel disease, but were densely calcified vessels, especially the LAD. And just by the beginning of the fluoro, you only know that in fact you are the calcium in wait for you, and there was a tramline calcification, especially in the proximal LAD, and that dense calcification in the proximal segment. And coming to the coronary angiography through the right radial route, and there was a suspicion of a left main plaque, and a circumflex ostium has got a mild disease, and the LAD in the proximal segment has got a critical lesion with a TIMI2 flow distally. And the middle lady also got a calcification, and it's a long tubular lesion, and which is probably there is a landing zone which is ending at after the major diagonal. So this moment, we proceeded with a primary angioplasty. It was a right radial route, 6 of extra backup, 3.5 gating catheter. We tried with a 2x10 Riuri balloon, but with our maximum effort, in fact, we could not track the balloon beyond the proximal LAD. And so at the area of the tight lesion, in fact, we could negotiate the balloon into, and we did a balloon dilatation because we really want, because she was in angina, not very severe angina, but she was in angina. So we really want to relieve the angina. And we dilated that area with a 2x10 Riuri balloon. And following which the TIMI3 flow is achieved, and she only told that in fact her pain has subsided. And at this moment, in fact, we do have some concerns, especially there was a left main plaque and distally, and the calcification is definitely creating some trouble, and this is probably a case which is not to be done at the midnight hours, and we thought an ad hoc procedure should not be done in this case, and as she has relieved of the symptoms, we can take some time. And so issues were whether the left main is involved, and for extent of disease and calcium, for which we thought an imaging would be definitely of help in deciding the plan of this case. So this time, in fact, as we have got a, for the better catheter support, because we tried an IVUS also, in fact, during the initial setup, and we tried to pass the IVUS catheter. The catheter was not tracking. So at this moment, we thought a right femoral artery route, because we want imaging, and we cannot do more balloon dilatations also, because the balloon was not tracking in the initial setting. So we did a right femoral artery, and a 7F extra backup guiding catheter was used. And we tried our luck with the OCT, and the OCT catheter, with some negotiation, it could pass. There are 4 areas, in fact, which I would like to draw your attention to. First is a distal landing zone. The dye clearing was not that great, in fact, but still the distal landing zone looks okay. And with a 2.2 is the ml diameter. And coming to the mid LAD part, you can see that there is a significant calcium with the calcium pools and some amount of 180-degree calcification extending to 270 and 360 at some points. And coming to the the proximal LAD, where we did a balloon dilatation, you can see that there is a dissection at the proximal LAD, and with some protruding red thrombus inside. And coming to the left main, you can see the minimum fibrotic plaque in the left main, and a bright with a minimum involvement of the left main. So we thought, in fact, this would be our strategy. So this is about the middle LAD area. The calcium score was 4 with an extensive calcification. MLA, the minimum area was 1.63 millimeters square. And this is the 360 degree of calcium, which could be demonstrated in the mid LAD to proximal, just after the proximal LAD area. And coming to the proximal LAD area, where we did the balloon dilatation, we could see that that nasty dissection, in fact, with irregular margins. And in the central panel, you can see a thrombus. In fact, it's probably a red thrombus, which is protruding into the lumen. And there was no signal, in fact, passing beyond the thrombus, and a very ill-defined margins could be a red thrombus. So our strategy is now very clear. We have to exclude the left main from the bifurcation, intervention, and a calcium modification, preferably by atherectomy at proximal to mid LAD to be done. And we have to exclude the dissected and the thrombotic proximal LAD area from the ablation, because we thought, in fact, an ablation strategy like a rota or orbital atherectomy would be, orbital atherectomy would be a good choice. So we have to exclude the dissected and thrombotic proximal LAD area from the ablation. So stenting is the ideal way to exclude those areas from the ablation. And so we did a 3.8 millimeter balloon dilatation followed by a 3/12 drug-eluting stent post-dilated with a 3.56 NC balloon dilatation. We didn't have much carinal shift, and the circumflux ostium also looking good. And then we started with an orbital atherectomy just at the distal to our previously implanted stent. And this is the Diamondback 360 coronary orbital atherectomy system. We slowly give a forward movement only. And then around 30 minutes we took for the proper ablation. And this was the post-ablation picture after the orbital atherectomy. And you can see multiple scalloping and concavities and cut of the calcium. Even some cuts we could be demonstrated, and it was probably unlike the balloon-induced cutting. It is a very regular borders, not like the balloon-induced dissection. And or a balloon-induced cuts, and which is followed by a 2.5 into 12 NC balloon for the proper dilatation and pre-dilatation, and then the stent being used were 2.75 into 32 drug-eluting stent, and there was some geographical miss, and we did a 2.5 into 13 drug-eluting stent also distally, and the finally we post-dilated with a 3/10 and a 3.5 into 6 NC balloon, and this is the post-OCT image of the final image, and you could see a good expansion, and the MSA, there was no distal stentage dissection, and the MSA was 5.2 millimeters square meter, and approximately it was 6.93, and ostial area it was 7.22 millimeters square. There was some amount of malposition and the mid segment we can notice, but they were very focal and without any under expansion, so we really didn't do much to that. And finally we got came out with a good result. And the present case highlighted the importance of imaging in calcified coronary lesions and highlighted the change in strategy of PTC after imaging. Our strategy is already almost changed a 180-degree. In fact, we really thought for a left main bifurcation stenting initially, and also orbital atherectomy as a calcium modification strategy is ascertained. Thank you so much.
Arshad, extremely well done case. The strategy was good. You had challenges in crossing with the balloon. You decided that you'll just dilate it, get TME3 flow, get the patient out of the crisis. The next day you took up the patient for the procedure. Then you have demonstrated in OCT that the calcium score is quite high, and you made out that there was 360-degree arc of calcification. However, we didn't see any nodular calcification. It was really good. It is identified, and then you again decided that probably you shouldn't be dissecting the proximal LED, so you stented. We're not very sure whether probably that should have been done right from the beginning. Then you went ahead with the orbital atherectomy. Again, proved that you had enough of sanding, enough of fractures. I've been also doing OCT for all my orbital atherectomy cases. I've never seen any fractures till now, but I've seen a lot of sanding. Polishing has been done very clearly, but we saw that there was significant areas of fractures in thin calcified areas. It was very, very clearly demonstrated. And finally, patient also had a very good outcome. It was an extremely well done case.
Thank you, Dr. Deepak. But when you search for the literature, you can see like there are cuts also
Absolutely,
demonstrated.
absolutely. There are two mechanisms wherein you just have sanding and you have the pulsatile. You have the pulsatile forces that can lead on to fractures. I haven't seen fractures till now, but that's an extremely very, very well done case. Very well.
Thank you.
And again, the only challenge that I always feel with orbital, when it comes to heavily calcified lesion, is you mentioned even in this case, it took almost 30 minutes for you to do the orbital atherectomy. So when you have a sick patient, borderline hemodynamics, heavily calcified lesion, probably it's not the ideal situation.
True.
Rota would be a better option. That's what I feel.
Very well taken.
2 points. One, probably, did you consider going for a rota in the first sitting itself when you did POBA? That's one question. Should you have done a rota and finished the case then itself? That's one. Second, you stented the proximal segment. So, how does an orbital atherectomy or rota behave when you go through a stented area?
Yeah, really.
Versus a dissected area.
Absolutely. The first question was regarding the initial setup. Definitely at the midnight hours, in fact, I really don't want to do an ablation at that moment, though the system was ready. Rotational atherectomy was there at that time. And coming to the later stage, in fact, dissection was a thing. We were not aware about the dissection, and only in the OCT, in fact, we could, because otherwise there was no haziness in the proximal LED area after the balloon dilatation, the repeat check shoot. So that moment, in fact, when we stented that, we thought an orbital atherectomy will give a controlled drilling rather than a rather than a rotational atherectomy, and we really don't want to interfere with the stented segment. That area is very much devoid of minimal calcium was there. That area is having, it's more of a fibro-fatty area.
Basically, even if you have a senior operator, many a time you don't get the proper technician and nurse to assist a complex case like that. Agreed.
Any specific advantage of orbital atherectomy in this case over rota?
Probably, sir, controlled atherectomy, more control of operator. It's a slow procedure, in fact. So, because we really don't want to come to the stented segment by the atherectomy. So, just distal, we kept the crown just distal to the stent and did the process. So, it's a very slow, controlled procedure, in fact.
Thank you so much. It was a nice presentation.
Thank you.
Shall we move on to the next one, Dr. Renju?
Going to my case, a case of failed rota. And it's a 75-year-old male. He's hypertensive and diabetic. He first presented in 2017 with an episode of CAD, unstable angina. And that time angiogram showed triple vessel disease and was advised ABG, but he was not done the procedure. And then he had recurrent events in 2019 and 2021. And 2021, he presented with an NSTEMI with an acute LVF, and it was moderate to severe LV systolic dysfunction. And that time we did a repeat CAG, which showed a triple vessel disease with a LAD of proximal 90% lesion and D1 100% and D1 in RC Ramus distribution and RC of 90% lesion. And that time also he was advised CABG, but he has not done the procedure. And the LV function gradually improved over a time. And in March 2022, he again presented with class 3 symptoms. And this time he agreed for a revascularization by PTCA. And he was posted for an angiogram. And this was the angiogram. The left main was okay. And the LCX was relatively disease-free. And the LED shows a proximal and mid segment shows a diffuse 90% stenosis. And the D1, there is an early D1 in Ramus distribution, which was showing a proximal total occlusion with a stump, which is a CTO. And the RCA shows a long segment, 90% stenosis in the proximal and mid segment. And there are some amount of calcium. We thought that we could do the calcium with the balloons because we don't have any imaging facility during this at this point of time. So we proceed with an angioplasty. The plan was PTCA to LAD, D1 and RCA. And the PTCA for RCA was taken up as a first procedure. And we wired JR guide and the Sion blue wire. And the 2 mm balloon was just crossing the proximal lesion, but it is not crossing the mid lesion. And there is a body wire support was taken with BHW wire. And with this body wire, even the 1.5 mm and 1 mm balloon was not crossing the mid segment lesion. So we know that it's a significant calcium which is producing, we have to do some atherectomy procedure to proceed the procedure. So since we thought that we'll do a rotablation, so we put a temporary pacemaker and the wires changed to rota wire. And at 1.5 mm rota burr was used, and 160,000 RPM. The rota wire, there was no problem with the proximal lesion, but the mid lesion was not yielding with repeated attempts and increasing the deep intubation of the guide. The rota could not cross the mid lesion. And meanwhile, after repeated 4 to 5 attempts, the patient started chest pain and he's developing an inferior ST elevation and he's going for hypotension. And by this time, we stopped the rotablation, and the next option the available is either you step down the rota bar 1.5 to 1.25 mm bar, or do an help of a guide extension to go to deep intubation of the guide to get a much more support. But since the patient is going hemodynamically unstable, I stopped the rota. I thought that we will wire the lesion again. The rota wire was kept there and put another coronary wire. And then we took a 2 mm New York balloon, and it is pushed to maximum to the mid RCA lesion, and we go had a high pressure and ruptured the balloon. And this rupture has shown the dissection which has just yielded the lesion. So we could cross with the 2.5 mm balloon, and we just pre-dilated the entire length segment. And then after that, we stented the mid RCA with the first an Onyx 2.75 34 distally, and then by an Onyx 3 into 30 proximally with an overlapping, and then post dilated these segments with the 2.75 and 3 mm balloons with a good result. And this was the final RCA result. And then we proceeded for the left side procedure. And first we wired the CTO D1, and field rexty was failed, and then the lesion was crossed with a Gaia 2. And then pre-dilated the lesions. And the LAD was also wired. And then put a D1 stent. Since the ostium was not involved, even the angiogram was, the D1 ostium was not involved, we thought that leave the ostium and the stent with an Onyx 2.75 into 38 placed, leaving the ostium. And it is stented, post-dilated. Then LAD was pre-dilated. And LAD was stented with a 2.5 into 48 science, and from the ostium of LAD. And the sport was done with a 3 mm balloon. This was the final result. Thank you. This was the case, the complex scenario, and there was a rotablation failure. So even though granuloplasty is not an accepted procedure from the interventional side, but as a bailout procedure, you can consider.
Yeah. Dr. Renjo, the difficulties you have gone through. Just some points actually. The rota was not going through because your guide support was obviously poor. Actually, the guide was kicking out. So probably taking an AL guide would have made the difference. Or as you said, you can de-escalate the burr to a 1.25 burr. That would also have helped you go through. Granuloplasty is actually recommended in a CTO, as Dr. Pradap would say, in balloon non-crossable lesions, and the recommended balloons are actually 1 to 1.2 or 1.2 to 1.5, where you go into into a non-crossable lesion and you burst the balloon and you create microspiral dissections, not with the 2O balloon, intentionally not with the 2O balloon. It can accidentally happen, but 1.2 balloon bursted out, causing micro dissections to create lumen. But again, as above, anything above 2 should not be advocated because there's a small risk of rupture, which you might go in for a bigger catastrophe because you're ruptured in a calcified segment where you will have really difficulty tracking any device down or even a guide extension down. So garendoplasty, if it happens if it happens accidentally, it is absolutely fine. But recommended thing rather than better would be just improve your guide support. You're just bird. You have all the time. You change to AL guide, de-escalate the bird to 1.25 and then probably finish off the case rather than doing an granuloplasty in such a case. But again, as I said, we are all as operators, we realize the adrenergic drive when there's ST elevation, patient becomes bad. Sometimes these things happen unintentionally and really bails out.
The granuloplasty is actually an indication when I will tell when there is no rotablation. Actually, once I did a workshop in Colombo, they actually told that to a failed case of CTO with the calcium, they told that, sir, this rota, for rota only they called me. After putting the wire, they told the rota is not working and nothing is there. And I told what to do now. So already failed case and this fellow is gone by flight there. And I told you give me a balloon. I took one balloon, 1.25, I just dilated, ruptured, taken a 2 millimeter balloon, ruptured. And they are looking what this fellow is doing. Finally, I could put a stent and come out very nicely. But I'm just telling that this should not be an indication. Rather than we are giving a discussion in our WhatsApp group, that is to be avoided. This actually not the way of doing, but rhinoplasty can be done accidentally, like Karun told it is okay. Otherwise, it is not a good way.
Actually, it was not intentional. Because of the adrenergic drive and ST elevation, we just wired the lesion. We wanted to somehow preserve the flow.
One more thing I just want to subintimal dissection is not a contraindication for rotablation. People think that there is a dissection means you cannot do rota. That is wrong because actually intentionally in CTO, I'm telling about the Japanese guys, they create a subintimal rotablation and then take a path and create a stenting. That is too much. I'm afraid of even thinking about it, but they are doing it and they are showing it.
Ranju, a good case. As Arun said, the guide support would have helped you cross the lesion with the rota. And even if patient was unstable, you had all the time in the world. No, you could have stabilized the patient and waited. Usually that's what happens during RCA rota. Patient will stabilize after a while. Now, regarding after all these trouble you had in the RCA, the LED also had significant calcium. You already had a rota on the table. So you could have done a few polishing drives, even if it was not very right. And probably I would have come back with the diagonal stent a little more closer to the ostium and probably done it as a bifurcation so that you don't miss the ostium of the diagonal. So very good case.
Thank you.
Thank you so much. Let me request Dr. Manu Verma to. Meanwhile, Dr. Manu Verma gets ready. Let's say there are situations wherein the rotabar doesn't go through. So probably one could do is what Dr. Renju has started off with 160,000 RPM. You could go up to 180,000 RPM, 200,000 RPM, maximum of 220,000 RPM. Doesn't go across at 220,000 RPM. You need to probably downsize it to 1.25 millimeter burr and again keep burring 3 minutes, 4 minutes of burr time. If it doesn't go through, rather than resorting to granuloplasty straight away, probably you need to switch over to a New York burr. By 3 to 4 minutes of burr time, probably what happens is whatever diamond it's over the burr, it all gets destroyed, and so you need to switch over to a New York burr, and many times the New York burr also will go through. Please go ahead.
Good morning, dear friends. She is a 67-year-old female. She had exertional angina as well as one episode of rest angina also. She was under optimal medical management. She underwent percutaneous coronary intervention to RCA and circumflexor in 2012. And RCA, no significant angiographic stenosis with patent stent. And her left ventricular function is quite good. And this is the angiogram of the left system. Right system I'm not showing because of the normal study. Here you can see the stent is patent, significant atherosclerotic burden in the left system, and you can see the fluoroscopy itself is significant calcification of the left main as well as the mainly in the proximal LAD and circumflex too. So is a the onset itself decided to go for a 2-stent strategy. I did a IVS evaluation of the left circumflex system. You can see the 260 arc of calcium at the ostium, as well as the mean lumen area is less than 3.5 millimeter. So 3.48 millimeter is the mean lumen area. So that's what that was the circumflex IVS evaluation prior to the procedure. I tried to take the IVS catheter into the left system, in the left anterior descending artery, unable to cross the lesion. So tried 1 and 1.5 millimeter balloon. I couldn't. Ruptured the 1.5 millimeter balloon. Then I took a 2 millimeter balloon, which showed a dog boning effect. And because of this, decided to go for a rotablation with a 1.5 millimeter burr. So after the rotablation, then I was done. IVS evaluation of the LAD done. In the IVS evaluation, you can see 2 cracks and reverberations also. But considering the 360-degree arc of calcium, I decided to go ahead with a lithotripsy for this patient, especially dense calcification of the proximal LAD. So I decided to take a QLET as my strategy to go ahead with the stenting. LCX stenting strategy is around 19.47 is the length of the lesion, and distal landing zones are quite good. These were the distal landing zones and the proximal landing zones. And LCX pre-dilate with a 3x15 NC, followed by a 3x23 millimeter DES was chosen, pod done with a 3.58 into NC. Then the LAD stenting strategy, around 36.6 is the lesion length, and then landing zones were quite good. And rewired, struts were crossed. LAD dilate with the LAD, proximal LAD initially did the lithotripsy, followed by the LAD dilatation with the NC balloons with 3. Again, this is only the struts were dilated. And I tried to take a long stent, but I was unable to take it in spite of dilating multiple times with balloons. I was unable to take the longer stent, so took 2 short stents. And LAD stented with 3 into 18 millimeter DS distally, and followed by proximal stenting, pod done rewiring, and then decided to do a sequential dilatation, but unfortunately I am unable to do a kissing dilatation. The reason was the aorta was a porcelain aorta, and my stent guide was kinked at the common iliac area. I was unable to take, in spite of a 7 French guide, I was unable to take 2 balloons together. So ended up this result now in front of me, whether I should remove everything and go for a kissing balloon dilatation with a long sheath and a long guide. That was my first question. Second is just do the IVS evaluation and see what are the MLA I have obtained, and then I will change the strategy. So the LCX post-stent run, a good LAD ostia is well opened. LCX obstia is well opened. And these were the MSA mean stent area I received at different levels, from 5.5 to 9.4 is the at the left main, and 6.3 at the ostial level. And this is a LAD post-stent run. well expanded struts, and you can see different MSAs at different levels from the distal to proximal. So considering this a good MSA, I decided to conclude my procedure because such huge calcification and doing the whole procedure again, it is not an easy way. And anyway, I was revealed good mean stent lumen areas, so I decided to conclude my. So my important point to mention in this case is that you should always consider the aortic calcification also, especially at the bifurcation area. And if it is a significant calcium, at the beginning of the case itself, you should use a long sheath rather than a short sheath. Otherwise, your guide will get kinked, and you might not be able to do a kissing balloon dilatation at the end. So in spite of meticulous lesion preparation, I was unable to do a proper kissing balloon dilatation. That is the whole thing.
A good case, Dr. Manu. Actually, did you do a port?
Yes.
Okay. You could not do a kissing balloon.
I couldn't do it. I did a sequential dilatation followed by a port also. But I was unable to do a kissing balloon dilatation because two balloons could not be negotiated at the bifurcation area.
Great case. Just one where was it kinked actually?
At the iliac area, iliac and common iliac area.
Why don't we do a plasty there? Just a balloon in the guide?
Oh, that I didn't do it.
Just balloon in the guide. You balloon the guide out. Probably it will allow you to take the two balloons out.
Because already the so many steps were there, and
the balloon the first balloon which has gone through, when it pulls back, you don't want to damage.
When you are using the single balloon, it was going very smoothly.
Yeah,
so I never expected. When I was taking the two balloons, it is not moving. And the shafts are getting kinked multiple times. But I didn't. I was not aware that I can do inside the guide. I can do a balloon angiogram. That's what I. Oh, okay.
It can be done.
But the guide will kick again there, no? At the same location?
Generally recoils, but the moment you can actually have what we do is we take the second balloon to the where the kink is. When the first balloon comes back, we inflate, and then the moment before it recoils, pass the two balloons across, and then you take it up. We have done.
Very tough case, Manu. Probably one of the cases that you would refer to the surgeon without even feeling a little tinge of guilt. So
see, this patient is a spinster and a polio victim also, and nobody to look after, so she doesn't want to go for a surgery.
Very well done, actually. Very tough case. Thank you.
And did you really make out in the final pullback from the LED that the stent in the circumflex, it's at least 1 millimeter into the left main?
Yeah.
Was that appreciable in the IVUS run?
Yes.
It was appreciable.
It was. So it was in the confluence as well as the ostias are all very well done. And removing everything and going again in such a calcific area, I found it very difficult. And I didn't think about what Arun had mentioned. Otherwise, I would have done it definitely.
You don't have to be apologetic. Even in the classical crush trials, 15% of patients, they didn't ultimately have a final kissing balloon dilatation. And those were the patients who came back with MACE in the future also.
Yeah, that is the reason why I checked the MSA and I found quite okay. Then with a sequential dilatation and a report, I completed my procedure.
It's not possible. Thank you so much, Manu.
Thank you. No, ideally
sequential followed by simultaneous. Thank you so much, Manu. The next presenter, Dr. Girish, is not available. Dr. Arun Gopi will be presenting Girish's case. He had to rush back to Calicut due to family issues.
So I think, as Dr. Deepak said, Girish is not here, so I'll be I think he had some message to say. It's about a 76-year-old with known case of LM plus triple vessel disease, advised cabbage, not done. Came to him actually with recurrent rest angina, taken up with an intention to revascularize. Vitals essentially stable except for axillary hypertension. ECG showing changes in the anterior territory, LED hypokinetic with mild LV systolic dysfunction. So this is the diagnostic angiogram. So RCA was a CTO, right dominant RCA was CTO, and this is the lesion actually. So there is a long LMCA with a mid-shaft disease and a critically narrowed segment in the proximal LAD. In between, there's an aneurysmal, a slightly dilated aneurysmal segment, two tandem lesions in the proximal LAD, which was the culprit. So right femoral axis was taken, EBU 3.57 French guide taken in. Initially, field FC wire was taken, but none of the balloons could cross. So over a caravel, it was exchanged to a Grand Slam wire for better support. After that, one point sequential, there were dilatation was done, and there was no upfront imaging probably used here. And initial dilatation with a 1.5 balloon, subsequently with a 2.0 balloon, and then the pre-dilatation was done with 2.5 balloon, but there was a significant dog boning. So it's probably a mistake that it's not an OPN there. Actually, it was an IVL that was used. So the bed preparation was done with a 3.0, 3 into 12 shock wave at initial 4 atmospheres in the first 5 cycles, and the last 3 cycles were done at 6 atmospheres. So the proximal LAD was prepared with, the bed preparation was done with a 3.0 IVL, all the 8 pulses being delivered at the same, almost in the sequential 2 tandem lesions itself. And after IVL, using a guide extension, a guide plus, we're able to track a 3.548 drug-eluting stent from mid-LAD to almost ostium of LMCA. And the stent was deployed, but there was still significant residual waste in the proximal LAD lesion. Probably the 3.0 IVL was inadequate there. And then subsequently the post-dilatation was done with 3.5 quantum balloon, but there was still a residual waste. And then subsequently that area was opened up with an OPN post-stenting, probably a pre-stent OPM after an IVL, and if we are done with a 3.5 non-compliant, if we had found a waste of 3.5 OPN at that time would have been better. But here we optimized it post-tending with a 3.5 OPN at 35 atmospheres, and at 35 atmospheres the waste opened up and the stent was adequately expanded. And then finally an LMCA pot was done with 4.0 balloon at 18 atmospheres, and this is the final angiographic outcome. And this is the IVUS pullback. It's slightly a longer run, but the first instance, the IVUS didn't cross, but probably after the initial bed preparation, we could have done an imaging, but it was done after that. Actually, we went ahead and pre-dilatation, we prepared with IVL, and then after the stent implantation, the post-IVUS was done. The post-IVUS, actually, the slightly longer run essentially shows well-expanded stents with good MSAs, and these were the MSAs. The MSA in LMCA was 11, almost 11, and LMCA in the proximal LMCA was 7.5. The key message was sometimes in tortuous calcified lesions, doing a bed preparation with rotablation or orbital might be challenging. It can be done, but might be challenging. So in this scenario, a balloon-based preparation was done, initially sequential dilatation, and pre-stenting a preparation was done with IVL, shock wave, and post-stenting the further optimization was done with OPN balloon. And balloon-based technology is always the easiest thing to do when you're dealing with a complex coronary anatomy. In a person, in such a case, the RCA was already a CTO, and you didn't want to have a slow flow in LAD. And so that's why this balloon-based strategy was thought alone, because this was a single surviving vessel and you're dealing with LM to LAD stent. And in ideal scenario, always a pre-imaging and a post-imaging should be done. Here only a post-imaging was done. But it's just to highlight that in a calcified subset, you need to have in a calcified subset, in essentially a single surviving vessel, if you want to have a quick and simple procedure, a balloon-based strategy would be the ideal one, IVL to start off with, and to top it up with an OPN. That's the message.
Yes, Arun. Nice case. As we had discussion during the fellows course, it's always good that when you have a extremely calcified lesion, it's always good to have a volume reduction with ablative strategy, orbital or rotablation, followed by a balloon-based strategy wherein you have a cracking of the lesion. And it was a wonderful case. And would you go ahead and say that OPN is better than IVL in at least certain cases? Because we've had one situation wherein we had an ostial RCA wherein 80 pulses were given, we were not able to open it up, but then So it was almost a failed IVL. Then the company guys, they had opium with them. They told you take it free of cost, and 45 atmospheres we were able to open it up. So there have been situations, anecdotal reports wherein the IVL doesn't work, and even opium at that point of time it works also. What is others' opinion regarding this?
Personally, I feel IVL is a very much over glorified technology compared to the cost that it is delivered at. The maximum pressure the IVL gives is actually 50 atmospheres. OPN, although they say RBP is 35, you can go above that also. It's all about pressure. IVL being a newer technology is more driven. Since both are from the same companies, they gave you OPN free. But otherwise, the real fact is you wouldn't say that IVL is so superior than OPN. IVL is too much overpriced.
But the stress is less when you use an IVL, because with OPN, every 5 atmospheres you go up, your blood pressure also keeps going up.
Probably, sir, you watch the complications case. I will show you a case where IVL is also not that same.
Sir, from sometimes we find that you put a 3 stent, you have used an IVL initially and there is no expansion, and there are pulses left in the IVL. So is it okay that, like in Arun's case, you have to inflate to 3.5, you use that 3 to higher pressure, or use a 3.5
People
OPN?
have done that, going up to 8 atmospheres and delivering the rest of the pulses inside the stented segment.
So which
Now
one
they
should
are
be-
actually permitting you can go with a high pressure and then deliver it also.
So which one should be done, sir? A 3.5 OPN at high pressure, or 3 IVL which remaining pulses at a higher pressure?
The
Or an underexpanded
Probably
stent?
you need to try both. If 3 doesn't work, a 3.5 IVL or 3.5 OPN, if the vessel size is big enough.
Rajesh,
And
better
once you have a IVL is taken with a normal IVL, all the pulses given, you can take a normal non-compliant balloon and dilate. Why do you take an OPN balloon there? It is not required.
Well, sir, 3 IVL is taken. You have delivered, say, 30 pulses.
Okay.
Baki 50 left.
You
and,
can
and the stent is still underexpanded.
No, but the principle is actually Dr. Ashok Seth is always telling that you have to give all the 80 pulses and take a non-compliant balloon, high pressure. That will give everything. That is the best way of doing rather than going this.
Yeah, IVL, if you go to higher pressure, it will rupture. The balloon is not meant for high pressure. So that is the problem.
I mean, if you go at, say, 6 or so and again deliver the remaining pulses, or take a 3.5 like what Arun did and go at...
But actually, Madhu, IVL after not delivering, otherwise also you can dilate as a balloon, you can dilate at a high pressure and give it and come out.
Sir,
Actually,
IVL RBP
that
is 6.
what-
RBP is 6. IVL.
But
RBP is
normal
6.
balloon is RBP
Yeah,
is
yeah, but-
actually 14, 15. You are actually going up to 24 atmosphere. The same principle applies here. This very clearly I asked for the IVL people. I'm just telling normal RBP for a balloon also 16 atmosphere. We go up to 24, 28, and that was the practice done by Colombo Lake. Here, you actually normal RBP is 6 only. You can actually, after the pulse is finished, you can take the same balloon, go up to 15 atmosphere, and rupturing is actually 99% of the chance. That is called a rated pressure. Actually, that will not happen. And my question is, in a very thin, but you can go 16. If people actually trying, these are all trying things, then only you will understand. And concentric calcium, I take a cutting balloon and take. We may think that it will not happen. A cutting balloon and dilate, and you can go up to at high pressure and then come back and take a non-compliant balloon and go it.
So we'll have one comment from Hari.
Not have any comment for that.
I had a single experience with a burst of an OPN. That was a deferred case of CABG in a Takayasu arthritis where the subclavian and the lima was involved. So fibrocalcific lesion, I started with an OPN. Of course, all the regular strategies were started first. I kept on going and it did burst at 50 and opened up the lesion. Luckily, nothing was there. So the RCA ostium was done like that, like a grenade. The same thing I did for the lady ostium also, with the experience of the RCA ostium. And I mean, my point is, OPN also bursts. It works also. Maybe it's not very safe to do that.
Very true. Varma, last comment.
Yeah. See, we should remember that the IVL is a method for delivery of ultrasound pulse to break or fracture the calcium. It is not a dilatation balloon. You can use it for dilatation at certain pressures, but ideally, after getting the fractures in the calcium, microfractures or whatever type of fractures, you go up with a NC balloon to high pressures and get the expansion. That would be the better principle.
Shall we have the next
Yes,
presentation?
agreed.
Next presentation. Arun, thank you so much. Dr. Anil Kumar, MK.
Good morning, everybody. First of all, I would like to thank the organizers for giving me this opportunity. I am presenting the case of a 76-year-old male, known case of diabetes, hypertension, chronic liver disease with hepatoma status post days, who presented with acute inferior wall MI on 28th February this year. This shows his ECG. His echo showed RWMA suggestive of inferior wall myocardial infarction, mild MR, and a normal global ejection fraction. He was immediately taken up for a primary angioplasty. This shows his angiogram. It shows a normal left main, severe calcification of proximal and distal circumflex, long 80% lesion of the proximal circumflex and another 80% lesion of the distal circumflex, severe calcification of proximal and mid LAD with an 80% lesion in mid LAD, and a severely calcified RCA which was occluded proximally just after the ostium. On seeing the calcium, we decided to go ahead with POBA to RCA and then a multivessel PCI with a plaque modification technique later. This is the POBA to RCA. Luckily, we got a good result, relatively good result with the TIMI3 flow. He was then taken up for multivessel PCI later. We didn't have an OCT at that time, so we used intravascular ultrasound. This shows the intravascular ultrasound, a static picture of LAD. He has both superficial and deep calcium. The calcium arc is 360 degree and its length is more than 5 mm. So the next question is, which is the optimum lesion preparation strategy? The various lesion preparation strategy can be remembered by the acronym ROLL: rotational atherectomy, orbital atherectomy, intravascular lithotripsy, and excimer laser. Here, the lesion was not balloon crossable, so we were left with rotational atherectomy and orbital atherectomy. Since he had both superficial and deep calcium, we decided to go ahead with orbital atherectomy. This shows orbital atherectomy being done. Sorry for the poor quality of the video. We used Diamondback 360 orbital atherectomy system. It was approved by US FDA in 2013 and obtained a CE mark in 2021. We crossed the lesion with 0.012 wiper wire with a 0.014 tip, and the tip was parked in distal LAD. And this wire has a length of 325 centimeters. It has a radio opaque tip whose length is 25 millimeters. And it should be parked in such a way that the minimum distance from the proximal tip of the radio opaque part to the crown should be more than 5 millimeters. The crown is 1.25 mm eccentrically mounted diamond burr, and it is taken to the proximal LAD with the help of a glide assist which rotates at 5000 RPM. We used 80,000 RPM to cut the calcium. There are two speeds available, 80,000 and 1,20,000. 1,20,000 is used for larger vessels more than 4 mm in diameter. And this crown was moved forward with a speed of 1 millimeter per second, assuring a 1:1 crown knob movement. This was moved continuously for 25 seconds and then stopped for another 25 seconds. And during atheroablation, pitch changes and tactile resistance can be appreciated as the crown engages the calcified lesion. And as the number of run increases, both the tactile changes and the pitch changes decreases. And the number of runs should be continued until both these changes are not completely appreciated. And after the run, we dilated the lesion with the non-compliant balloon as usual. then stented the lesion, and this shows the final result. The IVUS picture shows pre and post PCI. The area increased from 2.3 to 6. Similarly, we did orbital atherectomy of the circumflex also, and this shows the final result. This shows IVUS post balloon and post stent of circumflex. The area increased from 3.8 to 4.7. So in conclusion, orbital atherectomy is an adjunctive therapy used for lesion preparation of calcified plaques before PCI. And the goal of lesion preparation is to modify the calcified plaque, which changes the lesion compliance and allows for adequate balloon and stent expansion in segments with heavily calcified lesions. Thank you for patient hearing.
Dr. Anil, very good case. What did you did for the RCA, like second time?
The plasty was done. Angioplasty was done for RCA. It was dilated with the balloon. We could dilate it with balloon without using that orbital atherectomy.
No, you stented it?
Yes, yes.
Okay.
2 stents were used, one for the proximal RCA, one for the distal RCA.
Okay.
Your distal LED stent landed very too close to the myocardial bridge. So, would you prefer any particular stent or anything, any difference in strategy when you're doing that? No, even in the first angio,
Yes, that is true.
That LED had a very significant bridge actually, almost up to the small diagonal actually. So your stent distal part of the at least 5 millimeter of stent
It's
has
very
gone,
close to the, yes.
gone very well into the myocardial bridge. So would you prefer anything, any stent with more radial support or?
Yes,
medial stent
ideally
or
stent with more radial support should be used. But in this case, we used Ebert stent.
Why orbital atherectomy over any rota?
Now, he had a deep calcium. In some of the rota runs, it was very clear. So it was very difficult with the rotablator to cut those deep calcium. So we decided to go ahead with the orbital atherectomy.
So moreover, the theory is also correct. When you have a deeper one, the pulsatile forces are likely to break.
Yes,
You
yes,
went
that
up
is
to higher speed also, right? 80,000
No, no, only
and
80,000.
1.2 lakh.
No, no.
When you want to have a deep cut, it's always good to go. Even the vessel size is not very big. Deep calcium cut, you probably will achieve better with a 1.2 lakh RPM.
But they say use 80,000 RPM and reduce the speed.
While you go in, you go with 80,000. While you come back, you go with 1.2.
Pardon?
You can ablate antegradely and retrogradely. When
Yes.
you go in, you go with 80,000, but while you come back, you go with 1.2. That increases the luminal gain.
Okay.
Now, what about the antiplatelet for a patient with CLD hepatoma? You got 5 stents now, isn't it?
Yeah,
So-
that is true. We used the normal antiplatelets.
Aspirin, clopidogrel or ticagrelor?
Aspirin and clopidogrel.
Good
If
case,
there are
Anil.
no more comments, we'll move on to. Thank you so much. We'll have Dr. Gagan for the next presentation. Stent ablation of an under-expanded stent.
One small announcement. We have 5 kit bags available. If any faculty or delegate is set to collect, please collect it before it is completely over. 5 bags are available. 5.
You can keep it with you, Abhilash. Momentum.
Good afternoon, dear teachers and seniors. I'll be presenting a case we had done a few months back by Dr. Tharsan and myself. Stent ablation in an under-expanded stent at a severely calcified lesion. Our story begins with the 64-year-old male who had effort in a class 3 with TMT was strongly positive with good LV. This was way back in 2016. An angiogram was done at an outside hospital which showed a proximal LAD, severely calcified subtotal occlusion, and was advised PTCA. You can see the lesion before the procedure, a proximal LAD lesion. It is very calcified and it's a near total occlusion. As was routine, balloon dilation and stenting was done. A 338 drug-eluting stent was deployed. However, post-dilation was unsuccessful. Multiple balloons, New York balloons, were used, and the proximal waste in the stent did not disappear and was left as is. in the index procedure. Patient had inadequate symptom relief. He went to another center and another attempt was done to dilate the stent. It was not successful. Patient was not willing for CABG at all. And finally came this year to our center. That is almost 7 years after the initial procedure. He had significant financial limitation with limited our hardware of use. Our plan was what we would try was to try to rotablate the stent, use an open NC balloon. Lithotripsy was beyond the reach due to financial constraints, and hence we started the procedure. We went with a 7 French radial EBU 3.5 guide. You can see the initial shot, the stent, the flow is preserved all over these years. However, there is a significant waste in that proximal LAD segment. Initially, we decided to go with routine balloons. So first we wired, and then initially you try to track an NC balloon, a 312 AccuForce using balloon support, that 2x8 balloon in the OM. And this balloon, we went all the way up to 30 atmosphere. This did not yield. We tried tracking a New York OPN balloon. This did not track initially. And hence, we decided to proceed with rotablation. We used a 1.5 rota link plus burr, went all the way up to 2 lakh RPM. Initially, there was difficulty in crossing the lesion. Subsequently, after multiple pecking motions, the burr eventually made the way through into the distal segment. However, what happened at this point was the burr got stuck at that point. We tried tugging gently. It did not, nothing happened. And then we pulled back with full RPM. The entire system, the wire, the guide, everything came out. We took an immediate check shot. Thankfully, nothing bad had happened. There was still vessel. There's no ugly dissections per se. We rewired with another wire, and this time the NC balloon was able to be tracked. We opened up the balloon, went up again, and at close to 47 atmospheres, the balloon ruptured. At this point, we were able to track another stent, 330 resolute integrity, and then finally post-sale to 3.25 NC balloon. And the final result is good. Patient is still on follow-up and he is doing well. Some take-home points. The best way to avoid this situation would have to be adequate lesion preparation. The options in under-expanded stent would include CABG using an NC balloon, open NC balloon, then rotablation as we've done in this case, then lithotripsy or laser. Now, some points regarding stent ablation. It is an off-label use of the device. That is, we have close to 2 decades of data. There are multiple issues, and it is not a very safe procedure. Burr entrapment, dissection, balloon ruptured perforation. Our case reports show reasonable procedural success. How the long-term MACE rates are fairly high, 9 to 50%. Avoiding burr entrapment, we should stick to short runs and high RPMs. And this will avoid burr entrapment and slow flow. The concerns with the stent particles embolizing are not very great because the other embolization particles following ablation are extremely small, similar to the calcium piece, and are eventually washed out. Thank you.
Gagan, that's a great case actually. Just some questions actually. Stent ablation generally, so you went radial axis, 7 French.
Radial 7 French axis.
Yeah. Preferably, if you have availability when you're planning stent ablation, go femoral, 8 French axis. And if possible, like better to have a bigger burr actually, like always 1.75 or the larger size burrs is the one which is recommended for stent ablation. And because see, most of the time it's actually eccentrically ablating. That's why it's going in and then it is getting stuck actually. How to retrieve the stuck burr?
We pulled back at full RPM. The entire thing came out. Not very safe, but thankfully nothing happened.
Was it possible to at any time, I understand the financial constraint, was it any time possible to have an imaging to see what happened?
No. We wanted imaging, but we did not do because of the financial constraints.
And subsequent to stent ablation, the difference was the balloon was able to track in, and this time it expanded. But at what atmospheres the balloon opened up?
It opened up close to 45, 47.
The NC balloon.
NC balloon, OPN NC balloon.
OPN opened up at 45, and that's when it ruptured.
That when it ruptured.
But actually, stent ablation, people think that you have to cross the lesion in a stent ablation. It is not required. You have to take the rota burr almost up to the lesion, because I have done few cases like that. Just go to the lesion, touch and touch, come back, like pecking movement. After some time you take out and then take a balloon, definitely it will open. Because it's like a half rota business is required. That is, and it is dangerous because if it is stuck inside, luckily you're getting back. If you don't get back, finished. That is the end of the story. And you are telling patient is poor. Poor patient, how do you manage? You are given everything free of cost.
The rota ablation was discounted.
Okay. Number two, the patient was symptom free for last 7 years.
He had class 3 symptoms, but luckily he did not have an ACS in between.
7 years.
7 years. Sir.
Again, extremely well done.
I'm actually asking questions like Natarajan, you know.
It's technically quite challenging to do a stent ablation. As Arun has mentioned, they also recommend that probably you need to upsize it with an 1.75 bar. And again, there are three mechanisms what they say as the reason for stent ablation. Primarily, one is you ablate little bit of stent. Second thing is whatever calcium it's protruding in between the struts that can be ablated. And the third thing is the most important thing Dr. Prathapan has highlighted. You don't really have to cross it. It's the thermal injury. The thermal injury makes the underlying calcium very supple so that with the next balloon you'll be able to open. So the recommended thing is you start slow 160,000 1.5 bar rather than 1.25 bar. If possible, try to upsize to 1.75 bar and then go ahead with a high pressure balloon and then try to open it up. If possible, in between image and do the rest. It's extremely very well done.
Any issues with the...
True, sir.
Technically,
it takes a very long time, and most of the time it said that even the one we had two cases. In both the cases, we cross the lesion, but then we had to go for a new burr because it said that every time you start off with the first burr, the diamonds it gets denuded, it get eroded off, and when you look it under electron microscope, you'll be able to see the diamond pits inside in the burr because many of the diamond chips it will get eroded during while hitting with the stent. So many times you'll have to go in for a 1.5 itself. The second New York burr has to be taken for it to cross it.
Any issues with the drug if you do, you're ablating the stent? I mean, do we ideally require a drug-coated balloon after that or it will be fine?
Always these things are anticipated, but then you do not have any option, right?
No, my question is, sir, successfully we have done a stent ablation. Is it okay? Is there any added advantage of a drug-coated balloon putting inside?
No, the recommendation was actually to just dilate and leave it alone, not put another stent. You don't need to put another stent because you won't have any dissection.
Neither drug-coated balloon also.
After 7 years, no, but usually rota alone. Usually people do it immediately afterwards, no? Not after 7 years. So you don't know about this situation, but immediately afterwards, you just need to balloon and leave it alone.
Because many times the amount of stent that gets ablated is very less. But then there are OCT images wherein they've shown that the stent also has been ablated. Those situations, they go ahead and stent it. But otherwise, always try to avoid stenting. That's all. And again, as he has mentioned, the mortality rates, the event rates of these subset of patients is going to be extremely high despite doing a successful stent ablation. In all the trials, it's around 50% in the next 1 year. That's hard to believe. Can we go on for the next presentation? Thank you so much, Gagan. We'll have Dr. Sanu for the next presentation. Hybrid drill and disrupt. Probably that's the way to go in a heavily calcified lesion.
Yes.
Ablation followed by disruption.
Good morning. The rotatripsy plus approach in a heavily calcified vessel under IVAS guidance. The 73-year-old diabetic hypertensive, severe COPD. He had 3 months duration of effort angina. So angiogram was done. Angiogram showed diffuse severely calcified disease in LAD and L6. And there is RCA CTO. So this is a case of complex TVD with an RCA CTO. So the first option given was CABG. Since the patient had severe COPD, surgeon referred the case and was referred to our center for a possibility of PCA. So the challenges were the angulation. We can see the angulation of LCX, the ectasia and tortuosity, and obviously calcium. So we plan to do an image-guided PCA with calcium modification. So LAD and L6 was wired using fielder FC, and with the help of gate extension, IVAS catheter was taken, but IVAS catheter failed to cross the distal calcific segment. The images showed severely calcified LCX with 360-degree arc of calcium, and a mean MLA of 2.28 millimeter square. So considering the large reference lumen diameter and thick circumferential calcium, the next best option which we plan to do an IVL. So to take an IVL, we had to prepare the lesion. So the lesion was pre-dilated with multiple NC balloons, followed by 2.75 into 6 millimeter cutting balloon. Then we took a 3 mm IVL. The lesion was crossed and 70 pulses was given at the site of lesion. So we use Shockwave C2 plus. This is different from the conventional one, so that this can deliver up to 120 pulses. The post IVL IVS images showed calcium cracks. So the LC extending strategy was the lesion length was around 45 mm. So the nearest available stent was 48. So we took a 4 into 48 millimeter stent. 4 into 48 millimeter dust was deployed, and the distal part was posterior with 3.5 into 12, and the proximal part was dilated with 4 into 8 millimeter NC balloon. Post stent I was run short, no distal edge dissection, but since the proximal part had some ectasia, there was some malapposition which was further dilated later. And finally, we got a very good result for it's a well expanded stent with no edge dissection and malapposition. So the game is not yet over. LED also we had to say LED we wired. Then we took an IVS catheter. RCCTs. The IVS catheter failed to cross the calcific LED. So the available image showed a thick circumferential calcium along with deep calcification proximal to the tightest part. So the stenting strategy was to do serial predilatation, IVL followed by rotational atherectomy if required. So we predilated with multiple NC balloons and then cutting balloon. Since the 2.7, we could cross the 2.75 cutting balloon. We thought like we will do an IVL. Already IVL was taken. That was that is C2 plus IVL. So we had 50 pulses left. So we thought like we will finish off with the IVL rather than taking a rota. But IVL balloon failed to cross. 20 pulses was given at the proximal site of the lesion. So what is the next? We decided to take do a rota ablation. So 1.5 mm bar was used, but again failed to cross the tightest part. The procedure terminated with halfway rota ablation. Then the lesion was pre-dilated with serial cutting and NC balloons. Again, we could not take the IVL. So 20 pulses was given at the proximal site of the lesion. The LED was again dilated throughout with multiple serial NC balloons and cutting balloon. And we decided to do an IVAS. So the IVAS evaluation showed this LED had severe calcification with an MLA of 1.63 millimeter square, and there was ectasia at the proximal LED. So this time we decided like we will take another IVL of a lower size. So 2.5 into 12 IVL was taken. So luckily this time it crossed and 80 pulses was given. And the post IVL I was showed calcium cracks. You can see the calcium cracks and you can see the reverberation spots rota. So the LED stenting strategy, the total lesion length was around 55 millimeter. So we plan for a 2 stent strategy with a 4 millimeter stent in the proximal and a 3 millimeter stent in the distal part. A 3 into 38 millimeter dust was deployed in the distally, and 4 into 23 was deployed in the proximally, and posterior with 3.5 and 4 millimeter balloons. and there was final eye was short. There was no edge dissection. LED ostia was well covered, and we got proximal MLA of 10.72 millimeter square and a distal MLA of 6.67 millimeter square. So success is walking from failure to failure until no loss of enthusiasm.
What about RCA? What about RCA?
There's a CTO, sir.
With the sort of dexterity and with the sort of expertise, probably you should have done the CTO of RCA also.
So we're planning.
Not
Sir,
the,
Pradap, sir, I haven't finished. Sir, I think you need to read more of theory. You should be doing rota followed by IVL, not IVL followed by rota.
So already IVL was taken, sir.
How much does it cost? 10 lakhs?
No, Pradap, just give me 1 minute. I'm happy that Pradap Institute has presented this case. Last ICCK, when I presented a balloon-based therapy for a small short calcification, when I had to use more than 10 balloons, he told me we could have finished it one rota. I'm happy today.
No, let me, if you allow me 2 minutes, it's not a debate, But this case actually is, son is a pulmonologist. This fellow's inferior territory is totally thinned out and kinetic. That part is not good. And he's actually went and admitted in a hospital for a surgery. The surgeon told that this patient will have a real problem on ventilator and coming out of the case. Then he actually searched somewhere and came to me. He's actually not from Koilon. Usually Koilon doctors will not refer to me. The people are referring me from out of Koilon. So the patient came to me from a faraway place. And this fellow actually working in Gulf countries and he's a pulmonologist, a reasonably good pulmonologist. That is why he came to me. So he came to me, and then I saw this angiogram. I told it is the basic issue actually, Sanoop did not tell. The wiring of the circumflex was the toughest game here. And it was so, this angle it was. So I was thinking that I will be taking a 1 point. These people actually, the IVL people wanted to do me for the 1.2 that bar, and they can show this case. I presented this case in front of the Ashok Seth meeting. It was well appreciated. This case was actually taken with a guide plus, and I've taken. I thought this 1.2 I can finish everything. So we used 70 and kept 50 for the LED. Then when I took the guide plus, I was not able to take this balloon down. So whatever this, when each one you take it out, this balloon will get damaged. So I thought I will use that IVL part, initially 30. Even then I kept that 20 for the next one. But after balloon dilatation also, nothing happening. You can very well see that there is an angulation in the LED coming down. So I was really afraid of taking a rota but down that position because there's an angle. If you get stuck, you're end of the story. So it's a pulmonologist. I just understand the background. Not a medical student like morning presented, So then I thought I will give that pulse and come out. Taken a cutting balloon, dilated, nothing happens. Then I tried to take the rota, this IVS down. Then I was seeing 1.63 on the area. That is why I was afraid. Then 2.5. I took one more IVL balloon, 2.5, but with the guide plus, because of the half rota done there. And then
where did you see 1.5? The vessel size?
Vessels.
Which area?
The lumen area, the angulator part. So that is actually nothing is happening. That is why IVL I will not taking. Then with that rota, half rota done, I took a cutting balloon and dilated with a 2.2 millimeter cutting balloon, dilated, then 2.5. Then we took an IVL and created a shock wave there and created. And the right side, I was actually told this fellow that it's, I don't know whether it's a viability is there, thinned out, same MI, nearly 20 years or 18 years back. I don't want to do that. If that fellow allows me, I'll try to do that.
Sir, one technical point regarding this circumflex artery, for whoever is sitting here, youngsters at least, IVS has proven that the distal circumflex is 3.5 and the proximal circumflex is 4 mm. And you've gone with a 3.5 NC balloon and a 4 NC balloon in the proximal portion. So probably I would say that in a heavily calcified vessel like this, the circumflex is not a huge vessel. Even a 3.5 would be fair
No.
enough.
He told us actually 3 into 48 stent is taken, 3.5 proximally and 3 dilated. He was
No,
the
sir,
right.
post dilated with 3.5
Post-dilate is-
distally and 4 proximal.
That is
So
actually
I would agree with you. That's the IVS derived vessel size. But when you have so much of calcification, isn't there a small risk of perforation? When you do 10 cases like this, don't you think that at least one can perforate with going with a 4 millimeter NC balloon in the proximal circumflex? Probably you need to compromise little bit safety wise, because I've seen your perforation cases also. The last one you showed, the lady you got the gym award and also probably little bit
That
of
perforation
little
is
bit
not.
of
No. See, actually,
Sir, I
that
would agree with
perforation
you.
case
IVS
was
shows
with a
you
2.5 stent. 2.5 stent.
in a circumflex artery, which is not a huge vessel, shouldn't you be satisfied with a 3.5 rather than a 4?
One point. Sometimes OCT catheter doesn't track. Sometimes IVS catheter doesn't track. Sometimes both don't track. So don't sit in judgment.
Yeah, thank you. Excellent case.
So take homes.
Can you have the, thank you.
So the combination of rotablation and IVL is very effective in diffuse calcified lesions.
We'll close this. Can we have the next presenter? Thank you. Vince, sir.
Good morning to all. First of all, let me thank Dr. Ashish for selecting the case. Can you have the slide? Okay. My patient is a 77-year-old male, hypertensive, who came to me with class 2 angina and dyspnea of 3 months duration. His resting ECG was normal. His echo showed no significant regional abnormality and good early function. And the treadmill showed a strongly positive treadmill test. He underwent coronary angiogram through right radial approach, which showed a left dominant system with a triple cell disease, a CTO in the middle AD, and a significant distal LPD junction with a significant calcium in LED. The plan was to do image guided PCI2 CTO LED and PCI2 distal circumflex. This is the angioplasty runs. I did proceed through right radial approach with a 6F XB 3.5 guide catheter. You can see the CTO in the LED, middle LED, some lesion proximal LED also. The distal LED was filling through collaterals from circumflex. I started with the field drive XT wire with a microcatheter support. Field drive was not crossing the lesion. Then I took a gas second wire. It crossed partially through the lesion, midway through the lesion, but the wire got stuck there. With a little difficulty, I removed the wire. I think in the next image, you can see the tip of the microcatheter and a small radiopaque dot distal to that area. I think it was the piece of broken wire, because you can see the wire after removal got stretched out and elongated. But it was a small area only. Then I thought already it was crossed halfway through the lesion. I thought I'll take a field FC wire and try, but a field FC easily crossed the rest of the lesion. I did an initial dilatation with a 0.75 into 8 millimeter alveo HV balloon, followed by 1 into 10 Artemis and 2 into 10 Apollo NC balloons to facilitate imaging. And the imaging with the Boston SDIVS, which showed a significant calcification and some of the very tight areas in the distal LED where the CTO was open, with almost 360-degree calcium. I modified the calcium with the 1.5 millimeter rotabar at 180,000 RPM. Then followed by again post dilatation with 2.2 and 2.5 millimeter NC balloons. The total lesion length was around 80 millimeters, and I took two long stents, one 44 millimeter, 2.5 into 44 millimeter distally, and another 3 into 40 millimeter stent proximally overlapping with the distal stent. And both are post dilated with initially with 2.75 into 12 millimeter balloon distally and 3.5 into 10 millimeter proximally. And the final IVUS run showed a distal LED MSA of 4.8 square millimeter and a proximal MSA of 9.65 millimeter. And there was no edge distance. It was a well opposed stent and reasonably expanded. So take home message is imaging with IVUS is extremely useful in assessing calcified lesions. Calcium modification of the rotablation can be safely done even in CTO after successful wire passing. And pre and post PCI IVUS helps in attaining optimal PCI outcome in complex PCI. Thank you.
So well done, case. Good result actually. So just one question. Your IVUS pullback showed even in the at the 360-degree calcium area, the lumen diameter MLD was around 2 millimeter.
Yeah.
So do you think a 1.5 millimeter burr would have had any impact on the calcium there?
There was
it was a relatively straight area, no bends and all there.
Yeah, it was a very tough area because I don't when the wire got stuck there. So I think the amount of calcium should have been significant. Even though the area looks 2 millimeter, I think it was a circumferential calcium. I was not sure whether an NC balloon will dilate it properly.
Probably a cutting balloon would have helped you more in those areas actually where you have a bigger lumen and 360-degree calcium. Or if you have an IVL, then perfect.
Yeah.
So you look at the way the rotabar was passing, no? It was just passing like free floating.
No, I think it was a little difficult. I think I took only 2 runs here. It was not that easy.
Agreed. You'll have some small spicules which you can polish off, no? So that your stent passes.
No, it was not that easy because it was, this may be the final run. That's it. Yeah, it was some breaking was seen. No, it didn't show anything. No, it didn't show anything. I just checked it. It didn't show anything. Maybe. But it's just a radio opaque, a small area, radio opaque. Very a dot only, I could see. Just radio opaque, that's what I can say. Yeah. Okay.
Thank you, Dr. Ravindra. Thank you. We will call the next presenter, imaging in rocky tunnel with ISR. We'll see what is the tunnel. Srikala, please come.
Good afternoon, everybody. My respected senior colleagues, chairpersons, and dear friends. Today, I'll be presenting my case as a 70-year-old male diabetic hypertensive for past 20 years. History of anterior wall enstomy in 2011, for which he underwent a PTCA to osteoproximal LAD in our center with 3x24 drug-eluting stent. He was on regular treatment and with poor diabetic control and recent onset of effort angina since 4 months, and for which he was evaluated with TMT, which was strongly positive for inducible ischemia. So he underwent a repeat coronary angiogram. This is the ECG, and angiogram, you can see a heavily calcified right coronary artery with 2 areas of tight stenosis. LAD, you can see the stent with the peristent instant restenosis, and circumflex showed an osteoproximal diffuse calcified 80% disease with a relatively normal left main. So the option of cabbage was given, but he was unwilling for surgery. So our plan was to do rota for the rocky, like RCA was called the rocky tunnel actually. So right coronary artery is an entirely calcified vessel, and under rota, we were planning for an angioplasty to the right coronary artery. And for the left system, since it was an ISR, the OCT was the imaging which was selected. So the rota followed by 2 stents to RCA, proximal and distal, was done with good results. So there was some difficulty in passing the 1.5 rota burr, and good flow in RCA was obtained post stenting. And then we proceeded with the OCT run on LAD. You can see there is a diffuse areas of fibrocalcific plaque in the just outside the stent, and also the distal part of the stent. There is a significant ISR of 80% with fibrocalcific plaque with areas of spotty calcification. There was not much calcium in the entire LAD, so the calcium modification was not done. It was planned for a pre-dilatation of the. This is the peristent area, which shows a tight stenosis. And the proximal LAD, there was no areas of ISR. It was the stent expansion was around 85%. So our plan was to stent the peristent area only after the OCT images. This is the ISR segment, which is showing in the distal part of the stent. There was a significant so LAD ISR was pre-dilated and stented using a 2.75 into 28 drug-eluting stent, and the OCT run after the dilatation showed a good MSA of 4 millimeter square in the distal segment and also inside the distal part of the stent. And now the left main to circ stent was deployed after adequate pre-dilatation using a 3.5 into 40 millimeter disc, and a final port was done with the 4.5 into 8 millimeter balloon in the left main system. And a final OCT run of the left main to circ was again done, and a good MSA was obtained in the entire part of the stent, in the 6.8 in the distal segment, 8 millimeter in the ostial circ, and a 13.4 millimeter with some malposition was obtained in the OCT, which was again pre-dilated with a 5 into 5 millimeter balloon. You can see a few struts across the LAD ostium. So the final kissing balloon was also done in the last step. So this OCT to LAD revealed significant ISR with new atherosclerosis and microcalcification, and the OCT circ left main pullback revealed no disease in the LAD ostium. Hence the crossover stenting was planned, and the final kissing balloon dilatation and port was also done. And so the take-home message is imaging is very helpful to understand the pathology and mechanism. Lesion preparation is essential for safe delivery. Atherectomy devices like rota are essential for superficial circumferential calcium. And this case represents a combination of highly calcified lesion with left main bifurcation and instant restenosis. Thank you for the patient listening.
Good case, Srikala. Yeah, significant calcium with ISR.
Yes.
So all steps are very well done. So you did a SKS of left main, simultaneous kissing balloon of the left main to LAD.
No, final kissing balloon was done only because the LAD ostium was in the OCT also. In the final run of OCT also, the left main LAD ostium was not affected much. There was no pinching. So already there was a stent in the left LAD ostium. So just a final kissing balloon was done as the final step.
Oh.
So just a crossover stenting was done from the left main to circ. In angiogram itself, there was not much lesion in the LAD ostium. Only the peristent area was showing significant restenosis.
Just one question. Why did you choose to do a rota, such a complex rota and PC of the RCA first instead of fixing the LAD first? Because patient is likely to become more unstable if you have a diseased left side when you're doing the RCA rota. Just a question.
I don't know.
ചെയർപേഴ്സണോട് ക്വസ്റ്റ്യൻ ചോദിക്കാൻ പാടില്ല.
പ്രസിഡന്റ് സ്ഥാനം മാറി എനിക്ക് ചോദിക്കാൻ പാടില്ല.
Definitely, I would have fixed the left system first and then gone for the rota on the right side.
There was TIMI 3 flow, probably that was the reason.
Yes. Yes, sir. It was addressed. It was addressed. Then the left main to circ was addressed.
Here the flow is good, so probably the.
So did you do any debulking for the ISR or just put a direct stent?
No, I did. I dilated only with the NC balloon. I didn't do any debulking because in OCT did not show much calcium. That was a fibrofatty plaque basically.
Because the problem is when you do an ISR and you put a stent, I mean, if you, the last OCT, you can see so much of material between the two layers of the stents. That's why you use a drug-coated balloon, probably.
Rajesh.
Sir, if this patient were to restenosis the LAD ostium and the circumflex were to remain normal, is it just enough that we convert it into a tap-like thing, or we have to address the circumflex ostium also?
Now you have a stent going from the left main into the circumflex, and final kissing balloon has been, dilatation has been done, so that the strut has been removed from the LAD ostium. Now, if there is a restenosis, why would you want to have extra metal in the left main or circumflex? You would just want to address the LAD ostium alone with a balloon in the circumflex.
Yes.
Isn't it that?
Yeah.
Yes. So he was asking if this patient comes back with an LAD ostial restenosis, wherein the circumflex and left main is normal, would you want to do something for the circumflex? If circumflex is normal, you wouldn't.
Yeah.
Yeah.
We can,
A tap would be the best. And again, drug-eluting balloon.
So
I don't.
tap means stent to the ostial LAD and a drug-eluting balloon to the circ ostium.
Why would you want to?
That's what, sir.
Why would you want to use a drug-eluting balloon?
Just a stent in the LAD ostium and a normal.
And a normal balloon in the.
That's what, sir.
NC balloon in the circumflex. Sir, there is no stent in the LAD ostium.
There is a stent in the LAD ostium.
Till the ostium, it's not there, right?
Yes.
Till the LAD ostium, it's there.
It's there.
Then drug-eluting balloon would be the best option.
Drug balloon. It's covering the ostium. It is seen in the OCT images. It's covering the ostium up to the ostium.
True.
Shrikala, thank you. We'll go to the last case.
Shivaprasad, sir.
Good afternoon, and thank you, Ashish and Pratap and Abhilash, to allow us to present this case. This is zero contrast angioplasty. The story is a 58-year-old man with a long duration diabetic hypertensive dyslipidemia with CKD with the eGFR of 28, not on renal replacement therapy, with recurrent ACS and had good LV function, is a reformed smoker. CAG was done outside and referred for intervention. The patient did not want to undergo CABG, nor the surgeon was also very keen in doing this in this case because of the renal dysfunction. He had a calcified LAD with some ectasia and then significant long lesion in the LAD up to the mid to distal segment. And this is the angiogram taken from another center, and this is the lesion which is heavily calcified. So the problems are calcified lesion, long segment disease, a compromised renal function, and the allowable contrast. If you take by the formula, you get about 28 ml because the eGFR was 28. So our plan was to do ultra low contrast angioplasty or even a zero contrast angioplasty, and maybe we require rota, and IVUS guiding is essential for placing the stents and the landmarks. and pre-hydration was planned with isotonic saline at the rate of 1 ml per hour per kilogram body weight 12 hours before the procedure, and hardware is used for 7 F EBU 3.5 run through workhorse wire, then fine cross microcatheter to replace the rota wire, and the rota link plus 1.5 and opticross was used in this case. And you can see the first thing EBU cannulation without a check shot and pass the regular workhorse. We have not taken any angiogram till now, and LED was rotablated with using the calcium landmarks. We passed the wire, the rota wire and the rota bar, and we had some initial resistance. Then it easily went down, and we made a good polishing run at the end. And after that, we had a IVAS run, which shows the distal landing zone had the distal lesion is 1.65, and mid LED showed severe concentric calcification with reverberations and also proximal LED 360 arc of calcification. Osteoproximal LED had a good lumen area of 8.48. So after seeing this, we went on with to identify the length. We oriented in the long view, I was long view with the branches delineated there, and we had a total length which is given in the next slide. This is around 78.83. 33 was the length, around 79 was the total length of the lesion. And these are the various areas where the landing zones and the areas are given. And we dilated after this with we wanted to have a hard landmark. Till now we had a soft landmark. We used another wire to go to the diagonal, and that was placed there as a hard landmark. And then we pre-dilated the NC balloons 2.5 and 3, and subsequently we tried to deploy the 2.75 to 44 millimeter stent distally. It was deployed, and distal stent, after the distal stent, we found that there is no distal dissection after the stent edge, and stent is deployed well. And we have given post dilatations after that. This was done, and the minimal lumen area achieved was 5.06, and then we had a reasonable deployment of the distal stent. Then we had to find out the proximal stent length. From the proximal stent length was again calculated based on the long view. You can see that it's around 45. And again, these are the landmarks used. And we have used a 3x48 stent with the optimal overlap. And this has been placed with the port done proximally 3.5 into 12 NC balloon. And the run shows a good deployment of the stent, good lumen areas achieved, and even there is no edge dissection as well. Final result, we just give the first time, we are given the diluted contrast and given the final injection, which showed a very satisfactory result with a good, well deployed two long stents. And this is basically for insurance purpose, to claim the insurance as well as for medical legal causes. And to conclude, we used around 7.5 ml. Maybe it is less than that because we have used a diluted contrast. Fluorotim is 38 and radiation was 3.5 gray. Pre-procedure creatinine was 3.2 and post-procedure it was 2.8 because we did not use any contrast. And take-home message is in really challenged individuals. Zero contrast or ultra-low contrast is a valuable life changer. And how to calculate the volume we can administer is the EGFR and 1-to-1 ratio. You can give 28 ml of dye. In this case, 28 ml can be used without much deterioration of the renal function. But another way to reduce the contrast, use 2 to 3 ml syringes so that you inject only very small amount of contrast. Second, you withdraw the contrast from the gate catheter after injection so that inadvertently you will not push contrast inside. Make the C-arm fixed and lock the table. Learn and register the image in your mind so that you can place the stent properly. I stress the fact that assessment after each dilatation with a high definition IVAS run is very important so that you can place the stent in the exact landmarks where you imagine it to be. Thank you.
So well done, Case. Now you can engage your guide. You can wire. You can place your balloon for dilatation. You can place your stents for deployment, everything using landmarks without using any contrast. But sir, do you think it's safe not to do a check angio with, say, 1 ml after a rota, after a cutting balloon inflation, or after a high pressure inflation at a calcific segment? If there is a leak, if there is a perforation, you'll miss it till the last shot and patient will become unstable. So
That
it's
there is
there
an inherent danger of being
inherent
blind
danger.
throughout.
So what I would my thought process is your risk of producing an acute shutdown with an additional 2 ml or 3 ml contrast is very little. You use 1 ml contrast after your rota, after your cutting balloon, or after your high pressure dilatation, just to make sure that there is no perf.
But I had the other side of it. This is one side of the coin. Other side, with 1 ml, you may not recognize the perforation.
No,
You may not recognize the
sir,
perforation.
you can always go
but you
in,
add to the stress to
I got
the
it.
kidney.
You can always go in to the vessel with a guide extension catheter. You can always put a guide extension catheter,
that is
and 1
another-
ml will opacify the vessel
That
very
point
well.
is well taken because guide extension catheter is advised to reduce the contrast volume.
Exactly.
I would like to go with Shiv Prasad. You here, everybody will like to inject as much as possible. See, after balloon dilatation, after stent, after anything, but we have to differ from that that culture of
Temptation.
injecting at each point. That is what actually means by this presentation, if I get it right.
Exactly.
Right. So as minimum as
The
possible.
point is, Balakrishnan,
Yes,
the
yeah,
point
I
is,
got your point.
instead of using 3 ml of contrast, you end up using 6 ml of contrast.
No,
which is
not exactly. See, after balloon dilatation, I would like
not
to.
after every balloon dilatation.
Any balloon dilatation can produce the same thing.
No.
So it doesn't matter whether balloon
if you're
dilatation, stent, or
if you're
whatever
dilating a
procedure.
calcific area, if you're dilating at using a cutting balloon dilatation, definitely there is a chance of perforation. Means you have to
Definitely, we are
you have to
quite
judge
used to
your
this
contrast very well.
mind concept that we have to use with each and every. See, I don't usually post ending the if the pressure is okay, if the ECG is okay, if the patient is okay. I usually I take a check
In such
injection
cases,
after.
you don't need after stenting or after post dilatation, you don't need contrast. Agree.
Yes.
But some say after rota, if you don't do a check angio with 1 ml of contrast, then there is a real risk of
Definitely,
endangering the life.
there is definitely risk. This risk versus benefit is what is being in question, isn't it?
Sir, Mahesh sir.
Yeah, one point I want to say is that.
Sir, I think Abhilash wants to say something.
No, sir.
Yeah.
I just want to start the next session so that some of them are waiting.
We are continuing with the next session, right?
Yes,
Right?
we are continuing because
After the next session, we'll break for the lunch.
Only after finishing entire sessions.
Only after finishing
Many
the
have
next
to-
session, we'll have
yes,
the lunch.
Many have to catch the
Thank
3
you so
o'clock
much.
train.
Thank
So
you.
the session
So
continues.
if
Sri
you have
will be last.
if you have
Mahesh sir last.
creatinine between 1.5 to 2.5, I don't think you should compromise on how you do your procedure. Do it peacefully, aram se, use your contrast, do what you want. Give a short dialysis after that. So I've got 11 cases which I'm out to you. The next question asks where is the study? Study will come. It'll take time because the last 11 cases I've done this way have done extremely well. 3-month, 6-month follow-up has been very good. The creatinine has always dropped. Obviously, post-dialysis, the creatinine will drop. No kidney injury because of the contrast that I used. And I did my case in peace because if I don't want, like what Dr. Balakrishnan was saying, I'd like to check after everything what I've done, whether I've gone through or not gone through.
Sir, I would also concur with what Dr. Jayesh has mentioned because we are trying to do a safe procedure for any patient. So we are looking at the maximum safety of renal function. So similar to that, a perforation part also has to be kept in mind so that when you deploy a stent post-dilated at very high pressure, before taking out the balloon, probably a 2 ml puff would
Actually,
would be safer in a
Deepak,
calcified.
Deepak Jayesh issue is
Sir, not
actually
for every case. I'm not
Deepak
talking.
issue. Deepak Jayesh issue is actually after rota you have to check, not for
Sir,
after
he is
balloon and
talking
all.
about
He's
safety.
bothered on how many rota will produce a perforation. That is what is my doubt.
So he's talking about safety. It's just that extra 1 ml of 2 ml during the procedure may not make any difference.
You do 1,000 cases. You have one perf. You do 1,000 cutting balloon angioplasties. It doesn't perforate, but one case might perforate.
I
Agreed.
Pratap, for the youngsters, I think that lesson is after rota, they can have a check angio in a normal case. But I think here our intention was to not to push him for a renal replacement therapy.
I actually, one suggestion
So
is actually,
that is
I
why.
have done 96 cases so far. 96 cases. Two cases only. I have done 6 ml of contrast. And with that, there are 12 cases of rotablation. Nearly, I will be publishing the data very soon. Already published, and that's the largest data. I'm just telling that it is not like that. People wanted to use contrast. You use contrast below EGFR. And if the person does not want to use contrast, don't use contrast. I'm just telling that not to use contrast or below the EGFR is both are equal. That is what is I'm going to do a public randomized data I'm trying to do. Then you can also join in the study where you use maximum contrast. We will publish the data which is better.
So thank you so much. Thank you so much for all the inputs. It was a very good session. Thank you each and everyone. We'll go on to the next session.
Now lunch is open above. Those who are hungry can have lunch, but we are continuing with the sessions. Okay. We are continuing with the session. The prize announcement and the CD draw will be at the end of the session. We are continuing with the complication session. Yeah, yes.
Technically, ഏറ്റവും best case. Very meticulously done. Arshadini first കൊടുക്കണം.
Yes, yes, yes. അല്ല ട്രെയിനുള്ളവർ ലഞ്ച് ഓപ്പൺ ആണ് കഴിച്ചോട്ടെ അതിന് ലഞ്ച് ഓപ്പൺ ആണ് This winner is Arshad ഈ സെഷൻ
Then the next session is on complications. The chairpersons are Dr. Harikrishnan S., Dr. Prathapan, Dr. Manu R.
Good afternoon. We'll just go to the last session. I invite Dr. Hari Krishna for his presentation.
Good afternoon, everybody. I'm really grateful for this opportunity. Today, I'm going to explain a case scenario where I had multiple complications in a coronary intervention. It was a 58-year-old male, had ACS and unstable angina, and after stabilization, an angiogram was done. The coronary angiogram was done through the right femoral artery. An RC angiogram was completed and the picture is shown. There was a difficulty in taking the JL catheter for the left shoot. So when a sheath injection was taken, I could see the dissection in the iliac artery. Patient started complaining of severe lower limb pain, so that obviously I tried quite a bit of things through the right side. It didn't work, so I punctured the left femoral and took an injection to see what is happening. I tried to enter the right side through the left axis, but it failed. Finally, with the help of injections from the left side, I could access the true lumen from the right side. A POBA was done to the right iliac artery and the common femoral artery using a 2.75 into 15 NC balloon, followed by a 5 into 80 Armada peripheral balloon. After this, however, you see a lot of dissections and all, but the patient's pain relieved. We waited for some time and we thought we will work on this later and see as how it goes. We'll work on it later and we will proceed with the coronary artery thing, the left shoot and all with the right brachial approach. So through the right brachial artery, We did a PTCA to LAD and LCX. You can see the pictures. Nothing special to mention about that. Patient had complaints of severe bilateral lower limb pain after 2 days. So I didn't want to puncture again. So went for a CT angiogram, which showed bilateral iliac thrombotic occlusion. So it was predominantly thrombus as per the report. So this time, both the femoral axis and the right brachial axis is used. So now one axis left is the left brachial approach. So I did a POBA to the iliac artery, again with an Almada balloon. And you can see the results. Slightly you have pulverized or macerated thrombus. And I think the last, you can see some amount of distal flow established, but not great. At this time, since it is thrombus, I decided to give intra-arterial retiplase, half dose. As you know, retiplase comes in 2 vials and 9 milligrams each. So after giving the retiplase, the flow was established. So this is the left side. I think so this is the left side, right is over, and this is the left side. And you can see the pictures. We didn't have stents at that point of time. So we thought, again, if there is a problem, we will go ahead and stent it. And we asked for the appropriate stent sizes. And if it goes this way well, that's also another way to go because of, as you know, about the long-term results of ISR in long peripheral stents. So this is just to highlight. Sorry. One more thing. Everything is okay. Now the angioplasty is done. There is good supply to the lower limb. But the next day, there was a right brachial site hematoma, which is really big, which nobody noticed because that was a puncture site which was done 2 days back. We didn't notice it much, and we were always looking on the left brachial side. He was complaining of a pain that during the round somehow it was seen, the sisters noted, and that was really unexpected. And he had to have vascular surgery support. Surgery was not done, but they did some decompression and did it conservatively. So the take-home message is, access site complications are unpredictable. Acquiring basic knowledge and making available basic peripheral hardware in the shelf is important. When you're using intralytic agents intra-arterially, you should be careful about all the punctured sites because certain things which you think is done and abandoned could be a problem for you later. So the expertise for a peripheral intervention is an add-on during critical scenarios like this in coronary intervention. Thank you.
Thank you, Harry, for that interesting case. See, when you initially punctured, there was an retrograde dissection. There was a dissection on the left iliac also. How did this happen? Did it happen because your initial procedure was through the left side and it went on well? So we saw the subsequent flaps on the left iliac also. When it did happen? Did it happen during the balloon dilatation of the right side?
What I understand is he had significant disease in both sides. He had disease which we had not recognized earlier because the pulse was palpable. So we had not studied it earlier. So after doing whatever, as you said, right, there were dissections on both sides and thrombotic occlusion at that level happened on both sides. It's somewhere between the procedure it should have extended.
Harry, what I feel is that this is more not like a retrograde dissection. I feel this is an antegrade dissection which is produced by the withdrawal of the catheter. it would have pulled off the endothelium at the junction. It would have created an antegrade dissection, which has gone into both vessels and produced thrombus there.
So
This is more likely.
When you initially, there was no wire in the vessels. Then when you passed a wire and how did you make sure that it was in the true lumen? Did you do anything to find out there is a true lumen?
After the right coronary angiogram, I came out, and when I was taking as usual, taking the left catheter, there was some resistance. Then we started looking about it. What is happening? Otherwise, for an angiogram, we don't think much. After the right, it goes to the left.
One question. Nicely managed, Hare Krishna. My question is regarding your brachial access.
Yeah.
The way you puncture, do you have counter puncture or just only luminant puncture?
Very minimal puncture. Counter puncture will be, as we all know, it's going to be.
Ideally, when you are accessing the brachial. So
Normally, I just
do.
feel the pulsation, and you get a nice jet as soon as you.
Exactly.
As you
should not counter puncture in the.
I don't know whether we have to use a micro puncture set and all, but I used to use the same radial needle.
Because people have an inherent fear of accessing the brachial. But this is an excellent route.
Yeah, many times I do. I know the complications could come there as well.
Harry, just one point.
Yeah.
Most likely because the diseased aortic bifurcation,
Yeah.
and then attempting an O14, you try to wire using an O14 wire, and manipulating the catheter could have traumatized the origin of the left common iliac as well, because the thrombus formed essentially because of an flow limiting dissection on either side.
On either side. yeah.
Alala, Ashish, I just wanted to ask you, he actually passed a wire into the right, then he is taken in left. But when he actually taken the wire, and then the second time for correcting that right system itself, he has taken a wire. He's asking that how are you sure that you are in the lumen, true lumen?
Now, there are two things. One is you have come from the true lumen because you are from the femoral axis, and you have reached the aorta, then you are in the true lumen.
But actually, he dissected the vessel in the proximal
That
part.
is okay. Still, if you have passed from the true lumen to the true lumen, it is fine, especially if you are planning to stent, then there is no issue.
But actually, he planned to stent, and actually, later on, that part was left away.
And I was really surprised that actually, after you use the brachial for your PCI, you could have completed that from the left femoral axis. You had the axis that time itself. It was done in one sitting, right?
Yes.
So you had a left femoral axis.
Yeah, he didn't prove that.
And then why did you take the brachial axis for that?
That reminds me some point. There was some resistance again at that point of time on the left side.
No, actually, this is one thing which I would like to press on the juniors. See, we have always have a tendency to finish the procedure as early as possible. We take the catheters without the wire support. This would have produced. This is my postulation here. This would have pulled some endothelium from that junction, and it has created antegrade dissection. Retrograde dissection. How many of us have seen retrograde? How many cases we have seen? It does not produce this much of problem. It won't extend into the left anyway. This is antegrade dissection which has occurred either at the distal end of the aorta or at the bifurcation.
Our point is very simple. He has actually tried the right femoral axis, then left femoral axis. He was telling there was resistance. Then why did you choose a brachial route for doing intervention? Why don't you take a radial? Right radial. Your purpose is only to do intervention to the coronary artery, right? Or your interest was to do the bilateral common iliac intervention, then it is okay. Why a brachial route? I did not understand. No. His purpose was to do the coronary intervention. He did a coronary intervention through the right brachial route. Why?
Coronary intervention was done through which route?
Right brachial route, but then also we have some problem there. If you need to reach there after because the idea is to, after the angioplasty, I had an idea to reassess what's happening there. What's happening there?
The iliacs also. That is why he took the brachial route. Yeah.
So you anticipated that after doing the coronary, you will actually go to the common iliac and
can do something.
Just see what's happening.
Just a question. If something similar happens, just my understanding, would no. Would people do angioplasty at the same time, or would you just wait till this is sorted and do that?
You will be desperate. I'll be upset because this thing happened. Then let us settle everything and then go ahead and do the antibiotic. Only tension in this case. Actually, the patient may go to another hospital. That's only tension. I think.
No, Pratap. See, I think what we should do.
No, please. The
Sorry, what?
chairperson, actually, JS told chair is the final authority. I learned that. Now you just keep quiet. Okay.
No.
Now, Ashish.
See, what I would do is I would finish the. See, you have dilated. You have the sheet there. You have the wire across. The vessel is not going to close off. You can finish the coronary intervention from the right femoral axis itself. When you come down, you tackle and seal the iliac dissection. That is what I would have done.
Last comment.
Same thing. You have an access through into the true lumen through either right femoral or left femoral. Why do you want to lose that by taking it out and go through another route? I would have finished the same route. Maybe I would have finished the coronary, or else I would have finished the femoral first.
From the right femoral.
From the left femoral also, he had access through either
He told
side.
he's not able to take the
Yeah,
wire.
left femoral also showed a resistance. So,
No, but you were into the true lumen and the aorta, no, from the left femoral. You entered.
there was some resistance when you're going up the aorta. There was something, but the patient was not complaining of any symptoms when I was planning the angiogram. So I just kept in mind that in case I want to go down, we should go in the brachial to come down to the.
I think, thank you, Manu.
Okay, thank you, Rishna, for the nice
Thank you.
case. Let me invite the second presenter, Dr. Matthew Joe.
Good afternoon. The case is about complication we had to encounter in a patient who presented with ACS. This is the patient's profile. He is a 47-year-old male, smoker and diabetic, presented with acute onset of chest pain of 8 hours duration. ECG was suggestive of inferior wall MI. So we took the patient to the cath, and the left side injection showed a proximal 80% tubular lesion in the LAD. And the cranial shots showed that the heterocollateral is being provided to the distal crux region of the RCA. And the right side injection showed a mid-total occlusion. So, and some homocollaterals could be seen to the distal RCA. In the lateral view, a channel was seen in the lateral view, and we used a run-through NS wire, and I could easily track the wire through the channel to the distal crux region. So I thought I will dilate the mid portion so that the flow could be established at least till the distal crux region, and this acute occlusion would have occurred in the mid region, and dilated the lesion with a 2 into 12 mm SC balloon at nominal pressure, and this was injection immediately after the post dilatation. This was coronary perforation leading to frank extravasation of the contrast into the myocardium. Immediate transthoracic echocardiogram was short, and there was no pericardial effusion. So immediately we reversed the anticoagulation with IV protamine sulfate. 70 milligram of protamine sulfate was given. Unluckily, the patient immediately developed bronchospasm and hypotension, and we have to tackle it with IV hydrocortisone and IV adrenaline. At the same time, there was a drop in BP, and we had to, because of respiratory compromise, we had to intubate the patient. And with the same balloon, I immediately dilated the proximal RCA, and a balloon tamponade of the proximal RCA was given for about 10 minutes. And the check injection showed continued extravasation of blood into the myocardium, and there was evidence of expanding hematoma. So this is the hemodynamics at the time of expanding hematoma, and there was evidence of pulsus paradoxus that the patient was going into cardiac tamponade, and which is a form of dry cardiac tamponade. This is basically because the hematoma expanding into the myocardium has led to the compression of RA and RV, leading to a mechanical form of tamponade. So this is emergency echocardiogram near the we performed, and you can see a hyperechoic region into the RA-RV region, and with intramyocardial hematoma causing RA-RV collapse. So what we did was we introduced a microcatheter into the immediate mid RCA region, and autologous subcutaneous fat embolization was performed, and through the microcatheter. And this is the angiogram after the embolization. We could seal off the perforation, and the last this still image showing intramyocardial hematoma and staining of the myocardium. So after this, we could restore the hemodynamics. The patient, the BP was stabilized, and the pulsus paradoxus disappeared. So the take-home message: hematoma, even it is a myocardial, it's not a benign condition. It's predominantly described in patients with prior history of CABG who undergo PCI. Early recognition of hemodynamic instability is important since an initial bleed may appear contained only to progress in a relentless fashion. So what happens is a vicious cycle. Hematoma can expand through the myocardium. It results in avulsion of the perforating vessels, which leads to further bleeding and further expansion of hematoma, and the cycle continues. So this propagation may continue despite sealing of the index perforation. So it may take several hours for the hematoma to expand. Therefore, initial clinical stability may convey a false sense of security, and strongly the patient has to be monitored for the hemodynamics continuously for the next 5 to 6 hours at least. So because the patient can develop hypotension anytime. So what are the potential complications? In this case, the patient developed cardiac tamponade. Otherwise, sometimes the hematoma can expand and compress the epicardial coronary arteries, leading to angina and sudden cardiac death, RV or LV outflow tract obstructions. So management of perforation, balloon tamponade, covered stents, coil embolization, autologous fat embolization, emergency surgery. How does it present? It may present acutely at the time of PCA or in the immediate post-procedure period or subacutely. Majority present 1 to 5 hours post-procedure. Most common initial presentation is hypotension, subacute presentation. Less common initial presentation, cardiogenic shock and cardiac arrest. Most cases of large RV hematomas can be managed conservatively. Conservative management includes a watchful wait approach and IV fluids. AV groove hematomas can be difficult to identify with transthoracic echocardiogram and best diagnosed with CT. Always remember, in a patient with hypotension and no effusion in echocardiogram, suspect intramyocardial hematomas. Thank you.
Can you show to the first? No, just don't go away. Can you go to the first angiograms? Second angiogram shot, I want to see. Next. Okay, just keep. Actually, where was the track? How can you go? Can you show me a way you go?
This one, sir. Easily tracked through the like.
No, wire actually easily tracked through. Their next is actually shot is showing.
Yeah.
The wire is down. Where is wire? Where is the wire? Next.
This is
This is gone through, not into the vessel.
Any collateral from the left injection?
No.
No, I just wanted to tell you that. How do you dilate a balloon with a balloon when you are not in the vessel? This is the most important thing. The other part is the second part is actually a different thing. Actually, this is an important message when you are actually putting a wire down. If you are not sure that not in the vessel, how do you dilate?
2 millimeter.
No, how did you?
Actually, Natarajan, please don't give a wrong message to the operator. Let the operator tell 1 minute. Let the operator give a chance, please.
So
Are you sure that you are in the
we could see the distal crux region getting filled from the left system. So the first initial resistance I encountered was at the distal most region. So I stopped there, run through NS.
No, when you look at the wire movement, I'm just telling you, wire movement indicates you are not in the lumen. That's what I just wanted to tell you. This
Probably,
is the
sir.
only thing I
Yes,
just
sir.
want. The wire movement is definitely telling you are not in the lumen. When you are not in the lumen, the first message in intervention is you are not in the lumen, don't dilate.
Yes, sir.
And just
Yes, sir.
check. If you are not sure, take one more axis. You are actually a born student. You are going to become another aggressive intervention cardiologist in the future, replacing Pradap. So you just go on to the other side and then show that you are in the lumen. If you are in the lumen, dilate. This is a very important thing that is actually created all the problem. Rest of the problem will be discussed with Dr. Hari.
It's a very important thing to recognize that patient having features of tamponade without any obvious effusion, and you have to consider this, especially in post-CABG patients where you have significant additions and it can compress the atrium, producing this problem. That is one important thing to recognize. Yeah.
And moreover, you can take a small balloon, a low profile balloon, and just daughter it before dilating, and then take a check.
Yeah, I should have taken a check angio before dilatation, which was my mistake.
Natarajan.
Moreover,
No, apart from the wire not being in the vessel, etc., I think here the culprit was probably the LAD. The RCA was collateralized by the left system. The critical disease in the LAD has caused an infarction at the distance, and probably the LAD should have been addressed. And
Natarajan, actually, ECG shows MI, inferior wall MI. Right?
No, with so much of a T wave, symmetrical T inversion from V2 to V6, etc.
Can you go back to the
It could
one
very well
shot
be
back?
possible.
Just
It
go.
could be possible.
Now, ECG shows ST elevation in 2-3 AVF, no?
Yeah, there are some changes in the lateral V4 to V6 also, sir.
Can you go?
Sibu,
Okay,
Sibu.
okay.
Sibu next.
So it's not
Sibu,
a
Sibu.
it's not a
We have to
technical
give
thing.
some respect
Can
to
you
Sibu.
can we give 70 mg of protamine because maximum recommended is 50?
The 1 ml is 10 milligram.
More heavily,
There is a recommendation up to 50 only.
even if it is 10,000 heparin.
10,000.
Yes. Up to 50. That is all the textbooks and all the
Protamine allergy also.
protamine.
Yeah.
All
Moreover, the
50
dictum is that
maximum.
once the coronary hardware is inside, you should not give protamine heparin reversal. Only after removing the coronary hardware, you should give protamine. Otherwise, the chance of further thrombosis.
There is a recommendation
inside the
50
coronary.
only.
But here
But,
there is no problem in thrombosis because the vessel is actually
completely occluded.
The vessel may be occluded from the proximal part itself.
Patient mid occlusion, we had to, there was ongoing
One person
hematoma.
is
So.
one person. Pratap, for your information, mid LAD occlusion, here it's not an occlusion, can have ST elevation in 2-3 AVF, even if the RCA is not occluded, for your information. How do you localize anterior MI before the diagonal, after the diagonal? After the diagonal, No, I'm telling you.
This is learning. Actually, teaching the people. Actually, I'm making him to teach you, man. You just. Okay, go ahead.
An occlusion of the LAD, here it is not occluded, it is subtotal. Occlusion of the LAD after the diagonal can have reciprocal ST elevation in 2-3 AVF. What I'm trying. No, you are an aggressive interventional cardiologist. Once in a while, you should also see the ECG.
No. Basically, no. Actually, the person who is sitting there, actually,
Arshad.
the proximal LAD to be stented, okay, correct. But they thought it is inferior MI, right? RC occlusion, right?
Yes, sir. The mid portion would have occluded acutely.
Great salvage, and we will get definitely a false sense of security when we see that in fact the echo there was no blood, there was no blood in the pericardial space, and you promptly detected pulses, paradoxes, and all. In fact, that's very good. But just for the matter of learning, how did you do this autologous fat infusion? What was the microcatheter used? Was it a 0.014 compatible microcatheter or 0.018 compatible?
0.14 compatible.
0.4.
Yeah. From the thigh region, we just put a small incision, took some fat, and we placed it in the proximal edge of the microcatheter, continuously gave a small injection. So with the resistance, there was resistance, but it at the end.
0.014 usually created, probably the particles will be very difficult to.
Yeah, it's very difficult. Like there was some big resistance, but
Ideally, for Arshad, the best way is actually if you wanted to put a particle inside without any damage, before giving the heparin, after puncture, you just take 2 ml of blood and keep outside. That will get clotted. And that is the best thing to take inside and close the vessel. If you are anticipating, if you are doing a CTO, you are anticipating a perforation, take 2 ml of blood outside and keep it. Then after that, you give heparin. So this clot will be useful for the vest.
So do you keep, how often you keep?
I usually don't keep. Actually, I always anticipate no perforation. I'm actually now learning electrocardiogram. Now, actually, if you look at the angiogram properly, I would have done an angioplasty to the LAD even without knowing ECG. And after that, I will definitely try to open the CTO later, probably by a retrograde intervention through the septal collateral into the RCA. This is actually my way of doing. Why I just wanted to tell you the wire movement. I was thinking is outside.
Yeah,
the
that
vessel.
we agree.
Not my knowledge in electrocardiology is very, very less. But my movement, the movement of the wire. Next. Thank you.
Yeah, I think. Thank you. I will move to the next case while the discussion is going on. Yeah. Next presenter can come.
Natarajan, continue the discussion. No. Definitely in this case, my interest was actually wanted to show the angiogram, the movement of the wire. That was the only point to show to the crowd. That's the only intention. Actually, they have done a wonderful work. These type of hematomas sometimes will be ending in surgery also. Because actually there are septal hematomas, people actually enter in surgeries.
Pradap, can I take over?
Yeah, please.
Baleshwan, you will get a lot of questions from the audience.
Thank you. I'm presenting you a nightmare. Production is, of course, the person who does it. and the direction you'll have to do. And the supporting crew is, of course, the cath lab team. The plot is about a 60-year-old lady with diabetes, systemic hypertension, dyslipidemia, who presented to us with CAD interval and STEMI, with symptoms for more than 2 days. Strongly positive troponin, moderate to severe LV dysfunction, mainly interval territory hypokinesia, but involving other areas also. HbA1c 10.9, serum creatinine 2.1, AD pulmonary edema, initially managed medically, and then taken up for coronary angiogram. Of course, a high-risk profile was given to them. Fortunately for me, the left shoot shows a short left main, tight lesion the circumflex OM, a tight lesion, very tight lesion the mid LED, diffusely diseased LED. Beyond that lesion also, if you can look closely, there is some long segment disease in the mid LED, which I thought initially was mild. So it was a simple, straightforward LED intervention, wired with whisper. That was an extra support wire, initially pre-dilated. Pre-dilated with 2.5 to 10 millimeter balloon. But then, and in the proximal dilatation was also given because that was a long segment lesion. But then the plot, there was an acute change in the plot. The wire had disappeared basically because it had stuck, the balloon had stuck to the, it was an aux balloon, aux wire. I had to take the whole thing out because it was not coming out. Fortunately, nothing had happened there. There was mild dissection. But I could pass that dissection. I was expecting problem with that dissected segment. But after that dissection, there was some problem. You can see the wire movement there. So I thought there is something there where I have not dilated. But I could go with a loop. That area was tended. The initial area was tended, 2.5 and 8 millimeter drug-eluting stenting. Then going back, I thought there was some problem with the distal, mid to distal segment because I had created some dissection there. There was something wrong. So I thought I'll go with S10 at 2.5 into 28 millimeter drug-eluting stent. It could easily be passed, no problem there. But once I started dilating, then I thought there was some problem because the patient started having pain. This was really horrifying. Immediately the BP was starting to drop to 70. All real nightmare. BP falling, heart rate coming down, apparent reverse. What all things I did, I don't know. Pumping fluids. But the thing is that I never used, without an angio, which we discussed last time, with check angio, I don't remove my balloon usually. That saved me. I kept the balloon inflated. That gave me enough time to get my other portfolio into action, the covered stent. Fortunately, that was there. But taking that covered stent through the initial stent, I was thinking all possibilities, how exactly I can do it. After keeping this, patient started having pain because ST started elevating because the balloon is already long-term dilated there. Mind you, this was after protomin also, so that was another thing. So these things usually you do reflexly, and then by the time I removed the balloon, the patient started arresting. CPR initiated. With that CPR, I could somehow push my covered stent in. It was a graft master, dilated it. There was some proximal dissection which was with all this various gadgets in, that was tended, and ultimately it was a good result. That is the final result. shifted to ICU in a stable state. There was only very minimal pericardial effusion. 1 pint of blood transfusion given, stabilized, discharged on 5th day, doing fine for the last 4 months and still counting. The take home message is nightmares, do visit each one of us. If you have sleep and good dreams, nightmares do visit us without fail. Proper anticipation, proper stocking of hardwares and proper teaching of support staff is the key to escape unscathed. Nightmares do make us gasping with awe, but they are also teaching and testing us on character, the skills and temper and presence of mind. Thank you.
Thank you, Balasham.
Balashna, can you just go back to the angiogram and show us why you pushed the...
I have no access
stent?
here.
No, the angiogram is here,
No, I have no access. You asked them.
My question is actually why you pushed the stent down?
Which one?
Can you show it again?
Which one?
You actually, the stented in a non-diseased part, right?
No, actually initially I stented the proximal to mid-lady. Okay, the angulated part.
What was the length of the stent the first time?
Then I could have, can I go back on that? I don't remember actually. It was 2.75 something into, which stent are you talking? The first stent?
First stent.
Yeah.
Next.
Yeah.
No, this is after dilatation.
Dilatation.
Next. This I think is 2.75 to 24 millimeter.
What was the size of the stent which was used distally?
Distally it was 2.5 into 24
now
something.
he's going to take the stent. Now he's going to take the stent.
What was the indication? What did you feel? Why did you think that we need
The
to
second stent.
Second stent.
Second stent, there was some problem in negotiating the wire. One, if I get a dissection there, it was a dissection. I thought there was a dissection, and on the check angio also there was some haziness there. Can you see that haziness? Some haziness there. Immediately afterwards, there is a bridging. That bridging was not producing this sort of problem in the first check angio. So there was something there.
That actually this point of time,
I could have got out of the cath lab. Very true.
How many people would have put a distal stent rather they put a proximal stent and come out, right? Many people would have put one more proximal stent and come out. How many people would have put a distal
And
stent?
on another day I would have done the same. But
did you
here I thought this is a distal dissection. After stenting the proximal part, if I get a distal dissection, I may have to come back again on the same day for the cath lab to do one more intervention.
Did you consider imaging at this point?
Yeah, that was not available at the time.
The point actually this I just wanted to show that the one more stent down actually created all the complications.
Yes.
Actually, if you put a proximal stent and come out, finished.
Done. Acute coronary syndrome. Sorry? I didn't get you. Direct stenting. No, this was a direct stenting only. The second one was direct only.
No, initially you pre-dilated.
That was a very tight lesion here. It was not NSTEMI. It was a very tight lesion, fibrotic lesion.
It's a class 3 perforation, very unlikely to settle with a balloon tamponade.
Yeah. My intention was not to tackle with balloon.
Yeah.
It was just to consume the time, to get the time, that's all.
You could have taken a second puncture, ping pong catheter, while tampering with the balloon, you can take another catheter and took that covered stent with a pre-wound and a wire.
Manu, that is too much of theory. He can keep the balloon there. By the time he can arrange the graft master and bring it.
Ideal way of doing a type 3 perforation is you keep the catheter there, balloon tamponade, take a second catheter, cannulate, and take the wire down, and then take the guide graft master. That is the ideal way of.
That is the ideal way,
that is actually you tell it is not teaching. It is the way people do.
But it's much more time.
Let me tell you something.
No, it is actually if you are doing like that, you can actually avoid all these pericardial tapping and all those.
There was no pericardial tamponade here. There was no pericardial tamponade. Hardly anyhow. It was just hypotension, bradycardia hypertension. That's all. That happens. And one more thing. Whenever this is to the youngsters, whenever you have hypertension, bradycardia, you always think about hemorrhage somewhere. This is what I have heard. Whenever you have massive hemorrhage somewhere, patient immediately goes into hypertension and bradycardia.
one
There
more
is some vaso response there.
No, one more thing. Actually, you reversed with the heparin.
Yes.
Protamin.
Protamin.
Giving with a device inside the coronary.
No, all this are possible. Yeah, when you are in this soup, you don't know what all things you do.
Balash, my point is actually just wanted to emphasize the point. What you have done is actually luckily everything is okay. Keeping a device inside the coronary and giving a protamin reversal is not right. If you are actually taking all the devices out, then you can reverse it.
So there are two schools of thought. You could either, if you plan for an immediate graft master, then go the opposite groin, get the graft master and settle the issue. If you're planning for a prolonged balloon tamponade, it's also recommended that you can do half reversal of heparin, wait, disengage the guide catheter so that you do not have a lot of catheters inside the coronary, half reverse heparin and then wait for balloon tamponade.
Actually, if you take the graft master down and then reverse it also is okay. Take the reversal and immediately after that.
Pradap, one more thing. This taking the graft master, all these things are easy to say. But when you have this problem, to take it into the distal LED through the first stent, it is much more than nightmare.
What was the graft master size used?
It is, I'll tell you.
Okay.
Sorry? No, I still don't know because I still feel I checked the balloon that was not perforated. It was properly deployed. Otherwise, I could not have pushed the graft master there at all.
No, that's a bridge segment, myocardial bridging, standing in
There was no significant bridging and all. There was systolic bridging, mild systolic bridging. That's all.
Okay, thank you.
Thank you, Balakrishnan. Wonderful case.
Move to the
Come to
next,
the
madam's case.
That means you will have a minimum 10 minutes more discussion, and I will not get a chance to talk, madam. We should be getting a chance to talk.
Sir, a request.
I'm sorry, I'm a bit scared after all this discussion to present this. I also have to say that much of the heroics in this case have been done by Dr. Praveen, my assistant and my colleague. So this is the late follow-up of a Ellis type 3 perforation. The patient was a 60-year-old man who had an anterior wall MI and was lysed in March of 2015. In April 2015, he was taken up for CAG and ad hoc. His echo showed regional wall motion of the anterior wall territory. These are the hardware used. Now, as you can see, he has a large diagonal and the LED is not seen well. So, though it was only 1 month, we classified this as a JCTO2, score 2. And a CrossFit XT wire was taken. I know it was only 1 month later, and you can see it's slightly outside the lumen. So, leaving that wire there, a Progress 20 wire was taken. Is it stuck? Because actually yesterday I checked everything. You can see a second wire has been taken, and this was escalated to a Progress 140 wire. Yeah, there are 2 wires there. The original wire is there and the second wire is there. And then while the wires were there, you can see that a small perforation started. So when the small perforation started, heparin was reversed. I'm sorry that we reversed it. And a small mini-trach balloon was used to dilate proximally. But actually nothing happened. And this is the balloon dilatation. Yes. And after balloon dilatation, the leak increased. So actually, in this picture, you can see the wire is hanging loose in the pericardium. So at that time,
madam, the same wire movement I was telling about earlier. Same wire.
I know, I was waiting for you all to crucify us. But at that time, we didn't realize that the wire is in the pericardium. Only now we realized it. But we have done further mistakes. That's the funniest part. So here the wire is in the pericardium and we are doing a balloon dilatation and the leak has increased. So then we did what you said. We have gone through the femoral route and through a guide, we have put a prograft. A prograft is a covered PTFC stent. PTFC stent by vascular concepts, just like a graft master. Okay. Now you can see the leak after putting the prograft. So now we are really in a tight situation. Patient is having chest pain. Patient is having tamponade. The patient is pericardial aspiration has been done. I removed those slides. Otherwise, it becomes 56 slides. 56 slides. So finally, we did what we have done for a femoral perforation. We have taken a microcatheter and taken a little contrast in a bottle, in a beaker, and we have scraped ab gel in that. And this ab gel with contrast was taken in a 2 cc syringe and introduced across the wire, and the bleeding stopped. So why I'm presenting this is, one is because the patient recently came and saw me in Ramakrishna Mission, telling, Madam, you were there when I was in the ICU for 10 days. The second reason is, when I went to the Sky meet in Bombay, not in US, they didn't know.
This case finished?
Yeah, no, not finished. I'm in the middle of my talk. I'm just telling an important thing. The people there did not know that ab gel can be used to close a perforation. So we have closed a femoral perforation and it's published already. It's published. So that was in 2017. This is a coronary perforation.
Madam, go
closed.
ahead, madam.
So now
we are
this is
waiting for the case.
almost finished. So this is the post-procedure ECG showed.
What happened to the patient?
Patient's alive. Patient, I'm presenting the 7-year follow-up. I am presenting the 7-year follow-up of this patient.
You closed the vessel with the abgel.
Yeah.
Okay.
And then see, this is the echo. This is not a moving picture. After, there's only little, but already tamponade was there, tapping was done, patient had hypotension, all those things. I removed the slides because it becomes 56 slides.
Okay.
So, the messages from this paper are, the leak stopped. The messages from this paper are covered stents tied over the crisis during a perforation. But their long-term outcomes are not very good. So,
Madam, actually, where will you put a covered stent? That is the most important.
yeah, it has to be put in the coronary artery. We were
Actually-
outside. So I fully agree. This is, I was anticipating all this. But see, so I just want to tell you the follow-up of, so just give me 2 more minutes and then you can discuss. One is, what is the follow-up of LS3 type perforation? 21% mortality according to Antonio Colombo. And TLR is 13%. This is 1-year follow-up. And these are the different techniques used to seal perforations. Now, this is the echo of my patient. His ejection fraction is 40% and he has mild MR. So, the purpose of presenting was to show him after 7 years. And coils can be used for perforation. I just wanted to tell you that LS type 3 perforations have been studied in 3 named registries. CRACK 1 I have not put, CRACK 2 registry, and I'm coming to the other thing. In the CRACK 2 registry, GraphMaster was compared with Papyrus stent, and GraphMaster had more TLR but less mortality. And the second natural history, it's called the Glasgow Natural History Study of Covered Stent Intervention. It's a love for perforation. Sure. Finished. I finished.
I just wanted to understand that.
Yeah.
When you have a perforation,
yes,
where will you put the stent? In the coronary or from coronary to the pericardium?
Now see, only when we put the covered stent, we realize that we are outside. We should have looked at the motion of the wire. Now I know that. But at 2015, we didn't know that. This is 2015.
Madam, actually, basically the wire,
Yeah.
the first wire was outside the
I saw that.
coronary. The second wire was outside the coronary.
Yes.
You dilated the proximal part
Yes.
and put a covered stent from the coronary into the pericardium.
I agree.
So that is why this
100%.
all problem.
I
And
agree.
then later on, you put
Madam, where did you put that gel? Which part? Which part?
The
of
proximal part of the coronary. That is,
proximal part of the covered stent.
no.
Proximal
Before
part
the
of the-
covered stent.
Before the covered
You can see, no, that the covered stent is below the abdomen.
Okay, I understand.
Yeah.
it is like ligating the coronary proximal to the covered
Unfortunately.
stent.
No.
Madam, fortunately for the patient.
Allah, the thing is, see, this is an LAD patient. And we have occluded the LAD more proximal than his lesion. See, that's the funny part. But we are lucky. So my theory is it must have been a chronic total occlusion.
Madam, actually,
So the patient tolerated the closure of the LAD.
Organizer is hungry. So thank you for the presentation.
Yes.
We'll go to the next. Organizer is hungry.
Okay.
Next presentation. Very good case. Deepak Davidson. So ask some questions also. Crowd should be ready.
To stick to 6+2 the timing because many have to go by 2:45 train and 3 o'clock train.
Yeah, I shall do
So
that.
we have a CD award session as well.
I shall do that. Thank you so much for the opportunity given. This is not a very exotic case like whatever we've seen till now. It was a challenging case done in a different hospital. This was an elderly gentleman, 80 years old. He had an effort angina. He underwent an angioplasty to the proximal left anti-descending artery while in North India. You could see that the proximal LED, mid LED has got a tight stenosis. It was a calcified lesion, so they have done a rotablation, they have done cutting balloon dilatation, and that was how the stent was deployed. You could see that stent positioning is actually 3-4 millimeter beyond the ostium of the left anti-descending artery, and following the stent implantation, this was the result that they could achieve, a reasonably good result, a proximal LED mild, the ostial LED mildly diseased, but then the flow is good in the LED. Exactly 1 year later, while he was in Kottayam, he had an episode of effort angina, and he was admitted to a nearby hospital. You could see that they took him up for a repeat angiogram. There was critical stenosis in the proximal left anti-descending artery. So it was just one year after the first procedure. The first procedure did not reveal so much of significant stenosis in the proximal left anti-descending artery. Within 1 year, this was the lesion. So they thought that it was a very simple lesion and decided to do a balloon dilatation and a stent implantation. That procedure was done through the radial approach, 6-French guide catheter. However, they were able to wire the vessel very easily. However, the balloons wouldn't go across. 2.5 wouldn't go, 2 wouldn't go, 1.5 would go, but then they were not able to dilate it and they were not able to retrieve it. When it got stuck over there, and then the patient started developing hypotension, the patient had to be initiated on tirofiban and noradrenaline, and the patient was referred to us. They felt that it was a calcified lesion, and for rotablation, the patient was sent to us with the sheath in the radial artery. Now, patient was also on tirofiban. This was the image taken there in a cath lab. The vessel was flowing well. There was no problem. The patient was hemodynamically also stable. We were able to taper the noradrenaline. So it was a calcified lesion. They were not able to get the balloons across. So we decided on going ahead with a laser ablation to the proximal left-handed descending artery because it was a balloon, uncrossed balloon, undilatable. Of course, we could have gone with the rotablation also. We decided that we'll go with the laser technology. I wouldn't go through the further things about that. This is how the laser bubbles would expand and collapse, and this is how you would make the vessel more supple in a difficult lesion, and you could also adjust the energy that's delivered. Once you adjust the energy, then the bubble size will be much smaller or bigger. You can ablate more inside a heavily calcified or a difficult vessel. Then what we did was we gave contrast during the lacing. You could see that we were injecting contrast during the lacing. What happens during contrast lacing is this image shows you that when you have the laser catheter inside the saline, this is how the lacing is done. But then when you keep it inside contrast, you tend to have much bigger bubbles, and you tend to have much better ablation of the lesion. So this was the image following the ablation. You could see that the vessel is opened up reasonably well, both in the caudal as well as cranial view. You can see that compared to the pre and post images, you can see that the luminal gain is really good. In the cranial view also, you can see that following lacing with contrast, the luminal gain is really good. Then we decided on cutting balloon. so we also did an imaging followed prior to the cutting balloon. This is just to have a look at the lesion, what exactly was happening there. You could see here that this is the stent landing over here, and this is the circumflex, almost 6 millimeters. It was beyond the ostium of the left anti-descending artery. You could also see that there is some tissues inside the stented segment, but then most of the tissues is actually proximal to the stented segment. You can see that this is the sort of lumen that we could achieve. It was 3.28 millimeter luminal gain following contrast lacing with a 0.9 catheter. You can also see that there is some eruptive nodules over there, and it can be better appreciated here. This eruptive nodule was actually preventing the expansion of the previously deployed stent over there. And these are the images of the eruptive nodule that we made out in the proximal left anti-descending artery. You could see that this is the eruptive nodule. You can also see that there is a nodular protrusion there at the proximal, that is near the circumflex ostium. There was a nodular protrusion there. So seeing all these images, we thought that we'll go with a cutting balloon. That was how the cutting balloon at 1820 atmospheres. Wolverine wouldn't open up over there, so we decided that we should go ahead with an intravascular lithotripsy balloon, that is 3.5 lithotripsy. We positioned it right there and delivered almost 80 pulses over there, and that was how the balloon opened up. And then you could see that in the next image, the vessel is fully opened up. The nodule has been totally gone. Then we again did an OCT and identified what exactly had happened there. You could see that there is some amount of there is some amount of disruption of the lumen, there is some amount of dissection there, but then the entire nodule has been deformed. You could see here that in this frozen image, this was actually the nodule. You can see that the nodule has been fractured, the nodule has been deformed and compressed also. In the second image, again, you could see the same thing. You can see that there is a small dissection over there in the opposite segment. Again, there is a fracture there with the IVL. And finally, this is the circumflex ostium. This is the left main bifurcation. Again, you can see that there is some amount of disruption. So we could achieve a proper luminal gain with laser followed by IVL. And then we went ahead with the stent implantation. It was post-dilated and with 4.5 and 3.5 non-compliant balloons. And these were the final result that we could achieve. And the final result, following the stent implantation, this was OCT evaluation. You could see that we were able to achieve good luminal gain. Ostial LED, it was 9 and 10 millimeters, and left main, it was 12 and 13. 12 and 13. This patient had...
Deepak, no complication.
What is
Sir, they were trying to get the stent, trying to get the balloon across into the proximal left anti-descending artery.
This is actually
patient,
a laser stroke.
Thank you so much. I am done with that. Thank you so much.
No, just a comment. Basically, because I was waiting for some complication to discuss,
So that was
No
it was a
complication
nodular
means
calcium, which was not anticipated. It was 1 year following the stent implantation. They expected that it was a soft lesion in the proximal LAD. None of the balloons would go. 1.5 balloon got stuck there. It produced hypotension, and the patient was referred there with hypotension. And we were able to manage it.
But there was good flow when you saw the patient. What was the reason for hypotension?
So during the balloon dilatation, the balloon was not dilating properly, and patient had hypotension, and that was the reason why patient was referred.
Lab, if there was no laser, anyway, discussion point of him telling. If there is no
Rota
laser,
would have been.
you will not do this case.
Rota would have been right.
Okay, so the cost would have come down drastically. Rota and a cutting balloon would have reduced the cost by nearly 4 lakhs rupees. So the people who are having more money go to rubber city. People have less money come to the cashew city. I think cashew city means Koilon.
Thank you, Deepak.
Thank
you. Demonstrating an excellent
Thank you so much.
laser, because the problem is we are expecting more complication to discuss.
Thank you so much, sir.
Thank you very much. And the
Next,
Abhilash is very much. Gobi, show some complication, please.
Yeah. Just get the slides on. Yeah. So probably here we will have something to drill on. So here it's actually the straightforward usual scenario of a simple case turned into a nightmare. Straightforward angioplasty turning into a nightmare with a lot of inputs coming out. So the background, it's a typical VIP, daughter is a doctor with friends abroad as cardiologist who gave us a lot of inputs, made us more confused. 65-year-old diabetic, hypertensive, CKD EGFR 30 ml per minute, and underwent a PCA to L6 in 2014. Had anterior wall enstomy, echo showing wall motion elevatory, preserved LV function, underwent an angio at outside center, patent LCX10, tight calcific stenosis in LAD and RCA, already advised from multiple centers. So she came to us with this plan, written very well. Rota with IVL, followed by a IVAS guided minimal contrast angioplasty. We agreed. We took her for the same. So we started off with, this is the They unfortunately didn't give us the angiogram CD, so we had to take 2 shots. So this is this is the tight calcific stenosis in the LAD and RCA. Fluoroscopical calcium is very well evident. We planned for rota of RCA and LAD, so we had the temporary placed in. Fluoroscopically calcium is visible, so we went ahead, agreed to their plan. We wanted an IVUS guided minimum contrast rota PCI with an IVL backup, and the daughter was very clear that she wanted to try the balloon based strategy first, get imaging done, and then only rota. Okay, we agreed to that. So we had the right femoral.
Very rich daughter.
Yeah. So right femoral axis, 7 French guide, heparin 7,500 given, EBU 3.5. So she was in the lab. She wanted to see. She was the cardiologist was on the video call. So BMW wire, the distal lady. We wanted to image first. So the IVUS catheter didn't go down the lesion. So Caravel, so we took in a Caravel down, exchanged to a Grand Slam because we were hellbent on imaging. The image catheter still didn't go. We did a soft dilation with a 2O into 12 new balloon at 10 atmospheres, just a soft dilation so that IVUS catheter passed. And we were not checking at all during this time. Pratap sir's slide, no contrast angioplasty as per this. And next, the twist happens. Suddenly everything goes off. Patient suddenly starts severe angina, within seconds goes into ST elevation, VF defibrillated, CPR started. The patient gets on the temporary pacing. So now we have to check. And the daughter is sitting down, she is collapsed. So next. So this is the angio. This is the angio. This is so it's thrombus everywhere. Possibilities, again, retrospectively thinking, it could be a guide-induced LMCA dissection. There's a long LMCA. It could be inadequate anticoagulation. There was thrombus everywhere. We were just about 10 minutes into the PCI. We had given heparin. We thought it could be even heparin resistance, but these are all discussions now. Nothing was discussed at that time. Or it could be even that 2O balloon ruptured and an occult rupture of a balloon, which we didn't detect and could have caused all this. But so the CPR was going on. You can see hardly any cardiac contraction. On CPR, we quickly wire the LCX, LAD. LED wire was already there. We daughter a balloon 2.5, 12, daughter to LED. Wired the LCX 2.5 into 12 and dilated LCX and LAD. Gave intracurrent adrenaline. There was hardly any contraction. ACT, by that time, the floor nurse says that the ACT is 284. We asked her to recheck it. And still no flow there. But there's some pressures coming up. But this is where we are now. There's absolutely no improvement in flow. We gave intracoronary tyro, multiple thrombus suctions done. But slowly things started improving actually. We had thrombus suction done, we had balloon dilatations done. And gradually patients started slowly coming up. You can see some contraction coming up, 2.75, 20 non-compliant balloon dilated in LAD. There was definitely improvement of flow. ACT again, the floor nurse says now it's 320, but hardly there's any cardiac contraction. So now we have flow in LAD and LCX, and we wanted to stent this thing out and quickly come out. We put the LCX wire again in LAD, tried to act as a buddy wire, track to stent down. No, it didn't go. We put a balloon in the LCX wire, used it as an anchor and tracked the stent down. Didn't happen. We tracked the guide plus down. You can see the guide plus going till the mid LAD, but after that nothing would go. No stent, no guide plus, nothing could go. But and we had a calcific dissected LAD, and there was just in between the flow was still going down. So we needed to stent things down, and with this hardly contracting LAD, we didn't even think of in dreams of rotablating. So the IVL guy was in there anyway. So we thought of using IVL as a bailout, which was initially as a backup plan. We quickly took the IVL down, 312 IVL via the guide plus. The moment we started IVL, in the second cycle, the IVL opened up, but then again, the IVL ruptures. But this is an IVL granuloplasty, unintentional, but this time it does the trick. The IVL granuloplasty at the second cycle, probably as they show the bubble in the IVL actually ruptured out, the whole thing got ruptured, and by this time this is all well prepared. You have the guide plus going in down, a 3.548 does going down. We already have the LCX wire protected, we stent, and then you achieve good stent expansion, TIMI3 flow in LAD. There was a geographical miss, we anyway fixed it distally with a 3x15 stent, overlapped, did an LMCA pot with 410, a balloon, LAD post-del with 3.5, and this is where we end up with. So this is now 8 months after the case. He is doing good now. This is the final angiogram outcome we had. We had to use 90 ml contrast on ticagrelor aspirin, doing well. Creatinine increased. He was non-oliguric, but stabilized over weeks' time. Patient was discharged on day 5. He is doing good on clinical follow-up. He will never come to me for the RC angioplasty. And the creat is absolutely stable. And
you can send the patient to me for the RCA. Only one question just I wanted to ask you. You actually, what was the interest of putting anything to the circumflex? In a crisis like this, Arun,
Sir,
our focus was only on LED, right?
Yeah, truly on LED, but you have to see that we had the wire in LED, we dotted the balloon LED, we dilated the balloon LED. Still, the cardiac contraction was not there. The moment LCX wire was put, LCX was dotted, contraction happened. So the LED was preconditioned from the tight lesion earlier. LCX was a very well flowing vessel. So when you lost LMCA, LED, we already had a wire, we dotted, we
Okay,
ballooned.
Arun, if you are telling LED circumflex was the life-saving vessel, then you did not do anything to the circumflex.
No, the loss of flow deteriorated the patient. The moment we had flow in the L6, we had nothing to do. It was thrombus there. We didn't have to do anything to the circ. We needed just to restore flow. Put a wire, ballooned, just ballooned it, ensured flow. That's all.
But actually, when you took a IVL and you know that every IVL pulse will take some time, nearly 10 to 15 seconds, 15 into 8 is actually 120 seconds in such a crisis. Our other ways of doing, you would have taken a normal balloon and dilated a high pressure and dissect it. That is also one way.
That was done, sir. 2.75 at 20 atmosphere. It didn't happen. Nothing happened. Even then, the guide plus didn't go. The stent couldn't go. It was probably a spicule there. IVL opened up. The IVL blast actually created the passage. Actually.
But actually, I don't know. This patient is almost going to die because you are thinking that the patient may die. You take a balloon and dilate up to 28 or 29 atmosphere and just rupture the balloon there. Then you may be able to take a stent. See, IVL taking means the time taken. That's what I meant.
No, the guide plus was already there. Guide plus.
By that time you took the IVL, the patient was relatively, blood pressure started coming up.
Blood pressure had coming up. The guide plus was there. We were able to track balloons down. But any balloon, whatever non-compliant we tried, didn't allow guide plus to go down or the stent to go down. Only after we had anyway the guide plus there. We hardly took any time to track the IVL down.
Already IVL was ready.
IVL backup was there. So the guy was in the lab. So that's when we looked up. That's why the take-home message, you didn't give me a time, but the take-home message is some. But sorry, the take-home message is a backup IVL can be a bailout IVL in a calcific terrain.
Okay. So actually, a nice case.
Nice
with,
case. Well
some
managed.
complication was there, even though the result was very good. The patient is not coming back to you.
We'll send it to you, sir.
So we'll move to the next one.
Good afternoon and all. After seeing so much of complication made by smaller stents, I'll try to see a larger stent. An embolized TAVI done during TAVR post-MVR. This is our patient, 76-year-old male. He was diagnosed with rheumatic heart disease and severe mitral stenosis. He underwent closed mitral valvolectomy in 1972. He underwent mitral valve replacement with 30 star Edwards process in 2006. He started worsening symptoms with he had 2 to 3 breathlessness since last 5 years. He was diagnosed with calcific severe aortic stenosis and mild aortic regurgitation with mild PH, with controlled heart failure. He is diabetic and recurrent hyponatremia with erythral stenosis and frequent dilatations. Echo showed good LV function with the aortic wall gradient of around 120 by 54 gradients and aortic velocity of 4.8. Mild AR, mitral process gradient was fine, mean was 3, mild PH, and CAG showed mild distal PDA CTO. So the recent guidelines, both the European and American guidelines, you can see the guidelines, and American guidelines say that more than 65 years, up to 80 years, SAVR or TAVR can be taken, and more than 80 years, straightforward you can take for TAVR. And European guidelines say more than 75 years, with the STS and PROM score or Euroscore more than 8, or non-SAVR candidate, it's a class 1 indication for TAVR. So this patient, our patient had Euroscore of 10.6 and STS PROM score 7. Surgeons didn't want to open his chest for the third time, so he was deferred, and we took up for TAVR. He is some moderate amount of calcium was seen in the NCC, and then some calcium is there in the ascending aorta, and we had a LCC and RCC adequate. LCC and RCC, LC and RCA were more than 10 millimeter height from the annulus, and femoral access was analyzed, and it was more than 5.5 as required, and there was some calcium in the descending thoracic aorta, which was around 10 millimeter. We had the diameter. So this was the coplanar view, and LAO 8 and cranial 4, and cuspal overlap view of RAO 25 and 14. So his perimeter, his annulus dimensions were around, perimeter derived was 70.7. That was the area it was derived, and which was 26 evolute pro valve, making 16% of oversizing, which was a 26 millimeter valve, and we took a right femoral access through angiogram guidance. We took it right in the middle of the femoral head. Then we took, these are the coplanar and cuspal overlap views. You can see the mitral process is undisturbed, it is moving well. Then we started advancing with the Safari wire, and 26 mm evolute R was beginning to be deployed. We kept it around 5 mm below the aortic annulus, confirmed in different views. And once we started deploying, valve was deployed, and now you see the valve is not below the aortic annulus, it's above the aortic annulus. It is migrated above the aortic annulus. Now we are stuck, what to do? No, don't need to panic. You have to think of other plans. Once we have to retrieve it, or we have to think of other steps what to do. You have to snap the embolized valve. Anyhow, you'll be having both right and left femoral access, and you'll have a right radial access for your pectoral catheter. So if we are going through a right femoral access, so we had a left femoral access. We have to snare the embolized valve, snare the valve, and place it above the level of coronary, so that when you put another valve, it doesn't seal the coronaries off. So you have to choose a valve of higher size or maybe of same size. Same size we chose because that's already one stented valve is there, which will give us support. So, and we have to keep a pulling force so that when you are deploying the second valve, the first valve doesn't dive in and seal the coronaries. So we took a second 26 mm evolute valve. We position well below the aortic annulus. Then we didn't want to go so deep because we don't want it to interact with the mitral processes, because going too deep, that was the main reason. So we kept it slightly shallow, and it embolized the first valve. And in second picture, you can see the snare. We tried to snare the first valve. We tried to pull it slightly above the coronaries. You try to keep it in just in the junction of ascending aorta and arch of aorta, so that you don't interfere the carotids. So the valve is snared, and the second valve is being started. We started to deploy while one person is snaring it, the other person is slightly deploying it. It was deployed. The second valve was deployed, well deployed. It is it's below the aortic annulus and the stable position. It was post-dilated with the 22 mm Z-med balloon. This was the final angiogram which was taken, and mitral process was fine. There was no complications after this. And take-home message: TAVR in rheumatic heart disease is possible because most of the rheumatic aortic valves, they will have less calcium and they will have less support also. So we had done some 4 cases of TAVR in post-MVR patients, and we had some issues with them. Because they have less calcium, you need to slightly oversize usually we take around 13 to 20%, 13 to 30%, that's the size we choose. Here we chose 16% oversize, we should have gone for 20 or 26 oversizing. And oversizing in dramatic aortic valves with less calcium load helps to keep the TAVR valve position. In case it embolizes, don't panic, you always have the second valve. And the company gives it free, second valve.
So better to have some calcium.
Yes, always.
Severe calcium is not good. No calcium is also good.
Severe calcium is good.
Severe calcium is also good.
It's good, but we have to coronary protections.
Yesterday, Ashish told severe calcium created all the complications in the body.
Coronary perforations. Coronary complications.
Here also there was calcium.
There was calcium.
So I'm a little surprised you used this. I mean, why did you choose on a 26 mm valve itself the second time?
No, because
already this is embolized and the sealing happens only at the annulus. So the embolized valve is not going to give you additional sealing support above.
No, that above, just above the coronaries, you have that sealing support is there. So we thought that is going to give. Ideally, we should have taken a 29.
29. Because why did it embolize? It embolized because it was not properly sealed at the annulus.
Yeah, we didn't want to go deeper. Slightly keeping the valve slightly deeper would also prevented embolization. But here there are some mitral processes there, so we didn't want to go so deeper.
With the 26 also, he actually did it. How do you tell it this 29 is required?
As he himself said, generally they oversize by 15 to 30% in a self-expanding. And if you look at the perimeter, it is 70, which means it is borderline between 26 and 29.
Yeah.
Especially with less calcium, you should have gone for
No, actually, you choose there's a mitral process there. So you try to over choose it, then you will have underexpression of the stent, or we had cases of mitral process disturbed. We choose a valve, slightly go down, then you will have slight interaction with your mitral process. Maybe it may interfere with your mitral process. So we didn't want to.
All the more reason for you to use a balloon expandable valve.
Balloon expandable.
Thank you. Balloon actually is a balloon B, you are a CV. Thank you very much. And we will go to the next last presentation of the day. But after that, we have to present Abhilash to the crowd,
Yeah.
After this presentation, we will have a lucky draw. Last presenter is not there means we will go and finalize this thing. Last presenter is Mohammad Rafi. Now we will have the lucky draw.
And thank you everyone for the nice presentations and the nice discussion.
Don't go away. Lot of prizes are there. Should come out. Ashish, you are the president. Now you have to give the prizes. ഈ കൺസൾട്ടിനൊക്കെ വന്നത് അരുൺ ഗോപി ലാസ്റ്റ് ഈ പുള്ളി പോയിക്കളെ.
Thanks to everyone for staying up to 3 o'clock on a Sunday, last day of a conference. That is not usual. Thank you so much. Now, the award sessions for the chairperson's choice. We would say it is all presentations were good. It's not to say that other presentations were bad. We just decided to give a chairperson's choice. So, imaging session, the chairperson's choice was Dr. Rajesh Muralidharan. He just left it because he had to catch a train. I will give the prize to him. Then bifurcation standing, the prize goes to Lais Mohammed, Dr. Lais Mohammed. Lais. Next session, calcium management. The prize, the chairperson's choice is Dr. Arsha. No. And finally, the complication session, Dr. Arun Gopi. Now we are going to for the lucky drop. And I want to introduce Dr. Manasa and Dr. Anand. Both came from Medical College to Anchor today. So today's show is run by Medical College Trivandrum. Bifurcation standing, we have actually excluded those who already got the prizes. Bifurcation standing, sir. Dr. Lakshmi. Dr. Lakshmi. If Dr. Lakshmi is here, we are going to repeat that draw. Is she here? No. Sir can take another. You separate it out, please. Dr. Venkatesh. Yes. Venkatesh gets the SSD. So bifurcation standing, Dr. Venkatesh. Yeah. Yeah. ഇത് മാറ്റിയിട്ട് ഏതാണ് സാർ ഇട്ടിരിക്കുന്നത്? ഇത് ഏതാ? കാൽസ്യം. സോ ഫുഡ് കാൽസ്യം. So calcium management. Sanoop. Dr. Sanoop. Huh? Yeah. Yeah. Sir, ഇത് കൊടുക്കോ. Dr. Sanoop. Then what is the other section? Imaging. Last. Imaging. Dr. Jimmy, but he's not there. Next. No, he's not there. It was in the lot, but he's not there. So going to the next. We put everyone, but only those who are available. Dr. Vinu. Dr. Vinu gets the lucky draw. We excluded only those who got the awards already. Yeah, Dr. Vinu. No. Then he is the lucky draw winner. And one session remaining is complications. The last draw of Icck 2023. Arun is excluded because Arun just got a prize.
Dr. Hari Krishna D.
Dr. Hari Krishna D. And he is the first one to send a CD as well.
The last one to get the prize now.
Thank you so much. And over to President. President and Scientific Committee.
Actually, we should understand that the 3 days of program, Friday, Saturday, and Sunday, it was real scientific feast as well as excellent hospitality. All this is because of the two great personalities, Ashish Kumar for the scientific content, we should appreciate, and no words can tell thanks to Abhilash.
There was a scientific conference and scientific content was the main. Content was the main.
It's not like that. It is no science alone will work out. That is why only one thing was missing. The yesterday night the watery show, which was missing. So I am against for the watery show. For the next organizing secretary is willing for watery show, is also acceptable.
It was nothing like I was against alcohol. The thing is that we know all the reasons. No. Yes.
No.
The reason was everyone knows why we had to change the meeting.
Yeah.
We do not want to
Yeah,
repeat
yeah.
the whole process.
Oh, yes.
We had to cancel the meeting. We do not want to go through it again.
Yeah. See, I have only one suggestion because I don't know who are the new office bearers. See, I have.
It will come in the newspaper, madam.
No,
tomorrow.
1 minute. I have a lot of students in general hospital. I don't see a single cardiologist from general hospital. They're all doing interventions. It's the responsibility of the new office bearers to
Responsibility
recruit
of the
them.
general hospital cardiologist to come and attend the conference.
I know,
Number
but
one.
they may-
Number two, this meeting is announced
See,
in
not
Kerala.
that. No, not like that. The thing is, see, unless they're in the group, they won't see the message.
And actually, if anybody wanted to come to the meeting, they can come.
I
They
didn't
can
see
join.
Dr. Arun, Dr. Vijayalakshmi and all.
But they can all join as an ICCK member immediately.
No, but
The new
unless
secretary is
they're a
Ramesh
member,
Natarajan.
they won't see the message. That's the problem.
I think Ashish will tell the last word in favor.
ICCK is for everyone. Everyone has to be, it's a responsibility of the members to come in, not for the organizers to call them. No.
So thank you all, and so thank you all for this wonderful attendance, and a special thanks again to Abhilash for coordinating every single thing.
If everybody can come forward to have a photograph, please. Whoever is available, just have a photograph and leave. Whoever is there, please come for a photograph.